So good morning everybody. So yesterday we have discussed about pneumocystis pneumonia, the drug of choice, everything. So next important thing is, whenever a patient reaches to you with pneumonia, how will you assess the severity and decide on treatment? So patient with pneumonia entering the emergency department, so how will you assess the severity and decide on treatment? So that is the next thing that you should know. Assessment of severity of pneumonia. There is a scoring system called as curb 65. So CURB 65. So C stands for confusion. U stands for blood urea more than 7 millimole per liter. R stands for respiratory rate more than 30 per minute. B stands for blood pressure, either SBP less than 90 mmHg or diastolic blood pressure less than 60 mmHg, and 65, age more than 65. So when a patient with pneumonia reaches to you, you should see whether there are these parameters and you have to assess. And for each parameter, we give 1 point. So the scoring system, if the patient's score is 0 or 1, it is a mild pneumonia. Generally, home treatment with antibiotic. Home treatment with antibiotic. So this home treatment with antibiotic, it is also called as outpatient treatment. So whenever you are sending a patient to home and treating, it is called as outpatient treatment. See, wherever I write OP treatment, again don't ask what is OP and what is IP. OP means outpatient. IP means inpatient. You are admitting the patient in hospital and treating. Now if at all patient's score is 2, you should hospitalize and treat. Hospitalize and treat. This is adult respiratory medicine. Whatever I tell, it is only adults only. So not that adults only that you think for movies. Whatever we discuss diseases, this is only adults only topic. So pediatrics, it will be dealt later on. Okay. So 2, hospitalize and treat. If the score is 3 to 5. If the score is 3 to 5. So consider as severe pneumonia. Consider as severe pneumonia. Consider as severe pneumonia, and patient may require. Patients may require ICU admission. Patients may require ICU admission. So this is the scoring system. So whenever a patient with pneumonia reaches to you, assess these parameters, and these are the parameters which will tell you severity. So if there are less parameters, less severe. If there are more parameters, more severe. So if this is pneumonia, why am I worried about confusion, blood urea, blood pressure? What is the problem? See, any infection, the end complication is multi-organ dysfunction. So infection results in sepsis and multi-organ dysfunction. So whenever your brain is involved in sepsis, there will be confusion. If kidneys are involved, there will be renal dysfunction and gradually urea increases. If there is septic shock, blood pressure will decrease. So you may get it out, sir, we are discussing about pneumonia. Pneumonia means more with relation to respiratory system. So why I am looking at patient's confusion, patient's blood urea and blood pressure? Because any pneumonia in severe form results in sepsis, and in sepsis multi-organ dysfunction. So if your brain is involved, there will be confusion. If your kidney is involved, blood urea increases. If there is septic shock, blood pressure will decrease. So if there are more parameters present in the patient, it means there is more severe pneumonia. Now you have assessed the severity of pneumonia. Now what is the antibiotic that you should give? So ultimately treatment of pneumonia will be antibiotics because it is an infection. So what you should give if you are treating him outpatient, what you should give if you are treating him inpatient. So this 2 to 5, this is IP treatment. So IP means inpatient. You are admitting the patient in hospital and treating. So if the score is 0-1, you can treat him at home. This is called as outpatient treatment. Outpatient treatment. So let us see how do you treat the pneumonia accordingly. Empirical regimens for community acquired pneumonia. So whenever a patient with pneumonia reaches my hospital, I will assess the severity and decide where to treat him. Is it at home? It is called as outpatient treatment. Is it at hospital? That is inpatient treatment. Whether I want to admit him or whether I want to send him home. So outpatient treatment, generally we give him tablets. So medication in the form of tablets. So when I am sending in home, we give tablets. Whereas in hospital, we prefer injectables. Because it is a more severe disease, better is injectables more than oral forms. Injectables more than oral forms. Now let us see how to treat accordingly. So in outpatient treatment, I assess the patient again and I see whether there are any comorbidities. So no comorbidities. With comorbidities. So comorbidities in the sense patient might be having diabetes, hypertension, previous heart disease, kidney disease or old lung disease. So if at all there are comorbidities, the treatment is different. If there are no comorbidities, the treatment is different. So if there are no comorbidities, a single antibiotic will be sufficient. So either beta-lactam or macrolide or tetracycline. So any one of the antibiotic can be given. Either you can give a simple beta-lactam, macrolide or tetracycline. But if the patient is having comorbidities, you should treat him better. So the first preferred regimen is combination of beta-lactam plus macrolide or monotherapy with fluoroquinolone. So monotherapy with fluoroquinolone. So if there are comorbidities, you should give better treatment, either combination of beta-lactam plus macrolide or you can give monotherapy with fluoroquinolone. So I'm writing in order of preference for the regimens in our country. Now, if it is IP treatment, inpatient, where exactly I am trying to admit the patient? Is it in the ward, that is non-ICU, or is it in the ICU? So what should be given in ICU? What should be given for pneumonia in the ward? So if the patient is admitted in ward, non-ICU, so the treatment will be first preference beta-lactam plus macrolide or monotherapy with fluoroquinolone. Monotherapy with fluoroquinolone. Now, if the patient is admitted in the ICU, so first preferred regimen is beta-lactam with macrolide or combination of beta-lactam with fluoroquinolone. So these are the empirical regimens for community acquired pneumonia. So whenever a patient with community acquired pneumonia reaches your hospital, first assess the severity by curve 65 and see whether he is fit for home treatment or he should be admitted. So where to admit, in the ICU or in the ward? Now, if at all you have admitted the patient in the ICU, there are some special considerations. So patient is in ICU, there are some special considerations that you should see. If at all Pseudomonas is suspected, so if you suspect this patient is having Pseudomonas pneumonia, so if Pseudomonas is suspected, so whenever Pseudomonas is suspected, you should change the regimen to anti-pseudomonal beta-lactam, anti-pseudomonal beta-lactam plus fluoroquinolone, anti-pseudomonal beta-lactam plus fluoroquinolone. So if at all you suspect this patient to have Pseudomonas related pneumonia, anti-pseudomonal beta-lactam plus fluoroquinolone. Now, in the next scenario, you were doing your rounds in the ICU and you found out this fellow was a IV drug user. So whenever you find out that this fellow is an IV drug user and he is admitted with pneumonia in the ICU, what is the organism that you should suspect? Community acquired methicillin resistant staph aureus. So if at all community acquired MRSA, community acquired MRSA suspected, if at all community acquired MRSA suspected. So why I am calling it as MRSA? Because by the time nowadays a patient with pneumonia of staph reaches me, it will be already methicillin resistant staph aureus. So if you suspect this, what will be the regimen? So the first regimen will be beta-lactam plus macrolide plus vancomycin. Beta-lactam plus macrolide plus vancomycin. Or there is a new regimen which is the most preferable regimen nowadays. Beta-lactam plus fluoroquinolone plus linezolid plus or minus, you can add or no need to add clindamycin. In few countries they give clindamycin also. Now you can get a doubt. You are suspecting it as staph aureus, but still you have included beta-lactam, macrolide, beta-lactam, fluoroquinolone, along with that anti-staph drugs such as vancomycin and linezolid. So what is the reason behind this? See, whenever a patient is in ICU, that too because of very severe pneumonia, see, one cause might be staph aureus. It doesn't mean other organisms are not happening in this patient. Other organisms are not there in the patient. See, everything is empirical regimen, because if you want to have a definitive diagnosis for any pneumonia, you should get the culture report. So culture report will take more than 2 days. By the time patient may not survive. So whenever a patient is in ICU with severe pneumonia, according to patient's clinical scenario, you try to give broad spectrum of antibiotics covering all the common organisms. So here beta-lactam macrolide, beta-lactam fluoroquinolone will cover the common organisms such as Streptococcus, Legionella, Mycoplasma, whereas vancomycin and linezolid will cover the specific organism called as MRSA. So this is the empirical regimen for community acquired pneumonia as given in 20th edition Harrison. So 20th edition Harrison Principles of Internal Medicine. So this is the most important table. Now if you see in this table, there is a peculiarity. Even though fluoroquinolone is a very important drug and effective drug, so we are not using it as first line regimens for community acquired pneumonia in India especially. What is the reason? So why don't we use fluoroquinolones as first line drugs for community acquired pneumonia in India? What is the problem? So why don't we use fluoroquinolones as first line regimens in India? Yes, in India there is high burden of tuberculosis. So if you give fluoroquinolones for simple pneumonias, later when they develop tuberculosis, that population, they will be drug resistant. So write down fluoroquinolones, very, very important statement. Fluoroquinolones. So in India, fluoroquinolones. So empirical use of fluoroquinolones. Empirical use of fluoroquinolones. Not done due to high burden of tuberculosis. So elsewhere in the Western countries, whenever there is a community acquired pneumonia, according to that algorithm, they will start fluoroquinolones. But in India, fluoroquinolones are avoided. Empirical use of fluoroquinolones not done. Empirical use of fluoroquinolone not done due to high burden of tuberculosis. Empirical use of fluoroquinolone not done due to high burden of tuberculosis. So this is the important algorithm that you should know. So when a patient with community acquired pneumonia reaches you, so you should decide whether to give him treatment at home or in hospital, OP treatment, IP treatment. So is the patient having comorbidities? No comorbidities. ICU or non-ICU? Accordingly, you should design the regimens. So in the ICU, this is the regimen. If community acquired MRSA suspected, first regimen, second regimen. So this regimen is now considered as most preferred regimen for MRSA in ICU. So this is most preferred regimen for community acquired MRSA in ICU. So whenever a patient with community acquired MRSA is in the ICU, now the most preferred regimen is beta-lactam with fluoroquinolone, linezolid plus or minus clindamycin. So clindamycin is added in few countries, so it has some additional action on staph. Now we have discussed various pneumonias. Now I'll show you some images and questions. Try to answer them correctly. So first question. So this was a patient with a fever, red rusty sputum. So there is fever and red rusty sputum. This was the chest X-ray. So what might be the organism? What might be the organism? So fever, red rusty sputum. So fever and red rusty sputum, what might be the organism? So in the chest X-ray you can see localized involvement of lobe of lung, lobar consolidation. So there is lobar consolidation. So this is lobar consolidation. So what should be the answer? This is streptococcal pneumonia. So all the questions in recent NEET will be like this only. They will give you a clinical scenario. They will show you X-ray and they'll ask you the organism. Next question. So this patient was having fever and dry cough. So this patient was having fever and dry cough. This was the chest X-ray. This was the chest X-ray. So what might be the diagnosis? So when you see the chest X-ray, I am not seeing any dense consolidations here. I am only seeing some bilateral haziness. So I am seeing some bilateral haziness. So bilateral haziness. I am seeing bilateral haziness. Bilateral haziness. So this bilateral haziness, it is nothing but interstitial pattern. So interstitial pattern. So if it is interstitial pattern, it is atypical pneumonia. Atypical pneumonia. And can you tell me what is the most common atypical pneumonia? It is mycoplasma. Most common atypical pneumonia, it is mycoplasma. So see, try to identify the difference. So consolidation, typical pneumonia, lobar consolidation. So there is also red rusty sputum, streptococcus. So this is just dry cough fever, interstitial pattern. It is atypical pneumonia. Now another patient with the fever plus red currant jelly sputum. Red currant jelly sputum. So what is this organism? It is Klebsiella. You can see normally horizontal fissure should be straight like this. It has bulged down in this manner. It has bulged down in this manner. Bulged down in this. Somebody is asking why it is not TB. See, TB generally will have fever, there will be productive cough. Typical of TB is not interstitial pattern. Typical of TB is cavitations. Okay. So you can see in the lateral view also the horizontal fissure which has to be straight like this, it is bulged down. So this is a classical bulging fissure sign and the organism is Klebsiella. See, somebody was asking me this lobar consolidation, why it is not Klebsiella? See, this is not having bulging fissure sign and moreover red rusty sputum. See the difference. This is lobar consolidation due to streptococcal pneumonia. So this is bulging fissure. You can see the fissure is bulging. You should not forget this basic bulging fissure sign in Klebsiella pneumonia, and most important in history is red currant jelly sputum. Red currant. Why not pneumocystis in second? Neha, pneumocystis is pneumonia in immunocompromised. Without HIV history, you cannot call it as pneumocystis without immunocompromised history. So I did not tell that the patient was immunocompromised. Okay. So Fred Landler is the name of the person who has found out the Klebsiella. So why not collapse? Collapse means you should have mediastinal shift. So mediastinal shift, and there is a classical bulging fissure sign. Now next coming to cavity of lung. So how to identify a cavity? Cavity means air-filled space. Air-filled space with well-defined air. So air-filled space with well-defined air. Sorry, with well-defined wall. Air-filled space with well-defined wall. So wall will be usually more than 1 mm thick. So wall will be more than 1 mm thick. So air-filled space with well-defined wall more than 1 mm thick. So first I'll show you how to identify in a CT scan. So in a CT scan, to identify a cavity, first you should identify air-filled area. So can you notice this air-filled area? Yes. And around this air-filled area, can you notice a whitish layer? So this whitish layer is nothing but wall of the cavity. So this whitish layer is nothing but wall of the cavity. So in the same way, on the chest X-ray also, this is the air-filled area. So this is the air-filled area. So around that you are able to identify a well-defined wall. You are able to identify a well-defined wall. So this is a cavity, air-filled area with well-defined wall. Air-filled area with a well-defined wall. Okay. Now I will show you another air-filled area. Now tell me, how is this different from cavity? So here also you are seeing an air-filled area. Here also you are seeing an air-filled area. So how is this air-filled area different from previous one? There is no proper wall. There is no proper wall. So write down air-filled area. Ill-defined walls. Air-filled area with ill-defined walls. Air-filled area. Air-filled area with ill-defined walls. With ill-defined wall. So what is this structure called as? Pneumatocoel. 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 So you can see here also air-filled area, there is air and the wall is not well defined. So this phenomena is called as pneumatocoel. Now keep this pneumatocoel in your mind and I will show you again cavity. Now try to identify in cavity air-filled area and its wall. Now in the cavity, can you clearly see air-filled area and the surrounding wall. So cavity, you should be able to see air-filled area and surrounding wall. Air-filled area and surrounding wall. Whereas pneumatocyl, see, there is only air-filled area. There is no proper wall. No proper wall. So these are the differences between a cavity and pneumatocyl radiologically. What is the most common organism causing pneumatocyls in the lung? So what is the most common organism causing pneumatocyl in the lung? Your answer should be yes, it should be staph. So staph most commonly causes pneumatocyls. So you should keep this in mind. So well-defined wall is cavity. Ill-defined wall is pneumatocyl. Sometimes a cavity will be filled with both air and fluid. So this phenomena is called as lung abscess. So write down the definition of lung abscess. It is localized parenchymal necrosis. So lung abscess means localized parenchymal necrosis. In the chest X-ray, you see a cavity with air fluid level. So this is the cavity with well-defined wall. You can see cavity. Okay. And this is air. And this is fluid. So air and fluid. So this chest X-ray finding is a cavity with air-filled fluid. Cavity with air fluid level. Cavity with air fluid level. So this is a lung abscess. This is a lung abscess. Now coming to classification of lung abscess, primary form. So primary form is the most common form. So most common form happening in 80% of cases. So if there are 100 lung abscess cases, majority will be primary form. So this primary form is due to aspiration. So because the patient is aspirating, primary form lung abscess happens. So if it is due to aspiration, most common organisms responsible. So most common organisms responsible will be oral anaerobes. Oral anaerobes. See again the same question. Why in Carbo 65 blood urea is taken? I told you thrice. See, when there is an infection, there will be sepsis, multi-organ dysfunction. When kidney is damaged, there will be increased blood urea. So because kidney function is vital, we take blood urea as a parameter for severity of pneumonia. So oral anaerobes. So when most common organisms will be oral anaerobes. Then secondary form. So this is due to some pre-existing lung disease. This is due to some pre-existing lung disease which complicates as lung abscess. So patient might be having some pre-existing pneumonia, patient might be having some pre-existing bronchiectasis which can complicate as lung abscess. Then next important thing is, what are the organisms? So organisms here can be Pseudomonas, Staph aureus, Klebsiella. So very important in lung abscess. If they ask you what is the most common form, answer is primary form. What is the most common risk factor? Aspiration. So because patient is aspirating, that is resulting in lung abscess. So when somebody aspirates, so oral cavity contents are going into lung. So what does oral cavity contain? Oral anaerobes. So oral anaerobes. So treatment for secondary form, it is according to the organism. So secondary form, it is according to organism. So we have already discussed what to give Pseudomonas, what to give for Staph, what to give for Klebsiella. So if you find it is due to some Pseudomonas, you give that anti-pseudomonal regimen. For Staph, we have discussed the regimen. For Klebsiella, we have discussed the regimen. Now, most common cause of Lung abscess, never forget. It is oral anaerobes. It is oral anaerobes. So what will be the drug of choice for oral anaerobes? So what will be the drug of choice for oral anaerobes? So what should be your answer? If this is oral anaerobe, this is the drug of choice. So who is the drug of choice? It is clindamycin. Very, very important question. They will give you a clinical scenario. So they will say this patient has developed lung abscess. So what will you give next? It is clindamycin. So drug of choice for oral anaerobes, it is clindamycin. Oral anaerobes, drug of choice is clindamycin. Yes. Now try to solve this question. A 20-year-old male, history of fever, cough, mucopurulent expectoration. Chest X-ray is showing patchy infiltration. Multiple cavities, sputum smear will show. So I think so many Lucifer fans, even I am also a big fan of Lucifer movie. So 20-year-old male, history of fever, cough, mucopurulent expectoration, chest X-ray showing patchy infiltration, multiple cavities, sputum smear will show. What is the answer? So patient is having fever, mucopurulent expectoration, it is patchy infiltration, cavities, all these are suggestive of bronchopneumonia pattern due to staph. So answer C. So answer C. So this was also a previous AIMS question, direct question from your notes. A 32-year-old HIV infected male. So somebody was asking, why not pneumocystis? Why not pneumocystis? Whenever there is a HIV infected male, one possibility is pneumocystis. Shortness of breath, fever, 2-week duration, examination, cyanosis is present, respiratory rate is high, and basal crackles are seen in the chest. Chest X-ray is given. So in the chest X-ray, you are unable to identify consolidation. There is no consolidation. There is no cavity. What do you notice here? So mild haziness. So what is this haziness? Bilateral interstitial infiltrates. So it is more of interstitial pattern. And bronchoalveolar lavage reveals immunofluorescence staining is positive. So this is the new technique, immunofluorescence staining. So most likely etiological diagnosis. So immunocompromise, interstitial pattern, immunofluorescence staining, you could see something. So you can see those cysts. So what is the answer here? It is pneumocystis. So pneumocystis. So for 13th case, answer is B. 13th case, answer is B. So this is also a direct question. So don't overthink why it is not mycoplasma, why it is not Legionella. Everything is straightforward. Interstitial pattern, immunocompromised. You have taken bronchoalveolar lavage, immunofluorescence staining you are doing. You are working out for pneumocystis here. Then CURB 65 includes all except. CURB 65 includes all except. So respiratory rate more than 30. Age more than 65, urea will be high, but SBP less than 100. So you're asking to repeat 12. See, even when repeat 12, okay. So what is there here? Fever, mucopurulent expectoration, patchy infiltrate. See, once you take the table where we have discussed staph and search for the clinical features. See, questions will not be just like spoon feeding. So questions will be, there will be 10 features. So you should select the most important feature and you should try to analyze. So fever, mucopurulent sputum, patchy infiltration, cavities. All these are suggestive of staph areas. So CURB 65, SBP less than 100. It's not the answer. This is not the answer. So SBP should be less than 90. SBP should be less than 90. SBP should be less than 90. See, Chitresh Agarwal, yesterday I told you bronchoalveolar lavage means you are going to send the fluid into the alveoli. So you take the scope, you inject saline. So that will go and hit the alveolar walls. So interstitium will be in touch with alveolar walls. So it will bring the organism from the alveolar walls. Okay. So Akshay S. Hegde, why cyanosis in question 13? See, when there is hypoxemia, there will be cyanosis. So severe hypoxemia, there will be cyanosis. So that is a basic thing that you should know in your first year physiology. So how is 12th different from today's second question? So there was dry cough there. Aditya Satish, there was dry cough. Here it is mucopurulent expectoration. So I don't think you are not reading the questions completely. See, when you want to be a good doctor, when you want to excel in any entrance exam, each and every point you should try to think with common sense. You should try to assess, then only you'll get the answer. So compare. So there it was dry cough. Here it was mucopurulent sputum. Yes, all the x-rays will be uploaded. Don't worry. Now, next question. Case number 14. A 26-year-old alcoholic, okay, with fever, cough, productive, copious sputum, with foul smelling over 10 days. So over 10 days. So in past year, he has been admitted twice to the local emergency department for being found unconscious due to alcohol intoxication. So this fellow is having features of alcohol intoxication. Each and every time he drinks a lot of alcohol and become unconscious. So chest X-ray is shown. What is the next step in management? This is also a classical question, new pattern question. So when you go step by step, you should be able to answer such questions. Even after learning the concept, if you are unable to answer this question, you should change your way of thinking. Okay. See, here he is a young male. He is an alcoholic and he is having bad habit of getting intoxicated and becoming unconscious. So he presented with sputum and very, very foul smell. So whenever there is a foul smelling sputum or foul smelling secretions anywhere, suspect an abscess. So clinical history, alcoholic means chances of aspiration. That too, he is frequently getting intoxicated. So don't ask me, sir, why will alcoholic intoxication cause aspiration? You drink alcohol and try once, you will know what is meant by aspiration. So with foul smelling odor, so clinically everything is suggestive of aspiration. So radiologically what you can see? You can see a cavity. There is air and there is fluid. So chest X-ray is suggestive of lung abscess. History is suggestive of aspiration. So history is suggestive of aspiration because alcoholics, intoxication, they can aspirate. So all this is suggestive of a primary lung abscess. Now, what will be the next step in management? So what causes primary lung abscess? Oral anaerobes. So primary lung abscess, oral anaerobes. So what will be the drug of choice? IV clindamycin. So IV clindamycin. So drug of choice here is IV clindamycin. Okay. So don't forget this. When they give you a clinical scenario, alcoholic or anybody who has tendency to aspirate, they have developed some pneumonia. So see whether there is lung abscess, yes or no. So you have to treat this with clindamycin. So drug of choice for swine flu prophylaxis. So direct answer, oseltamivir. So actually after COVID, we all have forgotten regarding swine flu. Let us have a brief review. So let us have a brief review. So this swine flu is caused by H1N1 influenza virus. And next important thing, this has significant man-to-man transmission. man-to-man transmission. So drug of choice for treatment is oseltamivir. And in exposed individuals also we can give prophylaxis. So drug of choice for prophylaxis is also oseltamivir. So in swine flu, important thing is it is caused by H1N1 influenza virus. For treatment and prophylaxis, it is oseltamivir. Apart from this, there are other drugs which are useful. There are other drugs. So what are those drugs? We can give zanamivir, permavir, and recent baloxavir. So if they ask you what are the other drugs helpful in swine flu management, these are the drugs. Other drugs helpful in the management, these are the drugs. So zanamivir, permavir, baloxavir. Zanamivir, permavir, baloxavir. Zanamivir, permavir, baloxavir. Okay. So this is regarding swine flu review. So regarding COVID pneumonia, already I have made 2 modules. One in AIMS capsule, I have discussed about COVID for 2 hours. Again in DVT, I am discussing COVID for half an hour. So you can follow COVID in that, because discussing regarding COVID, it will take a lot of time. I have discussed in detail in those modules. You once see that module, if you are not able to understand anything, you can ask me doubt at any point of time. Now what is this disease? Abnormal accumulation of fluid within the pleural space. So that is not pleural effusion in alcoholic, that is a lung abscess. See, what I say is, whenever they give you a question, see the most striking feature. So don't worry about those distractions. I told you in the beginning also, they will give so many distractions. Don't go for that distraction. So see the striking feature, most probably that will be the answer. So what is this disease? Abnormal accumulation of fluid. It is pleural effusion. Now coming to approach to pleural effusion. So we'll discuss approach to pleural effusion. So already we have discussed the clinical findings and radiological findings in pleural effusion. So clinical findings, it is a pushing lesion generally, and if you percuss, there can be a stony dull node. Whereas radiological finding, it is a whitish density with meniscoid fluid level, meniscoid fluid level. So write down approach to pleural effusion. We have transudate. Other is exudate. And for this, the differentiation is by Leit's criteria. So the differentiation is by Leit's criteria. So write down regarding the Leit's criteria. So to call it as transudate, pleural effusion protein by serum protein. Pleural effusion protein by serum protein will be less than 0.5. Pleural effusion LDH by serum LDH will be less than 0.6. So whenever there is some active inflammation, so the proteins and LDH in that area will increase. So transudate is not due to active inflammation, it is due to some problem in filtration. So the protein ratio and LDH ratio will be less. Protein ratio and LDH ratio will be less. Whereas exudate, either protein ratio more than 0.5 or LDH ratio more than 0.6. So if the protein LDH ratios are less, it is transudate. If the protein and LDH ratios are higher, it is exudate. So presence of proteins and LDH within that fluid indicates it is due to some active inflammatory response. So it is classified as transudate. If there is less, it is not due to any inflammation. It can be due to some filtration problem. Now if it is transudate, life is very easy because majority are systemic causes. So let us see what are the systems involved. First important system is your heart. Cardiac failure. Cardiac failure. So right now cardiac failure is considered as most common cause of pleural effusion worldwide. Next important system is the kidney. So in kidney disease it can be due to nephrotic syndrome. And third important system responsible for transudative pleural effusion is liver. So if at all a liver disease is responsible for pleural effusion, it is called as hepatic hydrothorax. So hepatic hydrothorax means liver disease causing pleural effusion. Liver disease causing pleural effusion. If at all a liver disease causes pleural effusion, it is called as hepatic hydrothorax. It is called as hepatic hydrothorax. Now tell me what are the mechanisms. So why there is pleural effusion? Why there is pleural effusion? See, both should be satisfied for transudate. Protein should be less, LDH should be less. So cardiac failure, why there is pleural effusion in cardiac failure? So in cardiac failure, there will be increased hydrostatic pressure. So there will be increased hydrostatic pressure. See, I think you must be knowing, for fluid to get accumulated anywhere, either there should be increased hydrostatic pressure or decreased oncotic pressure. So this is some basic in your pathology that you discuss in the pathophysiology of edema or accumulation of fluid, increased hydrostatic pressure or decreased oncotic pressure. So in cardiac failure, the reason for accumulation of fluid is increased hydrostatic pressure. So somebody is asking why nephrotic syndrome. Now think with common sense. Why in nephrotic syndrome there will be pleural effusion? What is nephrotic syndrome? So massive proteinuria, there will be proteins lost from the urine. So that will result in decreased oncotic pressure. That will result in decreased oncotic pressure. So in nephrotic syndrome, the reason for pleural effusion is decreased oncotic pressure. Now in hepatic hydrothorax, how will a liver disease cause pleural effusion? So try to understand here. So majority of liver diseases ultimately will result in ascites. So there will be ascites. So ascites is formed in the abdomen. So in the abdomen also there is your diaphragm. So generally diaphragm will be having very tiny holes. So diaphragm will be having very tiny holes. So these tiny holes will not be open in normal conditions. So now because of increased pressure within the abdominal cavity because of ascites. So whenever ascites become very gross, these diaphragmatic holes can open. So whenever these diaphragmatic holes open due to positive increased pressure in the abdomen, so there will be transfer of fluid from the abdominal cavity into the pleural cavity. So write down the mechanism of pleural effusion in hepatic hydrothorax. So it is movement of fluid through diaphragmatic pores. Movement of fluid through diaphragmatic pores into pleural cavity. And next important cause of a transudative pleural effusion is peritoneal dialysis. So peritoneal dialysis. So why in peritoneal dialysis there will be pleural effusion? So I think you know dialysis is of two types. If you use blood as a medium, it is called hemodialysis. If you put a catheter in the peritoneal cavity and you use peritoneal membrane as a filter, it is peritoneal dialysis. So whenever I put a peritoneal catheter, I am going to inject about 3 to 4 liters of some concentrated fluid. So whenever excess amount of fluid is injected into abdomen, in few patients what happens is, again in the abdomen the pressure can increase. So whenever the pressure is increasing, again the diaphragmatic holes will open. So when the diaphragmatic holes are opening, from the abdominal cavity, fluid can seep into the pleural cavity. So just this is a concentrated fluid, it will not be having any proteins or LDH. So what is going to happen? It will be a transudative pleural effusion. So again, in peritoneal dialysis also, the mechanism will be the similar. So movement of dialysis fluid through the diaphragmatic pores into peritoneal cavity. The mechanism will be the same. The next important thing is hypothyroidism. So in hypothyroidism also, there will be pleural effusion and it will be transudate. So exact mechanism is not known. So exact mechanism is not known. Exact mechanism is not. So to call it as transudative effusion, both these criteria should be present. But to call it as exudative, any one criteria is sufficient. Either protein ratio more or LDH ratio more. Now if it is exudate, life becomes difficult because there are so many causes of exudative pleural effusion. There is so many causes of exudative pleural effusion. So we have to rule out one by one. So first thing, I should send the fluid to cytology. So why I should send it to cytology? To look for any malignancy. And I should send the fluid to cell count. So I should send the fluid for cell count to look what is the type of cell elevated. Is it neutrophil? Is it lymphocyte? In that manner. And I should send the fluid for gram staining. So why I should send the fluid for gram staining? To see whether there is any infection. The next important thing, I should send it for TB markers. So why I should send it for TB markers? Because most common cause of exudative pleural effusion worldwide. Most common cause of exudative pleural effusion worldwide. Most common cause of exudative pleural effusion worldwide is TB. So most common cause of exudative pleural effusion worldwide is tuberculosis. So what are the TB markers? So generally tubercular pleural effusion will be lymphocyte predominant. So lymphocyte predominant. Lymphocyte predominant. So there will be increased ADA. So ADA will be more than 40 international units. And next important thing is interferon gamma. So interferon gamma will be more than 140 picograms per ml. So whenever you are suspecting a exudative pleural effusion, you should make sure you are evaluating for tuberculosis. So what are the TB markers? So it will be a lymphocyte predominant effusion. So it is TB is a lymphocyte predominant effusion. There will be increased ADA. So what is meant by ADA? ADA means adenosine deaminase. So what is its importance? So whenever my body is actively fighting against TB, there will be some substances released in my body. So one such substance is ADA, and other is interferon gamma. So if that fluid contains high ADA and high interferon gamma, it means my body is actively fighting with TB. My body is actively fighting with TB. So chances of tubercular effusion is high. Next important thing is, you should know what are the causes of low glucose pleural effusions. So low glucose pleural effusions means pleural effusion glucose less than 60 mg%. Low glucose pleural effusion means pleural effusion glucose less than 60 mg%. So they'll ask you what are the diseases. So it is seen in empyema, malignancy, empyema, malignancy, and next important thing is rheumatoid arthritis associated pleural effusion, rheumatoid arthritis associated pleural effusion. And next important marker is high amylase pleural effusion. So high amylase pleural effusion. So high amylase pleural effusion can be due to pancreatitis, esophageal rupture, and third important is malignancy. So very important table for approach of pleural effusion. So if you know this table, you can solve majority of questions in pleural effusion. Now let us see what is this low glucose pleural effusion. So we find it in empyema. So what is meant by empyema? Empyema means pus in pleural cavity. So what does pus contain? Pus contain actively dividing bacteria. So what do bacteria consume as food? Glucose. So the actively dividing bacteria consume the glucose in the pleural fluid. So pleural effusion glucose will be less. Then why in malignancy there is low glucose pleural effusion? So malignant cells will be having active metabolism. They will be actively dividing. So malignant cells will always be actively dividing, and they also will consume glucose. So that's why pleural effusion glucose in malignancy will also be less. Then why in rheumatoid arthritis? So this rheumatoid arthritis, as a part of systemic involvement, so just like arthritis, it can also cause pleuritis. So whenever there is pleuritis, the inflammation is in the pleural area. So these inflamed pleural cells will have very high metabolism. So these inflamed pleural cells will have very high metabolism, and the fuel for their metabolism is glucose. So in rheumatoid arthritis, what is happening? The pleural cells will have high metabolism, and fuel for that metabolism is glucose. So those cells will have high metabolism, so they consume glucose, so ultimately resulting in low pleural fluid glucose. Next important thing, high amylase pleural effusion. So why there is high amylase in pancreatitis, esophageal rupture and malignancy? So first let us see in pancreatitis. So whenever there is pancreatic inflammation, so you know that pancreas is an infradiaphragmatic structure. So whenever the pancreas are inflamed, it can cause some diaphragmatic irritation. So when there is diaphragmatic irritation, these diaphragmatic pores can open. And what does pancreatic inflammatory fluid contain in excess? Amylase. So this pancreatic inflammatory fluid through the diaphragmatic pores can go into the pleural cavity. So pancreas is an infradiaphragmatic structure. Whenever pancreas is inflamed, it can irritate the diaphragm. So irritation of diaphragm will make these diaphragmatic pores to open. And what does pancreatic fluid contains? Amylase. So that will be transferred into the pleural cavity. Now coming to esophageal rupture. So you must be knowing your esophagus is a mediastinal structure. So there will be esophagus here, and adjacent to that there is mediastinal pleura. Adjacent to that there is mediastinal pleura. So whenever esophagus is damaged, with that force, so whenever esophagus is damaged, so with that force, even the mediastinal pleura is damaged. Even the mediastinal pleura is damaged. So whenever mediastinal pleura is damaged, esophageal contents will be going into the pleural cavity. So what does esophageal content have? Saliva. And what does saliva have? Amylase. So again in esophageal rupture also there will be high amylase. Then why in malignancy? So why in malignancy? So malignancy, there will be actively dividing tumor cells, and few tumor cells can directly secrete amylase. So you can write in malignancy tumor cells directly secrete amylase. In malignancy tumor cells directly secrete amylase. So in exam they will not ask you what is the mechanism of pleural effusion. They will ask you what is the finding in pleural effusion. In pancreatitis, esophageal rupture, malignancy, there can be high amylase. Empyema, malignancy, rheumatoid arthritis, low glucose. In TB pleural effusion, it will be lymphocyte predominant, high ADA, interferon gamma. See why there is high glucose pleural effusion. I am telling about low glucose pleural effusion, Paras. So low glucose pleural effusion in empyema. Empyema means pus. So pus contains bacteria. Bacteria will eat up all the glucose. Bacteria will eat up all the glucose. Bacteria feeds on glucose. So that is as simple as possible. Okay. So whenever they give you any pleural fluid analysis, so this is how you should approach. By seeing the Lights criteria, you should differentiate it into transudate and exudate. So if it is transudate, look for systemic cause. So is there any cardiac disease? Is there any kidney disease? Is there any liver disease? Has there been any peritoneal dialysis? Is there any thyroid disease? Then if it is exudate, then you should evaluate further. By doing cytology, you need to rule out malignancy, gram staining to rule out infection, TB markers to rule out tuberculosis, by doing glucose to rule out low glucose pleural effusion, by doing amylase, you have to rule out high amylase pleural effusion, So low glucose pleural effusion, esophageal rupture. So I think that I have repeated it more than twice. Pancreatitis. See, pancreas is an infradiaphragmatic structure. Okay, so I'll make it very simple for you to understand. So this is diaphragm, this is pancreas. So whenever pancreas is inflamed, it will irritate the diaphragm. So when the diaphragm is irritated, the diaphragmatic pores will open. So pancreatic fluid rich in amylase will cross the diaphragm and go into pleural cavity. Esophageal contents contain saliva. Don't ask me why saliva is present in esophagus. So from the oral cavity, saliva goes into esophagus. Okay. Now these are some important approach to transudate and exudate. So I have discussed the common causes of exudative pleural effusion. Apart from that, there are less common causes but important for your exam. So write down other important exudative pleural effusions. So first is high lipid pleural effusion. So in high lipid pleural effusion, we have two types. So chylothorax, so pseudochylothorax. So what I feel is, if we start discussing very easily understood concepts, if we start simplify, see, we cannot simplify simple things. So if it is a complex thing, I can simplify. So it is very difficult to simplify simplest concepts. So all these empyema, malignancy, those are simple concepts. So you read it again, you will understand it, don't worry. So chylothorax, pseudochylothorax. So write down the definitions. So chylothorax, it is accumulation of chyle in pleural cavity due to disruption of thoracic duct. Disruption of thoracic duct. So most common cause will be surgical trauma. Next important cause is malignancy. So diagnostic feature, pleural effusion triglycerides. Triglycerides will be more than 110 mg%. Now coming to pseudocylothorax. It is accumulation of cholesterol crystals. Accumulation of cholesterol crystals in long-standing effusions. Accumulation of cholesterol crystals in long-standing effusion. So important causes will be chronic effusions, tuberculosis, rheumatoid arthritis, because these are chronic diseases. So TB is a chronic disease, rheumatoid arthritis is also a chronic disease. And here pleural effusion cholesterol will be more than 200 mg%. So the next concept we are going to discuss is, so uncommon exudative effusions but important for your exam. So it is high lipid pleural effusion, and these are white colored pleural effusions. So because of the lipid content they appear white. So chylothorax, pseudocylothorax. Chylothorax, pseudocylothorax. So what is chylothorax? So chylothorax means accumulation of chyle in the thoracic cavity. So why it happens? You must be knowing in your body there is a structure called as thoracic duct. So this thoracic duct is carrying chyle, and thoracic duct is also a mediastinal structure. So thoracic duct will be somewhere here. It is a mediastinal structure. Adjacent to thoracic duct there will be mediastinal pleura. So whenever the thoracic duct is damaged during some chest surgery or neck surgery, along with thoracic duct, chances of damage of mediastinal pleura is there. See, mediastinal pleura is a very, very fragile and sensitive area. So whenever the thoracic duct is cut, along with that mediastinal pleura can also be damaged. So from the damage, what will happen? Contents of thoracic duct will be going into the pleural space. So what does thoracic duct contain? Chyle. So what does thoracic duct contain? Chyle. So most common cause is surgical trauma. Most common cause surgical trauma. Next important cause is malignancy. So few malignancies, especially lymphomas, can directly infiltrate the thoracic duct, destroy the thoracic duct along with mediastinal pleura, and that results in leakage of chyle into the pleural cavity. And what does chyle contain? Triglycerides. Now, because triglycerides are reaching the pleural space, now pleural effusion triglycerides will be more than 110 mg%. Pleural effusion triglycerides will be more than 110 mg%. Now coming to pseudocylothorax. This is due to accumulation of cholesterol crystals in long-standing effusion. So whenever there is a chronic effusion for months and years together, what will happen is the cells in that effusion can degenerate. See, any cell after few days it will degenerate. If at all effusion is there, all the inflammatory cells which were accumulated previously, they will degenerate. So when the cells are getting degenerated, from the cells cholesterol can gradually accumulate. From the cell cholesterol can gradually accumulate. So because cholesterol is accumulating, pleural effusion cholesterol will be high. Pleural effusion cholesterol will be high. So this was noticed in some chronic effusions such as tuberculosis. So tuberculosis is a chronic disease, rheumatoid arthritis is a chronic disease. Now if they ask you, what is the lipid? What is the lipid elevated in chylothorax? Your answer should be triglyceride. What is the lipid elevated in pseudocylothorax? It is cholesterol. So both are white colored effusion. If the pleural effusion contain more of triglycerides, it is chylothorax. If the pleural effusion contain more of cholesterol, it is pseudochylothorax. So chylothorax, white colored effusion with high triglycerides. Pseudochylothorax, white colored effusion with high cholesterol. Next important is paranymonic effusion. Paranymonic effusion. So this is effusion associated with either pneumonia or lung abscess or bronchiectasis. So if at all patient is having infective manifestations such as pneumonia, lung abscess or bronchiectasis, pneumonia, lung abscess or bronchiectasis, if an effusion is associated, this is called as paranymonic effusion. Paranymonic effusion. So what will be the clinical features? Patient can have fever. Patient can have shortness of breath. Because of active involvement of the pleural membrane, patient can also have chest pain. So there will be fever, shortness of breath and chest pain. Now they will ask you, what are the indications for active intervention in paranymonic effusion? Active intervention in paranymonic effusion. Active intervention in the sense intercostal drainage, putting a tube and draining out all the pleural contents. Indication for active intervention, that is intercostal drainage, ICD, intercostal drainage in paranymonic effusion. So paranymonic effusion, whenever there is some infection in the lung such as pneumonia, lung abscess and bronchiectasis, if a pleural effusion is formed, it is called paranymonic effusion. See, can chylothorax be classified as exudate or transudate? See, I have clearly written it as important exudate pleural effusion. Even after telling it as exudate, so still you are asking, is it exudate or transudate? Okay. So effusion associated with pneumonia, lung abscess or bronchiectasis, it is called paranymonic effusion. So generally, whenever an infection is associated with effusion, if you treat that underlying infection, that effusion will also resolve automatically. So in majority of paranymonic effusion, treat the underlying pneumonia or lung abscess or bronchiectasis with antibiotics, that effusion will resolve. But in few limited situations, you should put an intercostal tube and completely empty out that effusion. Completely empty out that effusion. So what are those indications? So first indication is pus in pleural cavity. So pus anywhere is a very, very bad thing. So pus anywhere, it has to be removed completely. Second important thing, pleural effusion pH less than 7.2. Pleural effusion glucose less than 60 mg%. Presence of loculations, loculated pleural effusion. Next is pleural effusion gram staining. Pleural effusion gram staining reveals organisms. So reveals organisms. So whenever there is pus in pleural cavity, it should be removed completely. So then pleural effusion pH less than 7.2. Pleural effusion glucose is less. Loculations. So what does this all indicate? If at all this is happening, there is some active inflammation. There is some active inflammation due to active infection. So whenever there is an active infection within the pleural space, it has to be immediately removed. Whenever there is an active inflammation and active infection in the pleural space, it has to be removed. What is the reason behind this? See, what is the adjacent compartment to your pleura? Mediastinum. So if at all there is an active infection within the pleural space, it can easily migrate into the mediastinum. So once it goes into mediastinum infection, sepsis can happen very fast. So if you don't remove this infected fluid, if it spreads into mediastinum, if it goes into blood, so patient will die of septicemia. Then pleural effusion gram staining reveals organism. If the pleural fluid is showing organisms, it means it is actively infected. So any active infection within the pleural space should be immediately removed. Why it should be immediately removed? Because because if you don't remove it, so adjacent compartment is mediastinum, it will go into the mediastinum and there will be septicemia. So loculated pleural effusion means normally pleural effusion will be easily movable. Loculations means because of inflammation there will be formation of some thick fluid and fibrotic strands. So whenever there is loculations also, it means there is some active inflammation and some fibrosis is happening within the pleural space. So that is also a bad sign. It means active inflammation is happening. So it is difficult to aspirate. So that's why I put a tube directly. So it is difficult to aspirate with a needle. So I see in the ultrasound, wherever there is a big locule, I put a tube. So once you decrease the infective load, so the locules can later on resolve. So this is regarding parapneumonic effusion. So now I will give you a clinical scenario. Tell me what is the answer. So there was a 40-year-old male. He complained with fever, shortness of breath and chest pain. I have taken a chest X-ray. Chest X-ray was showing right-sided consolidation with pleural effusion. So patient presenting with fever, shortness of breath, chest pain. Patient presenting with fever, shortness of breath and chest pain. And there is right-sided consolidation and pleural effusion. Now what will be your probable diagnosis? So consolidation means pneumonia, pleural effusion means both put together, it is a parapneumonic pleural effusion. It is a parapneumonic pleural effusion. So parapneumonic pleural effusion is there. Now I wanted to know what exactly is there in the pleural cavity. I put a needle. So this is what I could find out. So I put a needle in the pleural space. This is what I could drain. So what is this? This is pus. So now what will be your diagnosis? So pus in pleural cavity. So when I aspirated, I got pus. So pus in pleural cavity, it is empyema. Now what will be your next step in management? Now you are having a patient with empyema. What will be the next step in management? Yes, you should immediately put an intercostal drain. So if they give you a scenario like this, you have aspirated fluid and it was pus. So what you should do? You should do intercostal drainage. Next is malignant pleural effusion. So malignant pleural effusion. So malignant pleural effusion, it can be either due to primary tumors of pleura or it can be due to metastasis from adjacent organs. So breast metastasis, it can be due to lung metastasis, colon metastasis. So malignant pleural effusion, it can be either due to primary tumors of pleura or due to metastasis from elsewhere. So the biggest problem in malignant pleural effusion is recurrence. So write down the management of malignant pleural effusion. So recurrence is very, very common. Recurrence is common. So even if I aspirate today, after few days, again fluid can accumulate. So in the management, first what I do is, I do a therapeutic thoracentesis. I am going to remove about 1 to 1.5 liter of fluid. So after doing therapeutic thoracentesis and treating the underlying malignancy, if it is not reaccumulating, there will be no issue. but in majority there will be recurrence. So majority there will be recurrence. So if at all there is recurrence, if at all there is recurrence, I go for putting an ICD to drain the fluid. So I will insert an intercostal drain. I will put an intercostal drain. So here consider this is the healthy lung. Around that this is the pleura. This was the diseased lung and there is collection here. Okay. So this is the malignant pleural effusion. So first step here is I am putting an intercostal drain. So once you put an intercostal drain, what is going to happen? After few days, fluid drains. And once fluid drains and the lung expands. So after few days, this will be the situation. So see this. So on the other side, it is the same. On the diseased side, now because fluid is drained, lung will expand, and this is the pleural cavity, and this is the ICD. So after few days, fluid is drained. After few days, fluid is drained and lung expands. So what do you do next? So once the lung expands, now I should inject a sclerosing agent. So sclerosing agent. So what are the sclerosing agents? So talc or doxycycline. So inject sclerosing agent into the ICD to obliterate pleural space. So this phenomena is called as pleurodesis. So this phenomena is called as pleurodesis. So what I am going to do is, once the lung is expanded, through the ICD, I am going to inject sclerosing agent such as talc or doxycycline. So what is the function of sclerosing agent? So it will go into the pleural cavity, and this sclerosing agent will just act like an adhesive. It will act like a gum. See, if there is pleural space, fluid can easily accumulate. So if I am obliterating the pleural space, so I am adhering visceral and parietal pleura together, there will be no space for fluid to accumulate. So this method of fusing visceral and parietal membranes together, it is called as pleurodesis. So this sclerosing agent works just like an adhesive. It works like a gum and it attaches parietal pleura and visceral pleura. So here the basic concept is you are blocking the space. You are obliterating the space so that fluid will not recur. So this is the traditional management. So pleurodesis is the traditional management, obliterating the space. But majority of the patients, what happens is, this is a very big tube. This is a very big tube, and patient will be having severe pain. And because it is a big tube, chances of reinfection will also be more. So through that tube, infection can happen. And you don't know for how many days the tube should be kept. Because in few people, the fluid will be drained within 1 week. But in few people, it will be continuing for months together. So to overcome this problem, now recently we are putting a small flexible tube. So that small flexible tube, it is called as indwelling pleural catheter. So this is the new tube that we are putting. So indwelling pleural catheter, also called as Pleurex catheter. So this is a small flexible silicone tube. So this is a small flexible silicone tube. The advantage is patient will have less pain, less chances of infection. So this can also cause this can also have frequent drainage. So you can frequently remove the fluid, and most importantly, better tolerated. So if they ask you what is the recent method for management of malignant pleural effusion, so for patient's comfort, we can go with a Pleurex catheter. So there will be less pain, less chances of infection, and this will also provide frequent drainage. And most important of all, this is better tolerated by the patient. So this is better tolerated by the patient. It is better tolerated by the patient. See, generally pleurodesis is reserved for malignant pleural effusions. So many people are asking, sir, will there not be any breathing problem or any issue? See, malignant pleural effusion itself means patient is stage 4 disease. So his survival is only for 3 to 4 months. So in this 3 to 4 months, instead of asking him to come daily to the hospital, removing pleural fluid, it will be painful. So this is a temporary method so that you can give his life last 2 or 3 months some pain-free experience. So whatever we are doing here is, it is not definitive management, it is not curative management, it is palliative management. So in palliative management, kindly remember, whatever procedure is having less pain to the patient, that will be preferred. So previously, conventional management is ICD and pleurodesis. So even if you do that, patient is going to survive for 3 to 4 months. Even if this is also done, patient is going to survive for 3 to 4 months. But this procedure has less pain, less chances of infection, frequent drainage, and it is better tolerated. Okay. So why can't we put sclerosant after pleural tap directly? So sclerosant has to be injected through the tube. That is a very, very thick substance. If you try to put it into the intercostal space, that needle will break, and you have to go to a CT surgeon, and you will be put under bars for breaking the needle in the pleural space. Okay. So Pleurex catheter initially was made for malignant pleural effusion. Nowadays in empyemas also it is helpful, but it was made for malignant pleural effusion. Now try to solve this question. A 60-year-old male with history of alcohol abuse is evaluated because of insidious onset of dyspnea over the course of 6 weeks. So he has moderate sized right pleural effusion. Serum amylase within normal limits, glucose normal, pleural fluid values are used as follows. So ratio of pleural fluid protein and serum protein is 0.2. Pleural fluid LDH, so serum LDH is 0.35. So other laboratory results serum albumin is low with prolonged prothrombin time, and normal urine analysis, ECG is normal. So which of the following is most likely diagnosis? See, you should not get wrong in this question, because everything is pointing out to a single diagnosis. Okay, let me go step by step. Now this patient is having pleural effusion. Now tell me whether this is transudate or exudate. Is it transudate or exudate? Yes, is it transudate or exudate? So this is a transudative pleural effusion. Why it is transudative pleural effusion? Because the ratio of protein is less, ratio of LDH is less. Now if it is transudate, you need to know whether it is liver cause, kidney cause or heart cause. So ECG is normal, cardiac failure with normal ECG is unlikely. Normal urine analysis, so nephrotic syndrome you can rule out. So it is not congestive heart failure, it is not nephrotic syndrome. So mostly transudate. Here transudate either should be heart failure or hepatic hydrothorax. Now can it be hepatic hydrothorax? history of alcohol abuse. Patient's protein content has decreased. So liver is the source of protein production, it has decreased. And there is also some clotting abnormality. Prothrombin time is prolonged. So all this indicates there is some coexisting liver disease. So the best answer is hepatic hydrothorax. So answer is B. So this is a transudative effusion. The summary of this question is transudative effusion and there is evidence of liver disease. So again, don't ask me how can you say there is liver disease. See, alcohol abuse risk factor. Alcohol abuse risk factor. Albumin, liver generates protein. Now protein value has decreased. It means liver is not functioning well. Prolonged prothrombin time. Again, liver is responsible for proper clotting factor production. So the best answer is option B. Best answer is option B. All are true regarding rheumatoid arthritis associated pleural effusion except. Yes, what is the answer here? Rheumatoid arthritis associated pleural effusion except. Yes. So what is the answer here? See, rheumatoid arthritis pleural effusion, it is an exudative pleural effusion with low glucose. So because it is an exudative pleural effusion, so protein can be high, LDH can be high. So because it is rheumatoid arthritis, there will be high RA factor in the body. But it is not high glucose pleural effusion. It is a low glucose pleural effusion. So very, very important. So in rheumatoid arthritis, what will happen? There will be pleural inflammation. And in the inflamed pleural cells have high metabolism. And fuel for that metabolism is glucose. So it feeds on the glucose from the pleural space. So what happens to the glucose? It will be low glucose pleural effusion. Now what is this disease? Accumulation of air into the pleural cavity. What is this disease? Accumulation of air in the pleural cavity. It is pneumothorax. Already we have discussed the radiological features and clinical findings in pneumothorax. Pneumothorax, is it pulling lesion or pushing lesion? It is a pushing lesion. And what do you see on percussion? There will be a hyperresonant node. Percussion shows hyperresonant node. And next important thing, on the X-ray, you can find hypertranslucent area. Hypertranslucent area with compressed lung margin, it was discussed. So let us see the classification of pneumothorax. So pneumothorax can be classified into two forms. So we have spontaneous pneumothorax, traumatic pneumothorax. So spontaneous pneumothorax again divided into primary spontaneous pneumothorax, secondary spontaneous pneumothorax. So primary spontaneous means there is no pre-existing lung disease, but still pneumothorax happens. Exact mechanism is not known. Exact mechanism is not known for primary spontaneous pneumothorax. Secondary spontaneous, there will be a pre-existing lung disease. There will be a pre-existing lung disease. So because of this pre-existing lung disease, there will be development of pneumothorax. So what is the most common lung disease responsible for pneumothorax? Already discussed. In which lung disease there will be hyperinflated areas called as bullas, which can rupture at any point of time. Yes. What is that disease? COPD. Apart from COPD, interstitial lung disease, tuberculosis can also cause pneumothorax. But if they ask you most common lung disease, your answer should be COPD. So why it happens in ILD and tuberculosis, when they discuss ILD and tuberculosis, we will know in detail. Coming to traumatic pneumothorax. So traumatic pneumothorax, it can be divided into trauma happening in hospitals, that is iatrogenic. So trauma happening in hospital, trauma happening outside. So direct chest wall injuries. So where do direct chest wall injuries generally happen? During road traffic accidents. So during road traffic accidents, generally direct chest wall injuries happen. Coming to iatrogenic causes. So what is the most important procedure that results in pneumothorax in the hospital? Yesterday I told you, I asked my postgraduate to get some sample from the pleural cavity. He not only punctured the pleural cavity, he inserted the needle very deep, puncturing the lung. Because of that, air escaped into the pleural cavity. So what is that procedure that we do? Thoracentesis. So pneumothorax can happen during thoracentesis. Second important thing is mechanical ventilation. Mechanical ventilation. So why in mechanical ventilations? So high pressures, high pressure or high positive pressure during mechanical ventilation can cause alveolar rupture. So whenever you give high positive pressure, your alveoli can rupture. So alveoli are very close to the pleural surface. So when they rupture, air can escape into the pleural space. So whenever air escapes into pleural space, what is the dangerous complication? Pneumothorax. And third important thing is insertion of subclavian catheter, central venous catheter, especially subclavian catheter. Insertion of central venous, that is a subclavian catheter. Subclavian catheter. Insertion of central venous catheter, that is subclavian catheter. See, whenever your peripheral veins are not accessible, you go for central venous cannulation. So one is jugular, other is subclavian. So whenever I want to approach subclavian, I have to puncture beneath the clavicle. So whenever I am puncturing beneath the clavicle, accidentally lung apex can be damaged. So whenever lung apex is damaged, air from the lung can escape into the pleural cavity. So that can result in pneumothorax. So if they ask you what are all the hospital procedures that can cause pneumothorax, so you should know it can be due to thoracentesis. If you give high pressures during mechanical ventilation, insertion of central venous catheter, especially subclavian catheter. Now out of all pneumothoraces, most important for your exam will be tension pneumothorax. So write down tension pneumothorax. So how it is happening? So for tension pneumothorax, the first prerequisite is presence of large air leak. So consider this is the lung and let this be the pleural surface. So you will have, let this be the diseased lung. So because of this disease, air is leaking into the pleural space. So there is a large air leak and there is formation of pneumothorax. And because of some unknown property, this air leak can function as one-way valve. So we don't know exactly why it is happening. So as one-way valve or ball valve. So this air leak can function as one-way valve or ball valve. So one-way valve means during inspiration, air will be coming into the pleural cavity. during expiration, nothing will be going out. So we don't know the precise reason behind this, but they have identified in tension pneumothorax that air leak was functioning as a one-way valve. So because of this one-way valve mechanism, what will happen? With each inspiration, air is coming into the pleural space and it is not going out. So there will be increased positive intrapleural pressure, increased positive intrapleural pressure. So whenever there is increased positive intrapleural pressure, it will start compressing. So there will be compression of adjacent lung and also mediastinum. So mediastinum. So adjacent lung and mediastinal vessels. So whenever the mediastinal vessels are getting compressed, there will be decreased venous return. So because of decreased venous return, there will be decreased cardiac output. There will be decreased cardiac output. So that results in hypotension. That results in hypotension. And ultimately, patient lands up in shock. Now, why this is called as tension pneumothorax? Not because patient is in hypotension and doctor is getting tension actually. So what exactly is happening in this patient? So there is increased buildup of pressure within the pleural space, and that pressure is causing compression. Because of that compression, there is reduced venous return, reduced cardiac output, resulting in hypotension and shock. So that pressure is also called as tension. So that's why it is called as tension pneumothorax. There is a lot of pressure in the pleural space which is compressing and not allowing circulation. So pressure is also called as tension because this is happening due to buildup of tension within the pleural space. It is called as tension pneumothorax. It is called as tension pneumothorax. Now, this tension pneumothorax is a medical emergency because the patient is in shock. It is generally a medical emergency. And most importantly, it is a clinical diagnosis. So no need to do any investigation to call it as tension pneumothorax. Patient is having features of pneumothorax and hypotension. It means it is tension pneumothorax. So because before you send him to a X-ray or you do something, patient may not survive because it is a very, very large compression. Immediately patient can go into cardiac arrest. So don't wait. If there is a tension pneumothorax, go sending him for X-ray, sending him for CT chest. It is a medical emergency and generally it is a clinical diagnosis. So what will be next step or best step in management of tension pneumothorax? Always remember, whenever I mention it is a medical emergency, the next or best step will be the procedure which will save the life of the patient. So life is most important here. So the next or best step here is insertion of a wide bore needle. Insertion of a wide bore needle on affected side, followed by ICD insertion, Now because there is more pressure in the pleural cavity and it is causing compression, by putting a needle you can relieve the compression. So once you relieve the compression, circulation will improve and patient may improve. But this single needle cannot drain the whole air. So for better drainage, we immediately put an intercostal drain. Now there will be some very, very smart students asking me, So instead of putting a needle, why can't we put ICD in the first instance itself? So what you need to understand is, for me to put a needle, it will take less than 5 seconds. I take the needle, I insert. But ICD is a minor surgical procedure. I should follow aseptic precautions. I should give an incision. I should take the tube. I should insert. It will take me at least 5 minutes. So here, if your 5 minutes will definitely cause deterioration in the patient. Because emergency means you should do within seconds. So what can be done within seconds? Needle insertion. So first insert a needle. So then you bring the ICD and you can put the ICD. So next question is, what is the ideal site of needle insertion? What is the ideal site of needle insertion, and what is ideal site of ICD insertion? Ideal site of ICD insertion. So write down, for ICD insertion, it is always a single answer. 5th intercostal space near the mid-axillary line. 5th intercostal space near the mid-axillary line. For ICD insertion, according to new guidelines, it is 5th intercostal space, mid-axillary line. So it has been changed recently. If it is not given in the option, you can follow the old guidelines. 2nd intercostal space, mid-clavicular line anteriorly. Mid-clavicular line anteriorly. So these are the new guidelines. So according to new guidelines, site of ICD insertion and site of needle insertion are similar. 5th intercostal space, mid-axillary line. But for needle insertion, there is also a second option. If 5th intercostal space is not given in the option, you can go for 2nd intercostal space, mid-clavicular line anteriorly. Mid-clavicular line anteriorly. See, intercostal drainage means you are putting a tube within the thoracic cavity, so that can also be called as thoracostomy. So generally here you get that triangle of safety, that 5th intercostal space. So that everything is a surgical aspect. It will be discussed in your surgery. Okay. So if they ask you, a patient in tension pneumothorax, what is the next step or best step? Always should be the life-saving method, that is insertion of wide bore needle. So for needle, according to new guidelines, 5th intercostal space. If it is not given, you can go for 2nd intercostal space, mid-clavicular line. But for ICD, it is always a single answer. That is 5th intercostal space near the mid-axillary line. Now try to solve this question. A 64-year-old male requires endotracheal intubation and mechanical ventilation for COPD. You are called acutely to bedside when his BP abruptly drops to 70 by 40 mm Hg. Breath sounds are absent on the right and clear on the left. What is the best course of action at this time? What is the best course of action at this time? See, how do you diagnose tension pneumothorax? Features of pneumothorax. So you are percussing, breath sounds are absent, there is mediastinal shift, there is hyperresonant node, patient is having shortness of breath. So we have seen the clinical diagnosis of pneumothorax already. So in this question, what is the probable diagnosis? See, patient is an elderly male. He is on invasive mechanical ventilation and he is having COPD. So whenever you put a patient of COPD on ventilator, there is chances of pneumothorax, and tension pneumothorax is an important complication of invasive mechanical ventilation. So BP has also decreased, breath sounds are absent. All these are suggestive of tension pneumothorax. So features of pneumothorax with hypotension, your suspicion should be tension pneumothorax. What should be done immediately? Save the life of the patient. How will you save the life of the patient? Place a wide bore needle in the right second anterior intercostal space to alleviate a tension pneumothorax. So because it is a right sided disease, you put it on the right side. So place a large bore needle in the right second anterior intercostal space to alleviate tension pneumothorax. So here for 16th question, answer is option C. Male with car accident, recent AIMS question, dyspnea, chest pain, anterior chest wall bruit, peripheral pulses present. In percussion there is tympanic knot, pelvis was normal, decreased breath zones on left side, tachypnea with low BP. So what is your diagnosis here? What is your diagnosis here? What is the diagnosis here? Yes, what is the answer here? So here there is trauma history. Along with that, tympanic knot, decreased breath sounds. So all this put together, this is most probably pneumothorax, because BP is also no, BP is also low. This can be tension pneumothorax. So best answer is a tension pneumothorax. Tension pneumothorax. Now, why can't it be cardiac tamponade? So because in cardiac tamponade, you don't find a tympanic knot. So why can't it be hemothorax? So hemothorax is collection of blood. So blood will not give tympanic knot, it will give stony dull knot. And why can't it be collapse? Collapse will also not give tympanic knot, it will give a dull knot. It will give a dull knot. Sir, what is it? See, that's why I told you. Here, pelvis is given normal. In any trauma, there can be pelvic injury also. So that's why we check for any collection in the pelvis. Yes. So what is the answer here? This is pneumothorax. Option A. Question number 17. Option A. Question number 17. Option A. Okay. So coming to the next disease, this patient is exposed to set of allergens like this, and patient is developing symptoms such as frequent coughing, shortness of breath, chest pain. So Mr. Amit Indragni, you are asking how wide bore needle affects. There is a big balloon, it is filled with air. Now I want to relieve the pressure from the balloon. So if you put a needle, so what will happen? Gradually the air will be released. So by putting a needle in the intercostal space, it is going to relieve the pressure. Okay, air will come out. So I'm sorry, because after telling that there is increased pressure, you put a needle so that you can relieve the pressure. Still, how simple I can explain? Yes? Okay. So what is this condition? Allergen exposure, patient is developing these symptoms. Yes? So this is asthma. So this is asthma. So asthma, write down the definition of asthma. So asthma is characterized by shortness of breath. Patient can have shortness of breath, cough, wheeze. So he can have any of these symptoms or combination of these symptoms: shortness of breath, cough, wheeze. Okay, due to variable and reversible bronchospasm associated with airway hyperresponsiveness airway hyperresponsiveness to variety of stimuli. So to variety of stimuli. So asthma is a disease where patient will have few symptoms. So what are those symptoms? Shortness of breath, cough, wheeze. So why it is happening? Due to bronchospasm. So why bronchospasm happens? Because of airway hyperresponsiveness to variety of stimuli. So your airway is hyperresponsive. So it can give a hypersensitivity reaction resulting in bronchospasm. So there is a disease confused with asthma, that is COPD. So I'll also discuss the definition of COPD. Then we will see how they are different. Chronic obstructive pulmonary disease. So COPD is also characterized by the same symptoms but persistent. So they are characterized by persistent symptoms. So persistent symptoms and airflow limitation. Persistent symptoms and airflow limitation. Persistent symptoms and airflow limitation due to airway and alveolar abnormalities. Airway and alveolar abnormalities caused by significant exposure to noxious stimuli. Caused by significant exposure to noxious stimuli. Now see here, in COPD also there will be the same symptoms, but they will be more persistent. So this is due to airway and alveolar abnormality caused by exposure to noxious stimuli. So what is that most important noxious stimuli? Smoking. So in short, whenever you are thinking about asthma, important is patient's allergy history. So this is a variable and reversible bronchospasm. So whenever an allergen is exposed to the patient, body will give an hypersensitivity response, and after some time it is gone. So it is a variable and reversible bronchospasm. So it is a reversible bronchospasm associated with airway hyperresponsiveness to variety of stimuli. Whereas in COPD, the symptoms are persistent and airflow limitation is also persistent because it is not due to allergen related. It is due to smoking related damage to the lung, because lung is permanently damaged here. So generally the airflow limitation will be persistent. So if it is asthma, you should ask the patient regarding allergy history. So asthma, it is variable and reversible bronchospasm and it is due to airway hyperresponsiveness. Whereas COPD, persistent symptoms and airflow limitation due to airway and alveolar abnormality caused generally by smoking, noxious stimuli. Now for asthma, there is something called as hygiene hypothesis. So first we will discuss regarding asthma in detail. So for asthma, there is a new theory called as hygiene hypothesis. So this looks a little bit funny. Being very clean, very tidy is a risk factor for developing asthma. So if you are clean, if you are hygienic, it is a risk factor for development of asthma. So this looks a bit funny, but it was based on an observation in hospitals in the United States. So what they have found out is children coming from rural areas were having less tendency to develop asthma, whereas children coming from urban areas were having more tendency to develop asthma, So what was the reason behind that? So they found that children grown in villages, they were exposed to low level of dust. They were exposed to low level of allergens. So this low level of allergens continuously was educating the immune system not to react excessively. So for this, I will give you a classical example. After so many days, you are taking bath with cold water for the first time. So on the first day, you will be shivering like anything, dancing like anything. Now if you continuously take cold water bath for next 20 days, on the 21st day also, you will shiver a bit, but when compared to first day, your shivering will be 80 to 90% reduced. So what was the reason behind this? So because of daily exposure to cold water, your receptors on the skin have become educated. So they have found out this is something routinely happening. This is something routinely happening. So no need to give that hyper responsiveness. So this is how your body's receptors are getting educated. In the same way, low level of dust exposure in childhood can reduce the risk of asthma. It is just a theory, not yet proved, but once asked in your exam. So write down few exposures in early childhood can educate the system. So somebody is telling that's why females are more prone to asthma. Actually, females are more prone to asthma. That is a true statement. Yes. So few exposures in early childhood can educate the immune system and thus protect against development of allergic diseases. Yes, hostel boys are always not prone to asthma. You are protected against asthma, don't worry. So the few exposures in early childhood can educate the immune system and protect against development of allergic diseases. So reduced risk of asthma was seen in children grown near agricultural areas. So children grown near agricultural areas. So because in agricultural areas, frequent exposure to dust. And recent theory has shown that in the childhood, even hookworm infection and also H. pylori infection. So hookworm infection and H. pylori infection, in this also there is low risk of asthma. So what is the reason behind hookworm and H. pylori infection? Studies have shown that these organisms produce a few substances which will reduce the hyperresponsiveness. So we don't know the exact substances. So they found out the tendency of hyperresponsiveness was less in patients infected with hookworm and H. pylori. So they thought that these organisms were producing few substances which were reducing the airway hyperresponsiveness. So previously asked question, which of the following is having low risk of asthma? So in the options, either you should select H. pylori infection, hookworm infection, children grown near agricultural areas. So in short, being clean, being hygienic is a risk factor for development of asthma, but a definite risk factor for development of COVID. So thinking that you will escape from asthma, if you stop being hygienic, you will be affected by COVID. So this is a double-edged sword. Okay. So low risk of asthma, you should know these three things. So children grown near agricultural areas, hookworm infection, H. pylori infection, H. pylori infection. Now with help of a table, let us see the differences between asthma and COPD. So whenever I want to study about asthma, generally it is allergen related, whereas COPD is smoking related, wherever COPD is smoking related. In asthma, it is reversible airflow limitation. In COPD, it is persistent airflow limitation. Asthma, generally early presentation. So majority of the patient will be young age, children and also young adults. Whereas COPD, it is delayed presentation. So why COPD has delayed presentation? The simple reason is, so for a person to develop COPD, he should have smoked for at least 20 to 30 years. So if at all he starts smoking at his 20th year, by the time he develops COPD, his age will be somewhere 50 years. Okay. So COPD patients are generally elderly, because for COPD to develop, they should have significant smoking history of 20 to 30 years. So by the time they reach 50th year, then only it generally manifests. Then asthma, because it is a reversible airflow limitation, there will be good relief with bronchodilators. Because there is no significant lung damage, it is a reversible airflow limitation. So during that episode, patient will have good relief with bronchodilators. Whereas COPD, only partial response. There is lung damage, so it will be only partial response. So whatever guidelines I discuss about asthma, they are called as GINA guidelines. So GINA means Global Initiative for Asthma. So GINA guidelines, Global Initiative for Asthma. Whatever guidelines I discuss about COPD are called GOLD guidelines. So GOLD means Global Initiative for Obstructive Lung Diseases. So this is a very, very important table to differentiate between asthma and COPD. So asthma, allergen related, early presentation, reversible airflow limitation, good relief with bronchodilator. COPD, smoking related, persistent airflow limitation, delayed presentation, only partial response. So for asthma, the guidelines are called as GINA. So GINA is an association which deals with asthma guidelines. GOLD is an association which deals with COPD guidelines. So global GINA means G IN. So initiative INA asthma. GOLD means Global Initiative for Obstructive Lung Disease. So in short, asthma is something happening very early in your life and mostly reversible, just like one's girlfriend. So asthma is just like one's girlfriend. It happens early in our lives and mostly reversible. Whereas COPD is something happening late in your lives, mostly persistent, just like one's wife. Very, very horrific and terrible experience. So only once you feel it, you will know. So in short, asthma is just like your girlfriend, early and reversible, whereas COPD, delayed and persistent. So out of these two, which is very, very dangerous disease? Definitely you know better. Very, very dangerous to control is your wife. So COPD requires more concentration and more treatment options. Now sometimes if you don't treat your girlfriend properly, she will start behaving like your wife. This is also a dangerous condition. If you don't treat asthma properly, it will also convert into a persistent disease. What is that phenomena called as? So it's not my personal experience. It will be personal experience for everybody. It is an inevitable experience. Don't worry. So write down. Even if you don't treat asthma properly, because of chronic inflammation, there are some changes happening in the airway called as airway remodeling. So if asthma not treated properly, if you don't treat your girlfriend properly, sometimes she will also start behaving like your wife. So if asthma is not treated properly because of continuous chronic inflammation, so always there is continuous chronic inflammation, there will be airway remodeling. Resulting in irreversible airflow limitation. It will also start behaving like COPD. So what are the features of airway remodeling? So this was asked as a question. What are the features of airway remodeling? So first feature is there will be subepithelial fibrosis. So subepithelial fibrosis. There will be increased mucus secretion within the airway. There will be increased thickness of airway smooth muscle. So let us discuss later regarding girlfriends and wife. Now let us concentrate on the topic angiogenesis. angiogenesis. So if you don't treat asthma properly, there will be airway remodeling and it will cause some permanent changes in the airway that results in an irreversible airflow limitation. So subepithelial fibrosis, increased mucus secretion, increased airway smooth muscle, angiogenesis. I will show you what is exactly happening here. Now you can see this is the structure of normal airway. This is the structure of normal airway. So this is the normal airway diameter. It is clear without any secretions, and this part is the airway smooth muscle. You can see airway smooth muscle is not that thick. So airway smooth muscle, normal diameter and no secretions. So in airway remodeling, what will happen is you can see within the airway there is plenty of mucus. So there is plenty of mucus, and most important finding is this. So what is this finding? There is increased thickness of airway smooth muscle. So there is increased thickness of airway smooth muscle. So this is a permanent change now. So whenever your airway smooth muscle thickness increases, now the diameter of airway decreases. So now it will start behaving like a permanent obstruction. Even if the patient takes inhalers, there will be no sufficient benefit. So in such patients, what is the new treatment? So the new treatment is called, in these patients, there is a new treatment. So this treatment is called as bronchial thermoplasty. So what is this bronchial thermoplasty? I am going to insert the bronchoscope in the lung. With a specialized device, I will give heat energy to the airway and I will decrease the thickness of airway smooth muscle. So bronchial thermoplasty means ablation or reducing the thickness of airway smooth muscle, by delivery of thermal energy. So recently asked question, bronchial thermoplasty is useful in management of which disease? Bronchial thermoplasty is useful in management of which disease? Your answer is asthma. So whenever there is poorly controlled asthma and there is increased airway smooth muscle thickness resulting in a irreversible airflow limitation, this is one of the treatment options. So what you are doing, you are putting a bronchoscope and with help of a specialized probe, you are delivering heat energy to the airway smooth muscle. So because of that heat energy, there will be reduction in thickness of airway smooth muscle. So once you give heat energy and you are decreasing the thickness of airway smooth muscle, the diameter of the bronchus will improve. So whenever the diameter of bronchus is improving, now the patient's symptoms will be declining. So this is it, bronchial thermoplasty, advanced method. So when all the medical management fail, so this bronchoscopic method can be done. Okay. So this is bronchial thermoplasty. So we cannot use for COPD because in COPD there is no increased airway smooth muscle. It is not in bronchus. So COPD is at the level of alveoli. So till that this instrument will not go. You cannot use it for COPD because the disease is very distally. You cannot pause any object there. So generally after bronchial thermoplasty the results are good. Okay. Now let us see asthma types. Extrinsic or atopic asthma, intrinsic or idiopathic. Yes, it is costly. It will cost about 1 to 2 lakhs. So to avoid fibrosis, we will give some steroids. So generally when you give steroids, the fibrosis will decrease. So extrinsic or atopic asthma. So write down, as the name indicates, atopic. Here the trigger is allergen. So this is allergen mediated disease, allergen mediated asthma. And if they ask you what is most common allergen responsible for extrinsic asthma? Your answer should be dermatophagoids. Your answer should be dermatophagoids. So what is this dermatophagoids? It is a house dust mite. Dermatophagoids means house dust mite. And because this is classical asthma, serum IgE will be elevated. And this is classical asthma, it is a type 1 hypersensitivity. So skin test will be positive for some allergen. So skin test will be positive for some allergen. So this is childhood onset disease. So majority of these patients present in childhood onset disease. And most importantly, this is a mild asthma. So this extrinsic or atopic asthma is the most common type of asthma that we see in majority of the population. So these patients tell that they are getting symptoms after exposure to an allergen. And most common allergen here is dermatophagoids. What is dermatophagoids? It is house dust mite. And if I see in their blood, because it is allergy mediated inflammation, serum IgE level will be elevated. And if I do a skin test with an allergen, you can see the positive reaction. Skin test will be positive for allergens. And here it starts early childhood onset disease. And in majority it will be a mild asthma. Coming to the rare asthma and unclear mechanism, intrinsic or idiosyncratic. So we don't know exact mechanism of this disease. So the trigger is also not exactly known. So few people think it is due to some viral infections or it can be due to bacterial infection. So the trigger is unclear. Because it is not allergen mediated classical asthma, here serum IgE will be normal. And you cannot identify any allergen responsible for this. Skin test will be negative for all allergens. So skin test will be negative for all allergens. So this is an adult onset disease. So this is an adult onset disease. And the presentation will be more severe. You don't know why exactly it is happening. So you cannot give proper treatment here. See, allergen mediated, you know the allergens, you can avoid the allergens because it is a mild asthma, you can treat it properly. You don't know the exact trigger. So serum IgE was found to be normal in this set of patients. Skin test will be negative for all allergens, adult onset disease, and this is a severe asthma. Now, in extrinsic atopic asthma, there is a special type called as thunderstorm asthma. So this is a very, very important table for your exam, thunderstorm asthma. So why thunderstorm asthma happens? So whenever there are thunderstorms, there will be strong winds. So whenever there are strong winds, there will be dispersal of pollen grains in that area. So when there is dispersal of pollen grains in that area, patients already having asthma, now because of exposure to pollen grain, will get more symptoms. So this phenomena is called as thunderstorm asthma. So during thunderstorms, there will be dispersal of pollen. Due to dispersal of pollen by strong winds. So because the pollen is dispersed everywhere, now the asthmatic, whenever he inhales pollen, his symptoms will increase. So this phenomena is called as thunderstorm asthma. Thunderstorm asthma. So write down thunder. If they ask you what is the cause of, what is the most common cause of atopic asthma, your answer should be dermatophagoids. If they ask you what is the cause or allergen in thunderstorm asthma, your answer should be pollen. So allergen in thunderstorm asthma, your answer should be pollen. Allergy for thunderstorm asthma, your answer should be pollen. So seasonal asthma is generally extrinsic asthma. Okay. So next important is diagnosis of asthma. So write down diagnosis of asthma. So most important test in diagnosis of asthma is spirometry. So most important test is spirometry. So within this spirometry, you will notice an obstructive pattern. Now even COPD is obstructive. Asthma is obstructive. How will you differentiate COPD and asthma? So for this we have a test called as bronchodilator reversibility. So in asthma there is a property called as bronchodilator reversibility. So what is this bronchodilator reversibility? There will be increase in FEV1 more than 12% or 200 ml after SABA inhalation. After SABA inhalation. So what is this? For example, there was a patient with asthmatic who has come to my clinic with FEV1 of 65%. Now I have given him SABA. So SABA means short acting beta 2 agonist. What is the function of SABA? Bronchodilation. And what is the frequently given SABA? Salbutamol. What is the frequently given SABA? Salbutamol. So I give SABA. After 10 to 15 minutes, I am repeating the test. So in asthma, what happens? His FEV1 will increase. Now if you see here, his FEV1 has increased more than 12%. So if his FEV1 is increasing more than 12% after short-acting beta-2 agonist inhalation, it is suggestive of asthma. This phenomena is called as bronchodilator reversibility. It is seen in asthma, not in COPD. Second important test is PEFR variability. So PEFR variability more than 10% in a day. So what is this PEFR variability? So in an asthmatic, when will there be more symptoms? In an asthmatic, when will there be more symptoms? So brackets, it is OR. So in an asthmatic, when will there be more symptoms? Early morning or afternoon. So symptoms will be more in the early morning. So the reason is early morning there will be cold weather. So cold weather or cold air can directly cause bronchospasm. And by afternoon the symptoms will improve. Again in late night the patient will have more symptoms because of cold air. So now if you ask the patient to do PEFR, so in the early morning it will be less. By afternoon it will increase. Again in late night it will decrease. So if in a patient his PEFR is changing with periods in a day, so morning less, afternoon more, again night less. So this is also suggestive of asthma. So PEFR variability more than 10% in a day. And third important test is bronchoprovocation testing. So bronchoprovocation testing, also called as Methcolin challenge test. Methcolin challenge test. You must be knowing this methcolin is a bronchoconstrictor substance. On giving a bronchoconstrictor substance, there will be decrease in FEV1 more than 20% after methcolin inhalation. So in asthmatics, decrease in FEV1 will be more than 20% after methcolin inhalation. Now you should get a valid doubt. Even if a normal individual inhales methcolin, there will be decline in FEV1 due to the bronchoconstrictive property. Then how can you specifically say that this decline is only because of asthma? For example, if a normal individual requires 1 mg of methacholine to cause bronchospasm, an asthmatic 0.1 mg is sufficient. So if a normal person requires 1 mg of methacholine to cause bronchospasm, in an asthmatic 0.1 mg is sufficient. Why is it so? Asthmatic airway is hyper responsive. Even with low doses of methacholine, patient will get decline in FEV1. So this is suggestive of airway hyper responsiveness. So this methacholine challenge test will show you airway hyper responsiveness. So already we have discussed in the definition. Asthma is a disease characterized by bronchospasm. So what is the type of bronchospasm? It is reversible. It is variable. And why it is happening? Because of airway hyper responsiveness to variety of stimuli. But out of all this, if they just ask you what is most important in asthma diagnosis, spirometry should show obstructive pattern and a property called as bronchodilator reversibility. So at the end, what you should know, spirometry showing obstructive pattern and bronchodilator reversibility. And few patients with asthma can develop exacerbations and go into a dangerous condition called as acute severe exacerbation. Previously it was called as status asthmaticus. Now it is just called as acute severe exacerbation. So let us complete acute severe exacerbation, then I'll give you a break. So write down acute severe exacerbation of asthma. See, PEFR means peak expiratory flow rate. So yesterday in spirometry first page I have given you the difference between PEFR and MEFR. Acute severe exacerbation of asthma. So this is how patient looks in respiratory distress. So coming to clinical features. So patient speaks in single words. So patient speaks in single words. Instead of sentences, he will be speaking in single words. So this is a very, very important sign. See, whenever a patient is comfortable, if you speak to him, he will be continuously speaking like this. My name is so and so, I'm from this place, I have these ailments, so this is my clinical history. He'll be telling like that. But whenever a patient is in severe respiratory distress, if you just ask him, what is your name? This is how he'll answer. My. He'll take a breath. Name. He'll take a breath. Is. He'll take a breath. So patient speaking in single words indicates there is some significant respiratory discomfort. And his respiratory rate will be more than 30 per minute. His heart rate will be more than 120 per minute. And if you put your stent, there will be bilateral wheeze. And he will be using even his accessory muscles for respiration. There will be shortness of breath even at rest. And you can also notice a phenomena called as pulsus paradoxus. So I hope pulsus paradoxus is being discussed in your cardiology. Then what are the functional criteria? So what are the functional criteria? So in functional criteria, patient's PEFR will be less than 50% of predicted. His SpO2, saturation of oxygen, can be less than 90%. His PaO2 can be less than 60 mmHg. So this will be the initial presentation. This will be the initial presentation of a patient with acute severe asthma. So patient speaking in single words, high respiratory rate, high heart rate. If you put your stent, there will be bilateral wheeze. He will be using even his accessory muscles for respiration, shortness of breath at rest, a phenomena called as pulsus paradoxus. So Rachit Bandari, whenever somebody is having respiratory distress, they will be using their sternocleidomastoid neck muscles also for respiration. So you run for 3 kilometers till you get maximum respiratory distress. Open your shirt and see in your mirror. You can see your neck muscles also taking part in respiration. Okay. Accessory muscle use. I told you now, whoever is having doubt, run for 4 or 5 kilometers, come to the room, open your shirt and see in the mirror. You can see that respiratory distress. Then, for example, you are treating a patient with acute severe asthma. So initially he came to you with bilateral wheeze. After some time, when you put your stats, the wheeze completely disappeared, but you are not also hearing breath sounds. So what is this phenomena called as? What is this phenomena called as? This is called as silent chest. So development of silent chest during acute severe exacerbation of asthma, is it a good sign or bad sign? Development of silent chest during acute severe asthma, is it a good sign or bad sign? Actually, it is the worst sign. So what has happened? Previously, there was bronchospasm, but still some place for air to go in, come out and generate. So as the condition worsens, there will be near total bronchial obstruction like this. So your bronchus will be completely obstructed like this. So because of that, during inspiration and expiration, air will not be going. Because air is not flowing, breath sounds will be absent. So because breath sounds are absent, you will not listen anything in your chest. And because air is not going into the body, what will not go in? Oxygen. So gradually in the body, oxygen levels decreases. And air is also not coming out from the body. So gradually CO2 increases. So there will be declining O2 and increasing CO2. And moreover, my normal respiratory rate is about 12 to 15 per minute. Now this patient is taking respirations at 30 per minute. Now for example, if your normal capacity is to run for 2 kilometers, if I make you to run for 5 kilometers, ultimately what will happen? Your muscles will become fatigued. Now even you cannot walk properly. In the same way, if the patient is taking continuously more than 30 per minute, after some time there will be respiratory muscle fatigue. That will cause decrease in respiratory effort. So once there is decrease in respiratory effort, during inspiration, oxygen will not come inside. During expiration, CO2 will not go outside. So gradually CO2 in the body will increase. If you find any one of these features in acute severe exacerbation of asthma, this is called as a life-threatening sign. Because if you don't intervene immediately, this patient will not survive. So what are the life-threatening signs in acute severe exacerbation? So first is, because of continuous hypoxemia, there will be altered sensorium. Now patient body is not getting oxygen at all. So brain function will decrease. And second important thing, due to continuous respirations, respiratory fatigue. There will be decreased respiratory effort. And third important thing, because air flow is not happening, there will be silent chest. And next important thing, patient's PaO2 will be decreasing. And most important feature, PaCO2 increases. So this is life-threatening signs in acute severe asthma. So if you don't intervene, this patient is not going to survive. So there is altered sensorium, decreased respiratory effort, silent chest, decrease in PaO2, decrease in PaCO2. So first we will see how do you treat acute severe exacerbation. So later we will also discuss what you treat in life-threatening asthma. So write down treatment. Treatment. So whenever a patient with acute severe asthma reaches me, I should give him oxygen and nebulization. Oxygen nebulization. So nebulization generally with a short acting beta 2 agonist, along with that SAMA. So SAMA is short acting muscarinic antagonist. Short acting muscarinic antagonist. So you must be knowing bronchodilators are of two types. Beta 2 agonist is one type and other is muscarinic antagonist. So muscarinic antagonist means anticholinergic. So beta 2 agonist has bronchodilator property. Anticholinergic also has bronchodilator property. Anticholinergic is nothing but muscarinic antagonist. So frequently used SABA, you everybody know, salbutamol, albuterol. SAMA, it is nothing but ipratropium. Ipratropium. Along with this, we can also add ICS. So ICS means inhaled corticosteroids. So just 5 minutes, I'll complete the treatment and give you a break because I don't want to lose the flow. Inhaled corticosteroids. So initially give oxygen and nebulization. So there is a mission called as nebulizer which will generate aerosols of bronchodilator combination SABA, SAMA and inhaled corticosteroid. Second important thing is this patient requires IV steroid, intravenous steroid. So you should give a steroid injection. So this will decrease the inflammatory response. So this will decrease the inflammatory response. If the patient is not improving with above management, a trial of intravenous magnesium sulfate helpful. So this magnesium sulfate has a remote bronchodilator activity. So it has a remote bronchodilator activity. So it might be used if the above medications are not working. So it is just a trial. If above is not working, a trial of MgSO4 can be helpful. Now what is the role of intravenous theophylline such as aminophylline? According to new GINA guidelines, now not recommended. So previously we were giving aminophylline in asthma management, but aminophylline was causing cardiac toxicity. Theophylline can cause cardiac toxicity. So because of that cardiac toxicity, now in management of acute severe asthma, theophylline are not recommended. Now finally, if at all patient goes into life-threatening form, so in life-threatening form, so by the time patient reaches to life-threatening form, he will already be in altered sensorium. So whenever he is in altered sensorium, I cannot go for non-invasive ventilation. I directly go for invasive mechanical ventilation. In life-threatening form, we go for invasive mechanical ventilation. So invasive mechanical ventilation done. And what is the strategy that I follow? So the strategy, it is called as high inspiratory flow. High inspiratory flow plus prolonged expiratory time. High inspiratory flow and prolonged expiratory time. So in the ventilator, the most important setting in treatment of asthma is high inspiratory flow and prolonged expiratory time. Now, how is this helpful? What is the role of this strategy? Now, when a patient reaches to me with life-threatening asthma, this will be the condition of his bronchus. So, near total occlusion of his bronchus. Now, there are two goals in management. First goal is I should open this bronchus so that oxygen can go inside. and I should also facilitate carbon dioxide exit, because this patient will be having both hypoxemia and hypercapnia. So to facilitate the carbon dioxide exit, I should increase the expiratory time on the ventilator. So once you put a ventilator, it can control your inspiration, expiration, airway pressures and volumes. So what I do is, by giving high inspiratory flow, so that flow will open the bronchus. By keeping the expiratory rate, keeping the expiratory time more, it will facilitate carbon dioxide exit. So this high inspiratory flow is for oxygen entry. Prolonged expiratory time will facilitate carbon dioxide exit. So high inspiratory flow will cause oxygen entry. Prolonged expiratory time will cause carbon dioxide exit. It is as simple as this. There is something closer like this. I should open this. How will you open? By blowing air with great force. So this is high inspiratory flow. I should also facilitate carbon dioxide exit. So I am going to prolong the expiratory time. So this is the treatment of asthma. So initially we give oxygen, nebulization with SAMA, ICS, IV steroid, intravenous magnesium sulfate, IV theophylline, now not used. If it is a life-threatening form, invasive mechanical ventilation. And the most important strategy is high inspiratory flow, prolonged expiratory time. Okay. So epinephrine shot not useful, only in anaphylaxis. If it is anaphylaxis with laryngospasm, it can be helpful. So somebody is asking why there is altered sensorium. See, oxygen is decreasing in your body. So now you are typing because oxygen is being supplied to your brain. Cut off oxygen to your brain, you will experience what is altered sensorium. So this is for acute severe exacerbation treatment. Okay. So FeNO is not gold standard. Depo, it is not gold standard. It is an additional investigation. Again, it is a fancy and costly investigation. So how MgSO4 helpful? MgSO4 also has a bronchodilator property, remote bronchodilator property. Theophylline cause cardiac toxicity. So we'll take break for 15 minutes and we'll return. So how to prolong expiratory time? There will be a setting in the ventilator, you can increase it. Just turn the button. Asthma and COPD can happen if an asthmatic smokes later on. So PEFR, it has to be in the range of 80 to 100% of normal individual. Here it will be less than 50% of predicted, means less than 50% when compared to normal individual. Usual value is 70 to 80. So silent chest, your bronchus is completely closed. Whenever your bronchus is completely closed, air will not flow. So for sounds to appear to be heard, air should be flowing. So Montelukast, no role in active exacerbation. It has a role in stable asthma that I will discuss next. See, what I have discussed here is exacerbation of asthma. See here, this was a topic, exacerbation of asthma. So in stable asthma, we will discuss stepwise treatment later on. Okay. So welcome back. So up to now we have discussed asthma, exacerbation, presentation and treatment. But fortunately, majority of patients with asthma will not be in exacerbation. They will be routinely doing their day-to-day activities. with few symptoms and taking treatment accordingly. So such asthma not in exacerbation, it is called as stable asthma. Asthma not in exacerbation, it is called as stable asthma. Now let us see the classification and stepwise management of stable asthma. Classification and stepwise management of stable asthma. So stable asthma means the asthma that you can manage at home, asthma that you can manage in the community. So whenever he comes to the emergency department with excess symptoms, it is exacerbation. So stable asthma means what asthma that you can manage in the community. So here we divide it into intermittent and persistent. So based on patient's daytime symptoms. So during the day, so whether he is getting shortness of breath, cough, nighttime awakenings. So in the night, disturbed sleep is nocturnal awakening. So intermittent asthma, the classification, daytime symptoms less than 2 per week. So mild persistent, more than 2 per week, moderate persistent, daily, severe persistent throughout the day. Nocturnal awakenings, when you call it as intermittent, if the nocturnal awakenings are less than 2 per month, more than 2 per week. Sorry, less than 2 per month, less than 2 per week, more than 2 per week, daily. So this is classification and management of stepwise asthma. So daytime symptoms and nighttime awakenings. Now how to use this table? If at all they ask you a question like this, there was a patient with asthma who had daily daytime symptoms, and in a week he is getting disturbed sleep 3 nights. 3 nights in a week he is getting disturbed sleep. So what is the type of asthma? So daily in the daytime he is having symptoms, and in a week he is getting disturbed sleep 3 days. In a week he is getting disturbed sleep 3 days. So in a single week. So by seeing this table, daily daytime symptoms and disturbed sleep more than twice in a week, this comes under moderate persistent asthma. So this comes under moderate persistent asthma. Now how to treat these patients? So if it is intermittent asthma, I generally start step 1 management. If it is mild persistent asthma, step 2 management. According to the severity, I am going to increase these steps. Step 3 management. In severe, it will be step 4 management. Even after giving step 4 management, if patient not improving, I increase it to step 5. So there are actually 5 steps in management of asthma. So each and every step indicates increase in the severity of the disease. Now what are the drugs helpful in the management? So we have 2 types of drugs. So one is reliever and other is called as controller. So reliever means that which relieves bronchospasm. So most important relievers are bronchodilators, and the preferred bronchodilators in asthma will be beta-2 agonist. And in beta-2 agonist, we have short-acting beta-2 agonist SABA, long-acting beta-2 agonist LABA. You know the names of SABAs: salbutamol, albuterol, LABAs, formoterol, salmeterol. So this everything is covered in your pharmacology. No need to stress upon that. Short-acting beta-2 agonist, long-acting beta-2 agonist. And controllers or drugs which decrease the inflammation. most important controller in management of asthma is ICS. So what is meant by ICS? Inhaled corticosteroids. Along with that, we can also use anti-leukotrienes. So ICS, anti-leukotrienes. Anti-leukotrienes are nothing but montelukast. So this is the general drug therapy that we prefer for asthma. So bronchodilators preferred will be beta 2 agonist. Controller preferred will be inhaled corticosteroid, and along with that we can also give anti-leukotrienes. Then next important thing, if at any step patient develops acute symptoms or acute shortness of breath. So acute symptom here is shortness of breath. You should give a rescue therapy. Now suppose this fellow was an asthmatic, he was doing his routine work, suddenly he developed breathlessness because of some exposure of some allergen. So you should give a rescue treatment immediately to help him out. So according to the new guidelines, what is the rescue treatment preferred? So it is low dose inhaled corticosteroid, also written as LDICS. Along with that, formoterol. So with this combination, they found out there was decrease in exacerbation rate, and also better bronchoprotection. So previously, whenever a patient in community develops acute symptoms, so whenever somebody develops acute symptoms, so we were prescribing SABA. But according to new guidelines, now we should prescribe combination of low dose inhaled corticosteroid with formoterol. Now this is the combination of choice for rescue therapy. So why there was such a change in guideline? Now whenever I was giving SABA, I was only concentrating on bronchodilation. So now suppose this patient is in a faraway place from hospital. So now if I only give him SABA, there will be only bronchodilation. If at all next allergen reaches his lung, he might develop exacerbation. So it is not acting on inflammatory response. In asthma, not just bronchodilation is important, you should also decrease the inflammatory response. So you should provide protection to the bronchus so that next inflammatory response is not happening, patient is not going into exacerbation. So this low dose inhaled corticosteroid will decrease that inflammation and it will decrease the exacerbation rate. And why we are going for formoterol? So formoterol, actually it has also rapid onset of action. So SABA, it will act within 1 to 2 minutes, whereas formoterol, it will take 3 to 4 minutes. So even though formoterol is 3 to 4 minutes action, but it will stay there for 12 hours. So SABA, it will immediately act 1 to 2 minutes. Formoterol, it will also act fastly, but 3 to 4 minutes. It will take 3 to 4 minutes to act, but its action is prolonged. So because of that, there will be better bronchoprotection. So formoterol, one good thing is its action is prolonged and it will also act within a short time, 3 to 4 minutes. Now the question is, if at all a patient is in emergency department, so he has come with an exacerbation and he is sitting in the emergency department with respiratory distress. So there, what is the bronchodilator of choice? There, still it is SABA. So what is the reason? SABA starts its action within 1 to 2 minutes. So formoterol takes 3 to 4 minutes. In emergency situations, even that 1 or 2 minutes is very, very important. Emergency situation, even that 1 or 2 minutes is very, very important. So in emergency department, if they ask you what is the bronchodilator of choice, in the emergency department, if they ask you what is the bronchodilator of choice, still your answer is SABA. In emergency department, even that 1 or 2 minutes is very, very important for me. I go with SABA. Whereas in community, if patient develops rescue treatment, so he is in office, he suddenly develops asthma symptoms. So what is the rescue therapy of choice? It should be combination of low dose inhaled corticosteroid plus formoterol. He is developing acute symptoms at home. What should be the treatment here? Low dose inhaled corticosteroid plus formoterol. So in emergency department, it is SABA. Whereas in community, it is low dose inhaled corticosteroid plus formoterol. Low dose inhaled corticosteroid plus formoterol. So this is the recent update. Very, very important. So recently they have changed for rescue treatment in community in stable asthma. It is low dose inhaled corticosteroid plus formoterol. Now let us see in detail the stepwise management. So we have 5 steps in management of asthma. So you should divide this. So what if the patient develops acute symptoms at any step? And what is the maintenance therapy that should be regularly given? So what is the add-on therapy? Based on patient's affordability, it can be added for better control. So coming to the step 1, step 2, step 3, step 4, step 5. Point to be noted. Let it be at any step. If patient is developing acute symptom. See, formoterol is a long-acting beta-2 agonist. See, its action is fast, but its action is also prolonged. So it is a long-acting beta-2 agonist. So it acts for long-acting beta-2 agonist. So don't say SABA should not be used in community. So preferred is this. So preferred is low dose inhaled corticosteroid and formoterol. So if you just give SABA, the next patient is not completely protected. He's not completely protected. Okay. So preferred is low dose inhaled corticosteroid plus formoterol. So it has anti-inflammatory action and prolonged bronchoprotection. So SABA is not contraindicated. So the best in community is low dose inhaled corticosteroid plus formoterol. So in emergency department, we go for SABA generally. So if patient develops acute symptoms at any point, he should be given as needed rescue medication. So what is the rescue medication? Low dose inhaled corticosteroid plus formoterol. Low dose inhaled corticosteroid plus formoterol. Then maintenance treatment. So maintenance treatment. Step 1 is only intermittent asthma. So whenever patient develops symptoms, this rescue medication is sufficient. So intermittent asthma, so rescue medication is sufficient. So step 1 is intermittent. So if patient develops symptoms on that day, give treatment. No need to give regularly. From step 2 onwards, you should give regular treatment because step 2 deals with treatment of persistent asthma. Step 2 deals with treatment of mild persistent. So it is persistent. So regular treatment is required. So in step 2, we add daily low dose inhaled corticosteroid. So I ask the patient daily morning and evening he should take a inhaler puff of low dose inhaled corticosteroid. Now the question is, in the afternoon, if the patient develops shortness of breath, what should be given? In the afternoon, if the patient develops shortness of breath, do not hesitate to give rescue medication. If patient develops acute symptoms, give rescue medication. See, I think you should be knowing a drug called as sorbitrate in cardiology. So sorbitrate, in few patients it will be given regularly. Morning and evening they will be taking sorbitrate. And doctor will advise that in between also, if you feel any chest pain, immediately take a sorbitrate. In the same way, rescue medication is as on when needed. If patient feels some respiratory discomfort, immediately he can take that rescue medication. So daily morning and evening he will be using low dose inhaled corticosteroid in step 2. So in between, if it develops any issue, he can use that rescue medication immediately. In step 3, we give daily low dose inhaled corticosteroid along with that LABA. In step 4, if patient is not improving with above combination, I increase the dose of low dose to medium dose. So medium dose inhaled corticosteroid plus LABA. And in step 5, daily high dose inhaled corticosteroid plus LABA. So even with this treatment, if patient is not improving at this level, so refer the patient to a specialist center. So refer a patient to a specialist center. And what do you do in specialist center? We give biological therapy that I will discuss. So step 5, I increase it to high dose inhaled corticosteroid along with that LABA. So even with this treatment, if patient is not improving, we refer to a specialist center. And what do they have in specialist center? They have facility for giving biological treatment. Now coming to add-on therapy. So this is not compulsory. So based on the patient's affordability, you can add some drugs for better control. So in step 2, I can add anti-leukotrienes. In step 2, you can add anti-leukotrienes. In step 3 also, along with this combination, I can give anti-leukotrienes. In step 4, we can give anti-leukotrienes as add-on therapy. Along with that, I can give tiotropium. So what is tiotropium? It is big brother of ipratropium. Long-acting muscarinic antagonist. And in step 5, I can continue tiotropium. Along with this, I can add oral steroid. So in the old guidelines, oral steroid was actually included in this maintenance therapy. But because of side effects of oral steroids, now it has been changed only to add-on treatment. So this is the sequence. So step 1, step 2, step 3, step 4, step 5. Now biological treatment, what are the options available? So we have anti-IgE. So anti-IgE, it is omalizumab. Anti-IL-5. So we have two important drugs, mepolizumab, racilizumab. So there are other drugs, but these are only available up to now in India. So the available in India will be asked mostly in your exam. Anti-IgE, omalizumab. So this IgE, IL-5 are important mediators for inflammation in asthma. If you block this, there will be response, and it is reserved for patients not improving with step 5 treatment. Anti-IgE, omalizumab. Anti-IL-5, mepolizumab, racilizumab. See how much is low dose? It will not be asked in your exam, but if you want for extra information, I'll tell you here. So 200 to 400 micrograms of budesonide is generally considered as low dose. 200 to 400 micrograms. So benralizumab is not available in India. So mast cell stabilizers, not that effective. These are most effective treatment. Mast cell stabilizers are used in exercise induced asthma. Okay. So Abhishek, steps based on FEV1. So here I have clearly showed how we are giving steps. It is based on patient's symptoms. So intermittent asthma, step 1, mild persistent, step 2, moderate persistent, step 3, severe persistent, step 4, based on patient's treatments. See, add-on therapy is optional, based on patient's affordability. See, budesonide, fluticasone also you can give. That is also a different type of. See, there are so many steroids: budesonide, fluticasone, mometasone, seclisonide. So initially we start with budesonide. So you can give at that step on. No issue in giving add-on treatment. So if you find patient is affordable, you can add then and there itself. Okay. So this is the general management. So according to patient's clinical scenario, we add this treatment. So if a patient is having moderate persistent, we give step 3. So daily low dose inhaled corticosteroid with LABA. Along with that, we can add anti-leukotrienes. It is optional. So generally we give treatment for 2 months. So once the patient is improving, we gradually taper in the span of 1 month. So generally this treatment we continue for 3 months at least. Okay. Now suppose there was a young female who has come to your clinic. So she was having asthma symptoms. So you have diagnosed it to be mild persistent asthma and you have prescribed her on daily low dose inhaled corticosteroid. Listen, this question very important. You have prescribed her on daily low dose inhaled corticosteroid and you have clearly told that use low dose inhaled corticosteroid regularly morning and evening, and in between if you get any problem you can use the rescue medication. And she was super rich. You also have prescribed anti-leukotrienes. After 2 days she comes back to your clinic, throws inhalers on your face telling that her asthma symptoms are not improving. So she starts abusing you. What will you do next? So you have put a patient effectively on step 2 treatment. Effectively on step 2 treatment. A super rich, arrogant young female on step 2 treatment. And she is coming back to your clinic telling that her asthma symptoms are not improving. What will you do next? So what will you do next? So what will you do next? Yes. So will you go to step 3 management or will you do something else? Will you go to step 3 management or will you go to something else? See, whenever you are thinking of increasing the management or increasing the dose of any drug in asthma, always check her inhaler technique. Always check her inhaler technique. So because the problem is majority of medications in asthma are given through inhaler. If the patient is not taking inhaler properly, whatever dose you increase, it will not go into the lung. That's why most important in asthma management is patient education. So patient should know how to use inhaler properly and they should regularly use the inhaler. I'll tell you why education is very important. If you don't educate patient properly, things like this will happen. So actually inhaler should be used like this. So if you don't treat the patient properly, so if you don't teach the patient properly, so they will start using this and they will abuse the doctor that your medication is not working properly. So most important is patient education. Active self-management and adherence. So patient should know how to use inhaler, when to use inhaler and regularly use inhaler. Now who are these people? Beckham, Amitabh Bachchan and Priyanka Chopra. Yes. What is common in them? Their asthma. You can see Beckham taking an inhaler puff before attending penalty shootout. So what is the asthma that I am going to discuss, especially in athletes? It is exercise induced asthma. So write down exercise induced asthma. In susceptible individuals, exercise can induce asthma. So this is more during cold and dry climates. So this type of asthma occurs more during cold and dry climates. So what they will ask you in exam? They will ask you, what is the drug of choice for short-term prophylaxis? And what is the drug of choice for long-term prophylaxis? And overall control of disease. Overall control of disease. So somebody is asking Chiranjeev Singh, how can an asthmatic play football? If his doctor is ineffective, he cannot play football. If his doctor is effective, he can play any game, whatever he wants. So that's why you are studying MBBS, to make even patients with disease like asthma, to control their asthma and give them good life. Okay. So what is the drug of choice for short-term prophylaxis? So what is the drug of choice for long-term prophylaxis and overall control of disease? Now, drug of choice for short-term prophylaxis. Now, Beckham needs to attend a penalty shootout. He is worried he is going to develop asthma. So what is one drug that should be given prior to avoid bronchospasm? So give him a short-acting beta-2 agonist. So that will stay in the lung for 4 to 6 hours. He can easily complete his exercise and come back without any problem. So drug of choice. So drug of choice for short-term prophylaxis is short-acting beta-2 agonist. Short-acting beta-2 agonist. If it is not given in the option, next best answer is anti-leukotrienes. In few countries, they also give mast cell stabilizers. But for all practical purposes, drug of choice for short-term prophylaxis in exercise-induced asthma is short-acting beta-2 agonist. But whenever they ask long-term prophylaxis and overall control of the disease, always long-term prophylaxis and overall control is by decreasing the inflammation. It is inhaled corticosteroid. So drug of choice for short-term prophylaxis, SABA. If it is not given in the option, next best answer is anti-leukotrienes, mast cell stabilizers. Drug of choice for long-term prophylaxis and overall control of disease is inhaled corticosteroid. Next, we are going to discuss about a drug which causes asthma. Can you tell me what is the drug that causes asthma? Yes, drug that causes asthma. It is aspirin. So write down aspirin-induced asthma. So in susceptible individuals, aspirin blocks cyclooxygenase path and shifts balance towards lipooxygenase path. So whenever lipooxygenase path is happening, there will be increased production of leukotrienes. That will result in bronchospasm. So in my body there is a substance called as arachidonic acid. Arachidonic acid. So this arachidonic acid is either metabolized through cyclooxygenase path. So when it is metabolized through cyclooxygenase path, what is the end product? Prostaglandins. If it is metabolized through lipooxygenase path, the end product here will be leukotrienes. End product will be leukotrienes. So aspirin in susceptible individuals, what it will do? So it will block this cyclooxygenase path. Aspirin will block this cyclooxygenase path, and not just blocking this cyclooxygenase path, it will shift the balance completely into lipooxygenase path. So whatever arachidonic acid is left, everything will be converted into leukotrienes. So whenever leukotrienes increase, what will happen? There will be bronchospasm. Now coming to the treatment. So treatment will be combination of inhaled corticosteroids, inhaled beta-2 agonist, along with that anti-leukotrienes. So whenever I say regarding aspirin-induced asthma, you should be knowing about a combination. So what is this combination? Nasal polyps, asthma and aspirin sensitivity. So what is this combination also called as? It is called as Samter's triad. So leukotrienes or inflammatory mediators which will cause bronchospasm. The name itself is leukotriene. Histamine, leukotriene, serotonin. These are inflammatory mediators. Okay. So this is regarding aspirin-induced asthma. In susceptible individuals, what will aspirin do? Aspirin is going to block this cyclooxygenase path. Because this cyclooxygenase path is not happening, all the arachidonic acid will get converted into leukotrienes. If leukotrienes increases, what will happen? There will be bronchospasm. Previously in aspirin-induced asthma, 2 questions were asked. So what is the mediator responsible for aspirin-induced asthma? The mediator responsible is leukotriene. So leukotrienes are responsible for aspirin-induced asthma. The mediator is leukotrienes. And what are the components of Samter's triad? Nasal polyps, asthma and aspirin sensitivity. Nasal polyps, asthma, aspirin sensitivity. Next we have a very important asthma called as brittle asthma. So only little is known about this brittle asthma. Let us discuss this. So this is an unpredictable asthma with exacerbations. So this is an unpredictable asthma. So you don't know what will happen next in this patient. This is an unpredictable asthma with exacerbation. So based on the presentation, it is classified into 2 forms. So we have type 1 brittle asthma and other is type 2 brittle asthma. So type 1 brittle asthma and other is type 2 brittle asthma. So let us see in detail. So to understand brittle asthma, you should first understand the normal lung function. So let this be the type and let this be patient's lung function. Let this be 0% lung function, 50% lung function, 100% lung function. In a normal individual, his lung function with time will not fluctuate much and it will be nearer to 100. So this is how a normal person's lung function vary with them. It will not fluctuate much. It will be nearer to 100%. Now, in type 1 brittle asthma, so LOX means lipooxygenase, COX means cyclooxygenase. So in type 1 brittle asthma, there will be rapid and frequent fluctuations in lung function. So his lung function will be normal decreasing. It will be like this, resulting in exacerbations. So there will be frequent fluctuations in lung function. Frequent fluctuations in lung function with exacerbation. So every week, once or twice, he will be coming to the emergency department. Frequent fluctuations in lung function with exacerbation. So the treatment. So because this patient is always at risk of developing exacerbation, you should give whatever available treatment of highest step. So what is the highest step of treatment? 5th step. So we give here high dose inhaled corticosteroid. And this patient requires continuous beta-2 agonist. So he will be taking inhaler puffs continuously. Along with that, we can also add oral steroid. So type 1 brittle asthma, frequent fluctuations in lung function with exacerbation. Now type 2 brittle asthma, what happens is, this patient initially will have a near normal lung function. But suddenly one day his lung function will decrease, and in few it can also cause death. So in type 2 brittle asthma, there will be near normal lung function. Initially near normal lung function, followed by sudden decline, that can also result in death. So this is a very, very rare type and dangerous type. So the exact reason is not known. They thought it was due to some severe airway anaphylaxis. So severe airway anaphylaxis. So what must have happened in this patient? So that allergen must have caused a severe airway anaphylaxis. So if it is asthma, it is only bronchospasm. My body can easily fight against bronchospasm. If it is severe airway anaphylaxis, there is a dangerous complication called as laryngospasm. So my body cannot fight with laryngospasm. It can give up and result in death. If at all you find a patient in this condition, here the treatment will be, for any anaphylaxis, injection adrenaline. So patient presenting with laryngospasm like condition, it is injection adrenaline. So they have asked previously, what is the drug of choice in type 2 brittle asthma? Your answer should be adrenaline. And they can ask you the trend. In type 1 brittle asthma, there will be frequent fluctuations in lung function. Frequent fluctuations and lung functions with exacerbation. See here, always patient's lung function will be fluctuating like this. Whereas in type 2 brittle asthma, patient can have near normal lung function and sudden decline, and it can result in death. This brittle asthma, still we don't know what exactly is the mechanism. So this disease is not yet understood well, but they can ask you the questions. So what do you see in type 1 brittle asthma and what do you see type 2 brittle asthma? So somebody is asking how to differentiate between them clinically. So type 2 brittle asthma, before he will not be having any symptoms, sudden decline and death. Type 1 brittle asthma, always he will be having on and off symptoms. On and off symptoms. So try to solve this question. So a 32-year-old female, so this is the same female here, with a history of intermittent wheezing in response to exercise, presence to the emergency room with shortness of breath. So she was taking an aerobics class At this point, she is having difficulty in breathing and has diffuse wheezing. Diffuse wheezing. So the most effective treatment at this point will be. So tell me the answer. Most effective treatment. Yes. Most effective treatment. So how to differentiate this from normal severe acute asthma? It's difficult. It's difficult to differentiate. Yes. So what is the answer here? So no need to discuss about her age. Tell me the answer. So think well. So this patient has developed exercise-induced asthma and she has come to emergency department. So she has come to emergency department because of acute symptoms. She is having difficulty in breathing, diffuse wheezes. So when there is difficulty in breathing, diffuse wheezes, she is in emergency department. What will you give next? Inhaled short-acting beta-2 agonist. So the best treatment here is SABA. So aminophylline we don't give. In acute episodes, oral leukotrienes, cromolyn, sodium. See, in acute episode you should give bronchodilator. She is having wheeze. She is feeling difficulty in breathing. So what should be given? A bronchodilator, a short-acting bronchodilator in the emergency department. So best answer is option C. Best answer is option C. So many people ask me what is Achedin for medicos actually, especially male medicos. So if you are an UG, this will be your position. So always you have to lift lot of scrap. So you will be having exams, you will be having duties, and you don't know what exactly is your relationship status. So Achedin for you is becoming a postgraduate. So once you become a postgraduate, everybody will be around you. You will have a lot of friends with benefits. That is secondary. So this is actually the Achedin for medicos. So we don't know when it will come. Let us hope for this. Have a great day thinking about this Achedin. Now what is this disease? So this patient is a chronic smoker. This patient is a chronic smoker and ultimately his lungs are getting affected like this. Ultimately his lungs are getting affected like this. So what is this disease that we are going to discuss? COPD, chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease. So write down regarding COPD. So we have chronic bronchitis. So chronic bronchitis and emphysema. So there are two subtypes in COPD, chronic bronchitis and emphysema. So chronic bronchitis, there will be cough with expectoration for 3 months. So for 3 months, cough with expectoration for 3 months for 2 consecutive years. So for 2 consecutive years associated with mucus gland enlargement. Associated with mucus gland enlargement. Whereas emphysema is destruction distal to terminal bronchiole. Distal to terminal bronchiole. So Agastya Saxena, why don't we give rescue treatment? It's not there in the option. She is in emergency department, you should first give a SABA. It is not there in the option also. So emphysema is destruction distal to terminal bronchiole. This is called as acinus. So these are the definitions of COPD, two subtypes, chronic bronchitis and emphysema. So previously we were seeing chronic bronchitis and emphysema as two different entities. But recently, they told that let it be chronic bronchitis or emphysema, it should be called with a single name called as COPD. So no longer you should use those old names, chronic bronchitis, emphysema, for clinical purposes. So for all clinical purposes, it should be called as COPD. See, the diagnosis is COPD. It will be diagnosis of COPD, complications of COPD, and treatment of COPD. So there is no separate treatment for chronic bronchitis and emphysema. So it should be called as a single entity called as COPD. So the new guidelines tell that for all clinical purposes, you should call either chronic bronchitis or emphysema with a single name for COPD. So it will be treatment of COPD, complications of COPD, diagnosis of COPD. Now write down what are the risk factors for development of COPD. What are the risk factors for development of COPD? So first important is smoking. So in majority, most common is smoking. Next is a genetic disease, alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. It is a genetic disease, so it will be mediated by a chromosome. So chromosome 14 is affected, and because it runs in families, there will be already family history of COPD, and these patients will be young. Because it is a genetic disease, generally they present at young age onset of COPD. And here less smoking history but COPD, less smoking history but COPD. And next important thing is alpha-1 antitrypsin deficiency can also involve the liver. There will be associated liver disease also. So how is alpha-1 antitrypsin deficiency different from smoking related COPD? So these patients will have family history. Because it is a genetic disease, it runs in families. Generally for smoking to cause COPD, it will take 20 to 30 years. If the patient starts smoking at the 20th year, it develops COPD at his 50th year. So here patient age is just 20 but still fully blown out COPD. It means something is happening since his birth resulting. So that happening since birth is alpha-1 antitrypsin deficiency. And patient is not a smoker or he just started smoking, he develops COPD. So one cause is alpha-1 antitrypsin deficiency. And alpha-1 antitrypsin deficiency also involves the liver and it can also have some liver disease. Next important is pollution. So pollution. So pollution, we all know about outdoor pollution. In India, especially in villages, females are developing COPD. So why is it due to indoor pollution? Because they use biomass fuel for cooking. So burning of biomass fuel will result in smoke. So that smoke when inhaled can also cause COPD. And an occupation, coal exposure, can also result in COPD. Coal exposure can also result in COPD. So coal exposure can also result in COPD. So most important risk factor is smoking, alpha-1 antitrypsin deficiency, pollution, outdoor pollution, indoor pollution. So coal exposure. So Sana Mirza, did I tell about Zina guidelines? Whatever guidelines I have spoken, it is Zina guidelines only in asthma. So stepwise management, everything is Zina guidelines. I told you in the beginning also, whatever guidelines I say in asthma, it is Zina. Whatever treatment I say in COPD, it is gold guidelines. So no need to again label it everywhere, Zina, gold, Zina, gold. Already I told in the beginning only. So smoking is most common risk factor for development of COPD. Genetic disease is alpha-1 antitrypsin deficiency. Others we have outdoor pollution, indoor pollution, coal exposure. Associated liver disease, there can be hepatitis, there can be later on cirrhosis, yes, So clinical presentation in emphysema. So Parash, you open your notes. Yesterday I have discussed pathophysiology of emphysema. Just open it, you will understand. So there will be impaired oxygenation. So there will be barrel shaped chest. Patient will have shortness of breath. Okay. It's all discussed yesterday. So already yesterday we have discussed the pathophysiology of emphysema. We have discussed why the lung volumes have increased. So what is the problem with diffusion? Why there is hypercapnia? Why there is barrel shaped chest? It was all discussed yesterday. So now coming to diagnosis of COPD. Diagnosis of COPD. So diagnosis of COPD. See, alpha-1 antitrypsin deficiency, it causes COPD, predominantly emphysema. So because people like Akshay will ask chronic bronchitis, what is emphysema, you will confuse and finally will stop treating the patient. So that's why for all clinical purposes, I should not use chronic bronchitis and emphysema. So now I am discussing respiratory medicine proper. Yesterday it was physiology, pathophysiology. There I have used the terms emphysema. In respiratory medicine proper, you should call it as COPD and you should treat it, let it be chronic bronchitis or emphysema, the treatment will be the same. So diagnosis of COPD, if you do spirometry, there will be obstructive pattern. So when do you call it as obstructive pattern? FEV1 by FEC less than 0.7. And even asthma is obstructive pattern. How is COPD different? So in COPD, it is a persistent disease. So there will be no significant bronchodilator reversibility. So when do you call it a significant bronchodilator reversibility? After giving a bronchodilator, FEV1 will increase more than 12%. So in COPD, it is that much increase is not seen. Now coming to gold staging. So gold staging of COPD. So COPD can be divided into stage 1, stage 2, stage 3 and stage 4. So stage 1 is mild COPD. Stage 2 is moderate COPD. Stage 3 is severe COPD. Stage 4 very severe COPD. So gold staging, stage 1, stage 2, stage 3, stage 4. So in all this, the common feature is the ratio. So FEV1 by FEC will be less than 0.7. So in all this, the common feature is FEV1 by FEC will be less than 0.7. Then on what basis is it classified? It is classified on the basis of patient's FEV1. In stage 1, patient's FEV1 will be more than or equal to 80% of predicted FEV1 of the given age. So again you will start asking, sir, it is more than 80%. So it is not 80% of FEC. It is 80% of normal FEV1 of that age. It is 80% of normal FEV1 of that age. Stage 2. FEV1 in the range of 50 to 79% of predicted FEV1. FEV1 30 to 49% of predicted. FEV1 less than 30% of predicted. Recently asked question, which of the following qualifies for very severe COPD? Your answer should be FEV1 less than 30% of normal FEV1 of that given age. Apart from this, for COPD, there is a prognosis index. So this is an old index, not used nowadays, but they can ask you as a question, prognosis index. So prognosis index, it is called as BODE index, BODE. So B stands for BMI, body mass index. O stands for amount of obstruction in the airways. This can be known by patient's FEV1. D stands for dyspnea. This can be known by patient's symptoms. E stands for exercise capacity. So how do I calculate the patient's exercise capacity? By the distance covered in 6-minute walk test. Distance covered in 6-minute walk test. So distance covered in 6-minute walk test. So they will just ask you the variables used in BODE index. So you should know B stands for BMI, body mass index. Body mass index. O stands for obstruction. D stands for dyspnea. E stands for exercise capacity. E stands for exercise capacity. So this is BODE index. So they'll ask you only the variables. So this index is an old index, not used nowadays. So just know the variables. B for BMI, O for obstruction, D for dyspnea, E for exercise capacity. And exercise capacity, how do you calculate? Distance covered in 6-minute walk test. So there are usually distance is calculated by meters, not steps. Meters. See, this 80% is not 80% of FEC. Again, I have repeated again. It is 80% of predicted FEV1 of that given age. You are not comparing it with FEC. You are comparing it with FEV1 of that age. So that is a complex calculation. So when you compare it, if it is more than 80% of predicted FEV1, that comes under stage 1. Now coming to treatment. So treatment of COPD. So out of all the management, which is considered as most important in treatment of COPD? So most important in treatment of COPD. Yes, what is most important in treatment of COPD? It is smoking cessation. So smoking cessation is considered as most important in COPD. Most important in COPD. Why smoking cessation is considered as most important in COPD? So the reason is simple. What starts COPD? Smoking. So if at all a patient is continuing to smoke, there will be continuous inflammatory damage. So smoking continuously damages the lung. So if a patient is continuously smoking, it causes continuous inflammatory damage. Second reason is whenever a patient is actively smoking, so whatever medications you take, it will not function properly in that environment in the lung. So whenever I want to treat a COPD, first thing what I should advise is not drugs, not oxygen, not transplantation. It is simple smoking cessation, which is difficult of all. Now next is, whenever I ask the patient to stop smoking, he will tell that I'll stop tomorrow, but you give me some drugs so that my symptoms will be reduced. So I have to prescribe few drugs to decrease his symptoms. Bronchodilators. So bronchodilators. So which bronchodilators will be more helpful in COPD? So it is bronchodilators. Is it short acting or long acting? See, in the initial phase of the disease, short acting may work. But once the disease is progressing, this is a persisting disease. So he should have long acting bronchodilators as of treatment. So bronchodilators, we can give long acting beta 2 agonist, long acting muscarinic antagonist. So long acting muscarinic antagonist available are tiotropium. umeclinidium, 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 glycopyrronium, glycopyrronium. Now coming to long-acting beta-2 agonist, you know the conventional long-acting beta-2 agonist, solmetrol, formoterol. So better than that, we have ultra long-acting beta-2 agonists. So the advantage of ultra long-acting beta-2 agonist is once a daily dose. So they function for about 24 hours. Say solmetrol or formoterol, the duration of action is 12 hours. So patient has to take twice. Ultra labas, the duration of action is 24 hours. So what are these ultra labas? Indacaterol, indacaterol, olodaterol, indacaterol, olodaterol, vilanterol, vilanterol. So these are the important bronchodilators. These are the important bronchodilators. So next important in treatment is steroids. So when to give, what to give, where to give. So steroids, either we can give systemic steroids. Systemic steroids means tablets or injection. Systemic steroids or inhaled corticosteroids. So systemic steroids can be given during acute exacerbation. So systemic steroid can be given during exacerbations. So because of some inflammatory damage, patients can worsen. Because of smoking related inflammatory damage, patients can worsen. So to bring down that exacerbation, you can give systemic steroids during acute exacerbation. So once the patient recovers from an acute exacerbation, there will be chances of re-exacerbations. So to decrease frequency of exacerbations, patient can be put on inhaled corticosteroid to decrease frequency of exacerbation. So now if they ask you one question, what is preferred bronchodilator? What is preferred bronchodilator in COPD? So in asthma, preferred bronchodilators were beta-2 agonists. In COPD, preferred bronchodilator will be long-acting muscarinic antagonist. So long-acting muscarinic antagonist will be preferred bronchodilator. And it is also most important bronchodilator in management of COPD. So what is the reason why LAMA is called as preferred bronchodilator? So there are most important reason is it will cause bronchodilation. Second is recent studies have shown that LAMA can also decrease smoking related inflammation. So LAMA can also decrease smoking related inflammation. So there are two actions of LAMA. So first is bronchodilation. So first is bronchodilation and second is it can also decrease inflammation in the lung. Not as effective as steroid, but it has some role. So if they ask you what is the preferred bronchodilator in COPD, your answer is LAMA. So LAMA, apart from bronchodilation, it can also slightly decrease inflammation in the lung, which is helpful in the patient. And these patients may have cough with thick sputum. So to break this sputum, we give mucolytics. So mucolytics such as N-acetylcysteine. N-acetylcysteine. And next important is there is a new drug in management of COPD. So it is PDE4 inhibitor. So PDE4 inhibitor. So the name of the drug is roflumilast. So this drug can also decrease frequency of exacerbation. So this drug can also decrease frequency of exacerbation. Then what is the role of antibiotics? See, whenever we were discussing asthma, we never discussed about antibiotics in asthma. So because asthma, even though there is an exacerbation, it is generally due to viral infection. So if exacerbation happens due to infection, there it is due to viral infection such as rhinovirus. So rhinovirus is something that causes your common cold. So for common cold, no need to give any antibiotic. But if at all an infective exacerbation happens in COPD, so infective exacerbation happens in COPD, it is generally due to bacteria. So to overcome that bacterial infection, you should give antibiotics. So antibiotics are given during acute exacerbations. Antibiotics are given during acute exacerbation. And what is the most common bacteria? So mucolytics are available as tablets. Most common bacteria is H. influenza. Most common bacteria is H. influenza. Then, if at all, then recently they have found out these COPD patients were getting frequent infections and exacerbations. So according to new guidelines in COPD, once the patient recovers from exacerbation, we give him azithromycin prophylaxis. So in a week, 3 days, we give azithromycin prophylaxis. So why we give azithromycin prophylaxis in this COPD patient? To decrease frequency of further exacerbations. So to decrease worsening in this patient. And next important thing, if there is hypoxemia, if at all patient's oxygen level has decreased, so this patient requires long-term oxygen therapy. So long-term oxygen therapy. So long-term oxygen therapy means 14 to 15 hours per day. So patient requires 14 to 15 hours per day, and we generally give low flow oxygen. So we don't give 5 to 10 liters. We give 2 to 3 liters. And what is the target saturation in these patients? So will you maintain it 95? No, target saturation is 88 to 92%. So in COPD patients, you give low flow oxygen and your goal is not to bring saturation to normal. Saturation should be near normal, 88 to 92%. Now, is there any surgery available for COPD? Yes. So we have lung volume reduction surgeries. So lung volume reduction surgeries. We can also perform an important surgery called as bullectomy. You know that in COPD, there are some hyperinflated areas called as bullas. So these bullas actually will not take part in gaseous exchange, but can apply weight on the diaphragm, not allowing the diaphragm to move properly. All these hyperinflated areas can apply weight on the diaphragm, not allowing the diaphragm to function properly. So by removing those hyperinflated areas, the weight on the diaphragm will be decreased. So because of that, diaphragmatic function and respiratory mechanics can improve. So by doing lung volume reduction surgery, you can improve the diaphragmatic activity and also you can improve the respiratory mechanics. And next important thing is, if everything fails, this patient is a candidate for lung transplant. This patient is a candidate for lung transplant. As of now, most common indication for lung transplant worldwide is interstitial disease. Next important disease responsible is COPD. So previously, COPD was the first indication. Now ILD has surpassed it. So for lung transplant, if they ask you most common indication worldwide, the first disease is ILD, second disease is COPD. Now even after telling all this to the patient, this patient will not stop smoking, and one fine day he reaches the emergency department with an exacerbation. So during exacerbation, so he reaches the emergency department with exacerbation and respiratory failure. So what will be the initial preferred method of ventilation? So in COPD exacerbation, what will be the initial method of ventilation, preferred method? Will you go directly for IMV or will you go for NIV? I go for non-invasive ventilation. So initial preferred is non-invasive ventilation. So if patient not improving, if patient not improving, if patient not improving, next important thing, we go for invasive mechanical ventilation. But what are the disadvantages of invasive mechanical ventilation? Increased chances of ventilator associated pneumonia, increased chances of pneumothorax. So this ventilator associated pneumonia, pneumothorax ultimately can increase mortality in the patient. So mortality in the patient, mortality in the patient. So Verma, what do you want elaboration on lung transplant? So emphysema, the lungs are damaged, there is destruction of the lung parenchyma. So you just transplant the lungs. So bilateral lung transplantation can be done. Okay. So even for cystic fibrosis, you can do lung transplant. I told you two conditions where lung transplant is done. So in fully blown out ILD and COPD. So lung washing and lung detox is a famous procedure followed by WhatsApp experts. So you can learn about it if you graduate in WhatsApp University, lung detox and lung washing. Okay, so this is one slide that I focus everywhere in my classes, because this is not just a treatment of COPD, it is progress of a patient with COPD. So whenever I prescribe this patient, bronchodilators, steroids, mucolytics, antibiotics, all this will cost him about 4,000 per month. So if I prescribe him oxygen, it will cost about 40,000. Lung volume reduction surgery will cost him about 4 lakhs. Lung transplant will cost him about 40 lakhs. Exacerbation can cost him his life. All this can be prevented if he stops 40 rupees on cigarettes every day. All this will be prevented if he stops 40 rupees on cigarettes every day. So smoking cessation, that's why it is very, very important. If he stops smoking, he can decrease the progress of the disease. So very important here is during exacerbation, initial preferred method in COPD is NIV. So if patient is not improving with NIV, only as a last resort, invasive mechanical ventilation is done. But there is a disadvantage with invasive mechanical ventilation. What is the disadvantage? Increased chances of ventilator associated pneumonia, increased chances of pneumothorax. So already patient is sick. If at all some pneumonia or pneumothorax occurs, there will be mortality. Now coming to new classification of COPD, new algorithm of COPD. This is called as COPD ABCD assessment. So this is new in gold guideline, COPD ABCD assessment. So this algorithm is based on a graph. On one side we take patient's symptoms. On other side we take patient's exacerbation history. How many times this patient has worsened in a year. So symptoms, I am going to divide this into two. So patients with less symptoms, patients with more symptoms. So when do you call a patient is having more symptoms? If he is having shortness of breath even at rest. So patient is just sitting quietly, still he is having shortness of breath. It is called as more symptoms. More symptoms means shortness of breath even at rest. Shortness of breath even at rest. Then exacerbation history, it can also be divided into less exacerbations, more exacerbation. So less exacerbation means in the last 1 year, patient is having 0 or 1 non-severe exacerbation. 0 or 1 non-severe exacerbation. So more exacerbation means in the last 1 year, patient is having more than 1 non-severe exacerbation or more than or equal to 1 severe exacerbation. Now how do you differentiate between non-severe and severe exacerbation? So severe exacerbation means that which is resulting in hospitalization and ICU admission. So when do you call it as a severe exacerbation? Patient is requiring hospitalization and ICU admission. Non-severe means patient may just come to the emergency department, take some treatment, and sometimes he may go back. So non-severe, severe exacerbation means that which is requiring hospitalization and ICU admission. So based on patient's exacerbations and based on patient's symptoms, we have done a graph. Now I am going to draw a line like this. So his exacerbations I have divided like this, and his symptoms I have divided like this. So now if you see, there are 4 compartments. Now if you see, there are 4 compartments. So you can name the compartments as Group A, Group B, Group C, Group D. So Group A, it indicates patient is having less symptoms, less exacerbations. Group D, more symptoms, more exacerbations. Now out of these 4, which group has good prognosis? So which group has good prognosis? Now we are having 4 groups. Which group has good prognosis? It is Group A, because patient is having less symptoms and less exacerbation. Which is most problematic group? It is Group D, because patient is more symptomatic and frequently is reaching the hospital for treatment. He is having more exacerbations. Now we have made this into 4 groups. So just like in asthma, we had stepwise management. Step 1, step 2, step 3, step 4, step 5. Now recently for COPD, we are having group wise management. Let us see what treatment can be helpful. So this is a very early COPD. Just a bronchodilator will be sufficient. So a bronchodilator, only a bronchodilator. Initially I try with short acting. So I can give SABA or SAMA. So SABA or SAMA. Whereas in Group B, I should give a long-acting bronchodilator. I should give a long-acting bronchodilator. So definitely I should give a long-acting bronchodilator. So long-acting bronchodilators, either LABA or LAMA. So either LABA or LAMA. Whereas in Group C, I should give the most preferred bronchodilator. What is the most preferred bronchodilator in COPD? It is LAMA. So in Group C, I have to give LAMA. I have to give LAMA. So in Group D, so these are the most problematic patients. So Group D are the most problematic patients. So my majority of treatment expertise should be concentrated on these patients, because in COPD there is a risk of exacerbation, and each time patient is admitted with exacerbation, there are chances of death. So these Group D patients are having highest risk of death. So I should concentrate on this patient. So why I am dividing in these groups is to concentrate my treatment very well on group D. So here I start LAMA. And I observe the patients. So if at all patient's symptoms are not improving, so still he is having the same symptoms as before, not even some decline. If symptoms not improving, he's just saying, sir, how much breathless I was previously, now also I am the same. There is no effect in your treatment. So what I do is I combine LAMA plus LABA. So if patient symptoms are not improving, I combine LAMA plus LABA. I give 2 bronchodilators to provide him better effect. Now, if at all in this patient, if there is history of asthma, so somebody was asking, so what if the patient is having asthma, can he develop COPD? So this fellow, previously he might be asthmatic. He started to smoke. Now he develops COPD. Now in his lungs, there are both components, asthma and COPD. And in these patients, if you see, in asthma, eosinophils will be elevated. So and eosinophil count in the blood is more than 300 per mm³. So if history of asthma or eosinophil count or eosinophils more than 300 per mm³. So eosinophil count will also give indirect evidence of there is some allergic response in the body. If history of asthma or eosinophils are more than 300 per mm³, so this patient should be given LABA plus ICS. So just like asthma, you should treat him properly. You should give a bronchodilator and you should definitely give steroid. So LABA plus ICS, LABA plus ICS. And this group D patients are having highest risk of death. So here you should add additional drugs. You can consider in this group D. So in this group D, you should consider adding roflumilast. And also you should start azithromycin prophylaxis. Azithromycin prophylaxis. So group D is very sick COPD patients, so who have tendency to go into exacerbation, So in group A, the problem is less symptoms, no need to give ICS here. So LAMA plus ICS not that effective. ICS works well with beta 2 agonists. ICS may not work properly with LAMA. So first we give LABA plus ICS. If it is not working, then we give LABA plus LAMA plus ICS. So if I give all the 3, it will be problematic for the patient. There will be some adverse effects. Okay. So this is the manner. See, whenever I treat a patient, if I am having 10 drugs useful for that disease, it doesn't mean I should give all the 10 drugs. I gradually increase it as a combination. If at all patient is not improving on the initial combination, I go to the next combination. Yes, we need to shift from LAMA to LABA plus ICS. So for asthma, LABA plus ICS works properly. And for COPD, LABA is there, it will take care of bronchodilation. So this is the new algorithm for COPD. It is called as COPD ABCD assessment. And most important, why I am doing this assessment is to identify the bad patients. I should identify group D. I should have strong follow-up so that mortality will decrease in those patients. Now try to solve this question. A 60-year-old male with COPD is brought to the emergency room by an ambulance that has been giving him oxygen by mask. 3 days ago, he noted that his sputum has changed color and increased in amount. So COPD with increased symptoms. So he is saying that he is brought to the emergency room because of increased shortness of breath. all this indicate the COPD patient has worsened. So this phenomena is called as COPD exacerbation. COPD exacerbation. On arrival at the hospital, he is conscious. He is conscious. So there is wheezing and his pH 7.31. There is hypoxemia and also hypercapnia. So patient is in type 2 respiratory failure. Why it is type 2 respiratory failure? Because CO2 has increased. So type 2 respiratory failure. So false regarding management. So read the question properly. False regarding management. Yes, he has survived. So this was one of our patient in our emergency department. So false regarding the patient. So this is in exacerbation. So can I give IV steroids? Yes. Can I give nebulized beta 2 agonist? Yes. You can give nebulization with beta 2 agonist. You can give nebulization with anticholinergics. And if at all I do mechanical ventilation, mild hypercapnia can be permitted during mechanical ventilation. Yes. So what is this? See, COPDs already they have CO2 level little bit high when compared to normal individual. So if it is a normal individual, the target CO2 after mechanical ventilation is near normal 40. But COPD already there will be some baseline hypercapnia. So no need to immediately bring down the CO2 to normal. So in COPD, no need to immediately bring down CO2 to normal. So you should bring down it gradually. So gradually bring down CO2. So because some amount of hypercapnia can be permitted during invasive mechanical ventilation. So this phenomena is called as permissive hypercapnia. So what is meant by permissive hypercapnia? This is very important question. So what is permissive hypercapnia? Permissive hypercapnia means no need to bring down immediately CO2 to normal. So his CO2 is 60. By putting a ventilator, no need to bring down it to 40 immediately. You can bring it down to 50 first day. Then you can bring it down to 45. No need to bring it down to 40 immediately. So because in COPD, no need to immediately bring down CO2 to normal. It can be brought down gradually. So some amount of hypercapnia is permitted. No issue. So because some amount of hypercapnia is permitted, this phenomena is called as permissive hypercapnia. So permissive hypercapnia means hypercapnia permitted during invasive mechanical ventilation. So the best answer is option 1. So NIV is contraindicated. NIV should be given because here patient is conscious. So option A. This was a question asked in last year NEET. Case number 19, option A. So this is a patient with COPD exacerbation. You can give beta 2 agonist. You can give IV steroid. No need to rush to bring down CO2 to normal. You can bring it down gradually. And NIV is not contraindicated. It is indicated in this patient. NIV is not contraindicated. It is indicated. So what is the reason that immediately see? If you want to bring down CO2 immediately, you have to ventilate with high pressures. What will happen if you ventilate with high pressures in COPD? Yes. So you'll kill the patient by giving him a tension pneumothorax. So no need of aggressively ventilating a patient with COPD. So gradual improvement is necessary. If you aggressively ventilate the patient, give him high pressures, so what is going to happen? He will develop pneumothorax. Instead of doing good to patient, you will harm the patient. So no need to aggressively bring the CO2 down. So this phenomena is called as permissive hypercapnia. Now what is this disease? There are abnormally dilated bronchi in the lung, and always patient is complaining of a symptom called as productive cough. Yes, productive cough. What is this? So dilated bronchi and productive cough. So this combination is bronchiectasis. Bronchiectasis. So bronchiectasis, this is abnormal dilatation of bronchi due to loss of muscle and elastic tissue. So what you need to know is this muscle and elastic tissue are the structures maintaining the architecture of bronchus. So why is your bronchus stiff? Because there is a good muscle, there is a good elastic tissue. That's why it is stiff. So whenever there is destruction of this bronchi, there is destruction of this muscle and elastic tissue, now there can be abnormal dilatation of the bronchi. So this phenomena is called as bronchiectasis. So write down the mechanism of bronchiectasis. So there will be an initiating event. So what are the initiating events? We will discuss in the next slide in etiology. So because of some initiating event, there will be abnormal clearance of mucus and secretions. Abnormal clearance of mucus and secretions. So because of some initiating event in the lung, the mucus and secretions are not cleared properly. So whenever the mucus and secretions are not cleared properly, they will stay there. So there will be stasis. So because of stasis, there can be obstruction. So whenever there are static secretions, what will it attract? So anywhere if secretions are static, it will attract infection. So there will be infection, and this infection will cause inflammatory damage. So that can cause an inflammatory damage. So because of this infection and inflammation, there will be destruction and dilatation of airways. So there will be destruction. So there will be destruction of muscle and elastic tissue. So because of destruction of muscle and elastic tissue, there will be dilatation of airway. Now tell me a destroyed and dilated airway. A destroyed and dilated airway, will it have good mucociliary clearance or bad mucociliary clearance? A destroyed and dilated airway, it will again have bad mucociliary clearance, and this sequence continues. So this sequence of events containing stasis, obstruction, infection, inflammation, destruction, dilatation, it is called as the famous vicious cycle of bronchiectasis. So it is called as vicious cycle of bronchiectasis. So this sequence of events, stasis, obstruction, infection, inflammation, destruction, dilatation, this sequence of events, it is called as a vicious cycle of bronchiectasis. Now because of these events, so what is going to happen? Your bronchus will be abnormally dilated like this, and always because of infection there will be some secretions. So always within the bronchus there will be some secretions like this. So because there are secretions, so what will be the most common complaint of this patient? Why will he come to my clinic? So most common presentation of this patient is productive cough. So he will be having productive cough. So if I put my stet, what is the classical sound that I am going to listen? So whenever air flows through these secretions, you will get a bubbling sound. So on auscultation, there will be coarse crepitations heard. So whenever you find this in combination, so productive cough, coarse crepitations, dilated airways, your direct diagnosis should be bronchiectasis. So productive cough, coarse crepitations and dilated airways, your answer should be bronchiectasis. So this is the mechanism of bronchiectasis, and this is the famous vicious cycle of bronchiectasis. Now we have studied here, there are few initiating events that can cause bronchiectasis. Let us see the etiology of bronchiectasis. So write down etiology of bronchiectasis. So etiology of bronchiectasis. So the first group, it can be due to bronchial obstruction. So bronchial obstruction. So this bronchial obstruction can be either, so first group bronchial obstruction, it can be either intraluminal bronchial obstruction or extraluminal bronchial obstruction. Intraluminal or extraluminal bronchial obstruction. Let us see what is this. Now consider this is the lung and let this be the bronchus. So this is the lung and let this be the bronchus. So intraluminal means there will be an obstruction directly in the lumen of the bronchus. So distal to that obstruction, the drainage of secretions will stop. So there will be collapse and no secretions will be drained out. So these secretions after few months, they can accumulate. So there will be secretions accumulating and that vicious cycle will happen. So static secretion, infection, inflammation, destruction, dilatation, and these areas can become bronchiectatic. So intraluminal obstruction. So example is a chronic foreign body. Apart from that, most frequently intraluminal obstructions are due to some tumors. So tumors such as squamous cell carcinoma, small cell carcinoma, and also carcinoid. So within the lumen of bronchus, there can be an obstruction. So distal to that obstruction, secretions are not cleared, and later on, after a few months, there can be development of bronchiectasis. Now extraluminal means the obstruction is not within the lumen. So for example, a lymph node can start compressing the bronchus. So whenever a lymph node compresses the bronchus, so again the same sequence of events happens. So bronchus is getting compressed, secretions remain, later on bronchiectasis. So lymph node can compress a bronchus. So best example for this is TB lymph node. So lymph nodes due to tuberculosis can compress. TB lymph node can compress. TB lymph node can compress right middle lobe bronchus. So that results initially right middle lobe collapse, and later there can be development of bronchiectasis. So this entity of right middle lobe collapse and bronchiectasis is called as Brock's syndrome. So there are many causes, but frequently in Indian scenario, it is associated with TB lymph node. Now you should get it out why TB lymph node compresses the right middle lobe bronchus. So TB lymph node generally happens at the hilum. So at the hilum, what is the bronchus arising? It is right middle lobe bronchus. So TB lymph node can compress right middle lobe bronchus, resulting in a sequence of events, right middle lobe collapse and bronchiectasis. This phenomena is called as Brock's syndrome. And next important group responsible is bronchial injury. So direct damage to the bronchus. So bronchial injury can happen either due to infections or due to connective tissue disorders, CTDs. So connective tissue disorders such as rheumatoid arthritis, scleroderma, SLE. So these connective tissue disorders as a part of systemic involvement, all these are autoimmune inflammatory disorders. They can directly involve the bronchus, destroy the bronchus, resulting in bronchiectasis, and infections such as tuberculosis, adenoviral infection, other bacterial infection can also cause bronchiectasis. Now if they ask you what is the most common infective cause of bronchiectasis, previously it was adenovirus, recently it has been changed to tuberculosis. So if they ask you most common infective cause of tuberculosis, now your answer should be tuberculosis. Most infective cause of bronchiectasis, it is tuberculosis. Now coming to the third group, so bronchiectasis, it happens as traction bronchiectasis. It occurs as traction bronchiectasis in interstitial lung disease. So in interstitial lung disease, the mechanism is not vicious cycle. It is slightly different. So what is the mechanism? Now consider these are two airways. So this is one airway, this is one airway. So initially let this be the diameter. So in between the airways, there is a tissue called as interstitium. In between the airways, there is a tissue called as interstitium. See, CTD means connective tissue disorder. RA means rheumatoid arthritis. So in between the airways, there is interstitium. So in ILD, what happens is there will be interstitial fibrosis. So in ILD, there will be interstitial fibrosis. Predominantly, the interstitium of the lung is involved. So whenever this area is undergoing fibrosis, so whenever there is fibrosis, will there be expansion of that area or shrinkage of that area? There will be shrinkage of that area. So because of that, what can happen? So the lateral limbs can be there itself, but the medial limbs will be pulled together. So why the medial limbs are pulled together? Because the tissue in between them has underwent shrinkage. Fibrosis is nothing but shrinkage. So what has happened here when compared to normal bronchi? Here the diameter of bronchi has slightly increased. So any abnormal dilatation of bronchi, it is called bronchiectasis. So why it has happened here? Because of pull of medial ends together. So pull is called as traction. So it is called as traction bronchiectasis. So try to identify, see here, these were initially two airways. In between them, there is interstitium. So whenever there is interstitial fibrosis, there will be shrinkage of tissue. So because of that, the medial ends can be pulled together. So whenever the medial ends are pulled, transiently what happens to the diameter of the airway? It increases. So this abnormal increase is bronchiectasis. Why it has happened? Pull of medial ends together because of fibrosis. So pull is called as traction. So it is called as traction bronchiectasis. Next important is genetic causes. Next group. So what are the genetic causes responsible? So we have ciliary dyskinesia syndromes. Ciliary dyskinesia syndrome, a very important disorder in children called as cystic fibrosis, and cartilage defect of airway. So directly the supporting structure, cartilage is defective. Cartilage defect of airway. So cartilage defect of airway. Example, we have William Campbell syndrome. William Campbell syndrome. Yes, ciliary dyskinesia, we have so many disorders. So Carter-Jenner, Young syndrome, all those. So cystic fibrosis, cartilage defect of airway such as William Campbell syndrome, and recently asked we have yellow nail syndrome. So for your exam they will ask you what is the classical triad of yellow nail syndrome. Classical triad of yellow nail syndrome. See Sumant Manjunath, first it is collapse. I told you collapse happens immediately. Bronchiectasis will happen after few weeks. It is sequence of events. Collapse happens immediately once it is completely occluding. So bronchiectasis happens later on. So yellow nail syndrome. So it is a triad. We have congenital lymphedema. So the lymphatics are not working properly. There will be pleural effusion. There will be yellow nails. So this is the classical triad. If they ask you what is the classical triad of yellow nail syndrome, patient will have congenital lymphedema, pleural effusion, yellow nails. Along with this, there can be bronchiectasis. So bronchiectasis is not classical feature of yellow nail syndrome. It is an additional feature. And finally, if you don't know the cause, idiopathic. So if you don't know what exactly is causing bronchiectasis, idiopathic. So as of now, idiopathic group is the most common group responsible for bronchiectasis. Idiopathic group is the most common group responsible for bronchiectasis. Idiopathic group is most common group responsible for bronchiectasis. So we have discussed the mechanism, pathophysiology. So clinical manifestations, now etiology. Now coming to some important aspects. So in your exam, depending upon the area of involvement, they'll ask you what are the conditions causing upper lobe bronchiectasis, what are the conditions causing mid zone bronchiectasis, what are the conditions causing lower zone bronchiectasis. So upper zone bronchiectasis, mid zone bronchiectasis and lower zone bronchiectasis. So upper zone bronchiectasis, it can be due to cystic fibrosis, tuberculosis. So we are discussing a topic called as site of bronchiectasis with respect to important diseases. Site of bronchiectasis with respect to important diseases. So in cystic fibrosis, bronchiectasis predominantly happens in the upper lobes. In tuberculosis, it is upper lobes. And even after radiation, there will be bronchiectasis. That was also seen more in the upper lobe. Post-radiation bronchiectasis. So in the mid-zone, so all these are observational findings, no specific mechanism. After seeing in so many patients, they have made statistics. They have found out these conditions were causing upper zone, these were causing mid zone, these were causing lower zone. So no specific mechanism for this. So ciliary dyskinesia. So ciliary dyskinesia was causing mid-zone bronchiectasis, and also infection with Mycobacterium avium. Infection with Mycobacterium avium. So lower zone bronchiectasis, interstitial lung disease, chronic aspiration, and majority of idiopathic bronchiectasis. So majority of idiopathic bronchiectasis will also be seen in lower zone. So in this single diagram, we have understood what are the causes of upper zone bronchiectasis, mid zone bronchiectasis and lower zone bronchiectasis. Now coming to general management of bronchiectasis. So whenever a patient reaches to me with bronchiectasis, what is the general treatment that I give? So first important thing, I should concentrate on patient's airway clearance. So these patients generally will be having thick sputum continuously. They will be having cough and production of thick sputum because infection for long duration can cause thick sputum. So to clear the secretions from his airway, I should give which will break the thick sputum into thin sputum, mucolytics. Along with that, I should give chest physiotherapy. So I should give chest physiotherapy. So TB lymph node will be mid-zone. So but Vidita Modi, what you should know is TB lymph node, primary TB is not that common. Common is secondary TB. Secondary TB usually involves the upper zones. Okay, when they ask you TB, don't go to the uncommon manifestation, please. Go to the common manifestation. Common manifestation, secondary TB, upper zones. Yes, most common site of bronchiectasis is lower lobe. Yesterday also we have discussed the same. Bronchiectasis generally happens more in lower lobe. Okay, so mucolytics and chest physiotherapy. So what is meant by chest physiotherapy? So we are going to gently tap on the affected segment. So I am going to tap like this. So whenever I tap like this, so these vibrations can induce a cough reflex and facilitate the excretion of secretions. So mucolytics will make thick secretions thin. So if I do chest physiotherapy, it can enhance the cough reflex and cause facilitation of clearance of the secretions. So this phenomena is called as airway clearance. And second important thing is antibiotics. So antibiotics definitely given during infective exacerbations. During infective exacerbations, to bring down the infection, I should give antibiotics. But patients with bronchiectasis frequently will have recurrent infections. So to bring down the recurrent infections, we should give antibiotic prophylaxis. So what are the antibiotic prophylaxis of what is the antibiotic prophylaxis that you give in bronchiectasis? So preferred is inhaled forms. Inhaled antibiotics, we have inhaled colistin, inhaled gentamicin, inhaled tobramycin, anyone, either colistin, gentamicin or tobramycin. And if it is not available, we can go for oral azithromycin. Next, in few areas, they are also giving intermittent IV antibiotics. So once in every 2 months, they admit the patient and give antibiotics for 1 to 2 weeks. And in Western countries, they also give oral fluoroquinolones. But in India, we routinely don't give oral fluoroquinolones. What is the reason? Because of chances of drug resistance and because of huge TB burden. And third important thing is, if patient has developed hypoxemia, we give him oxygen therapy. If there is a localized disease, so for example, this patient is having left lower lobe bronchiectasis. Already it is destroyed lung and frequently it is getting infected and causing some manifestations. So already destroyed lung. So if it is a localized disease, we can go for resection. If it is a more diffuse disease, so only option that we have is lung transplant. So this is the general management of bronchiectasis. So I should concentrate on airway clearance. I should give antibiotics. So if hypoxemia, oxygen. If localized disease, we can go for removal of that affected part. If diffuse disease, we can go for lung transplant. So this is the general treatment of bronchiectasis. So we'll take lunch break for 40 minutes. So because we are having so many topics to cover, so 40 minutes. So we'll conclude with a question here. This patient came with chronic productive cough and coarse crepitations. What is the diagnosis of the CT below? So whenever you find chronic productive cough, coarse crepitations, so one possibility is bronchiectasis. Now let us see the CT. So in the CT, can you see dilated airways here? So can you see dilated airways, blackish dilated airways looking like parallel railway tracks. I'll zoom it so that you can understand better. Can you see this? These are all dilated airways. So this is a normal airway. See, normal architecture will appear like this. Can you see predominantly dilated airways looking like parallel railway tracks? So this image is similar to this. So it is looking like parallel railway tracks. So what is this appearance called as? Tram track appearance. So tram track appearance. Because you can see the bronchiectasis dilated airways very well on a CT chest. So if they ask you, investigation of choice for bronchiectasis is generally CT chest. Investigation of choice for bronchiectasis is generally CT chest. So we'll meet by 2:40. So any doubts you can ask me now. Etiology slide of bronchiectasis. This is the etiology slide. So bronchiectasis is generally permanent. So sympneumonic effusion, we don't use the terminology now. So sympneumonic is generally associated only with pneumonia. Now the better terminology is parapneumonic. So Harrison does not include sympneumonic effusion. It is only parapneumonic. So bronchiectasis without significant production of sputum. It is bronchiectasis sicca. It can happen in tuberculosis due to fibrosis. So no need surgery of bronchiectasis in all patients. See, majority of the patients you can manage with medical management. So why there is dilatation of bronchi? Bronchi is supported very well by muscle and elastic tissue. That is destroyed. So it will lose its support and it becomes dilated. So yellow nail syndrome, we don't know the exact mechanism. It was an observational finding. Apart from lymphedema, apart from pleural effusion, they also identify bronchiectasis in few patients. So treatment slide of bronchiectasis. So there is the treatment slide. Shortness of breath and dyspnea are synonyms. They are the same. So cause of tension pneumothorax. Anything causing pneumothorax can cause tension pneumothorax. Usually after mechanical ventilation. So tram track appearance is characteristic of bronchiectasis. So lung transplant in COPD. So all treatments have failed. There is permanent damage to lung. The next thing is you go for a transplant. So no need high flow or low flow. You can just give oxygen therapy based on the saturation. Mechanism slide. This is the mechanism. See, the physiology of airways of bronchi and alveoli are different. So in emphysema, it is not the damage at the level of bronchi. It is at the level distal to terminal bronchiole. So there is dynamic airway compression. So dynamic airway compression usually happens in small airways. So that's why there it will collapse. Bronchiectasis is usually bronchi is involved, not at the level of alveoli. Most common cause of pneumonia in bronchiectasis. Yesterday it was told Pseudomonas. So Jones roughly equivalent to lobes. So in a chest X-ray you cannot clearly make lobes, so that's why I called it as Jones. So you can just correlate with the lobes also, no issue. So ABCD assessment. So this is the slide, ABCD assessment. So when to use biologicals in asthma? Even after step 5, patient is not improving, you can go for biological. Antibiotic prophylaxis, which is preferred. Inhaled forms are preferred, but they are costly. So generally we go for oral azithromycin. Alpha-1 antitrypsin deficiency is a genetic disease. So you cannot tell in whom it is seen. We identify a patient with that disease. Even after transplant in COPD, if he again smokes, he will not improve. So first you should stop smoking for that. So roflumilast and azithromycin prophylaxis usually reserved in group D patients. Group D patients. Now, see, severe exacerbation means resulting in ICU admission. It means patient is having more exacerbation rate if he is going into ICU. So sarcoidosis will try to complete. So opiates not included in pulmonary hypertension treatment. So pathophysiology of chronic bronchitis as told in the definition itself, there is mucus gland enlargement. So welcome back everybody. Okay. So now next topic is eosinophilic lung diseases. Eosinophilic lung diseases. So eosinophilic lung diseases, there will be peripheral eosinophilia. So within the blood there will be excess eosinophils. So peripheral eosinophilia with lung infiltrates. So peripheral eosinophils with lung infiltrates. So peripheral eosinophilia with lung infiltrates. So it means if you see in the patient's blood there will be excess eosinophils, and if you take a chest X-ray or CT scan there will be lung infiltrates. There will be lung infiltrates. Okay. Now let us see the important classification. Eosinophilic lung diseases are classified into two forms. So we are having an unknown cause. It means we don't know why exactly it is happening. Other is known cause. So unknown cause and known cause. So in unknown cause there are acute eosinophilic pneumonia. So we don't know why exactly these diseases are happening. Acute eosinophilic pneumonia is also written as AEP. Second is chronic eosinophilic pneumonia. Chronic eosinophilic pneumonia. So this is called also as CEP, acute eosinophilic pneumonia. So chronic eosinophilic pneumonia, chronic eosinophilic pneumonia. Third is hypereosinophilic syndrome. Hypereosinophilic syndrome. So what are the features of hypereosinophilic syndrome? There will be persistent eosinophilia. Persistent eosinophilia. So the eosinophil count will be more than 1500 per mm cube for more than 6 months. For more than 6 months. Along with that, end organ infiltration. Various organs in the body will be infiltrated. And last is a small vessel vasculitis called as Churg-Strauss syndrome. Churg-Strauss syndrome. So for your exam, this acute eosinophilic pneumonia and chronic eosinophilic pneumonia, both are very important. We will discuss in detail with help of a table in the next slide. Hypereosinophilic pneumonia, you should know what is the definition. It is persistent eosinophilia. So eosinophil count in the blood will be very high. So it will be high for more than 6 months. And not just the eosinophils will be excess in the blood. It will infiltrate majority of the organs. So if you take a skin biopsy, it will be containing eosinophils. So kidney will be infiltrated with eosinophils. Liver will be infiltrated with eosinophils with end organ infiltration. Churg-Strauss syndrome is a small vessel vasculitis which would have been discussed in rheumatology in detail. Now coming to known cause, First is parasitic infestations. So parasitic infestation, especially nematodes. Parasitic infestation, especially nematodes. So these parasites, especially nematode, during the life cycle, they enter the lung and give an hypersensitivity response. So parasitic infestations. So these parasites during their life cycle enter the lung and your lung will produce an hypersensitivity response. So what is this hypersensitivity response also called as? It is called as Loeffler's pneumonia. It is called as Loeffler's pneumonia. And second important thing, a complex allergic phenomena due to aspergillus. It is called as allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis, also written as ABPA. And third important reason for eosinophilic lung diseases are drugs. Drugs such as nitrofurantoin, sulfonamides, isoniazid, penicillamine. So these drugs can also cause hypersensitivity reaction, peripheral eosinophilia and lung infiltrates. So we have started our discussion post-lunch, eosinophilic lung diseases, unknown cause. We don't know exactly why they are happening. Some known causes. In that important is parasitic infestations. Parasitic infestations, especially nematodes. So these nematodes during their life cycle can enter the lung and cause an hypersensitivity response. So that hypersensitivity response caused by these parasites, it is called as Loeffler's pneumonia. And a very important phenomena called as allergic bronchopulmonary aspergillosis. Drugs such as nitrofurantoin, sulfonamides, isoniazid, penicillamine. Now first let us see the important differences between acute eosinophilic pneumonia and chronic eosinophilic pneumonia. Acute eosinophilic pneumonia and chronic eosinophilic pneumonia. So we will discuss in detail how these disorders are different with respect to smoking history, asthma history, clinical features and radiology, peripheral eosinophilia, bronchoalveolar lavage eosinophilia and also treatment. So acute eosinophilia, acute eosinophilic pneumonia. So smoking history is very important. So it generally happens in smokers. Chronic eosinophilic pneumonia, no such specificity. Patient may or may not be a smoker. Asthma history generally not present in acute eosinophilic pneumonia. So there is a strong asthma history in chronic eosinophilic pneumonia. Strong asthma history in chronic eosinophilic pneumonia. Now coming to the clinical features, patient will have acute shortness of breath within 1 month. So here the duration of shortness of breath, here the reference value is taken as 1 month. Along with that, there can be hypoxemia. Along with that, bilateral diffuse pulmonary infiltrates. So where did we come across such a presentation yesterday? Acute shortness of breath, hypoxemia, bilateral diffuse pulmonary infiltrates. So where did we come across such a presentation? ARDS. So the presentation in acute eosinophilic pneumonia can be similar to ARDS. But how to differentiate? So peripheral eosinophilia. So within the blood, eosinophil in excess eosinophils initially not seen. Excess eosinophils initially not seen. Excess eosinophils initially not seen, but seen later during course of disease. But seen later during course of disease. And most important investigation here is differentiating from ARDS. If you do a bronchoscopy and bronchoalveolar lavage, so bronchoalveolar lavage will be showing out of this cell count 25% of eosinophils. Generally, in that fluid, if there are 100 cells, only 2 or 3 will be eosinophils. Now here the bronchoalveolar lavage will be pooled with eosinophils. So more than 25% of eosinophils. And the treatment, even though it is aggressive in the beginning, it has good response to steroids. So patients will have good response to steroids. Whereas chronic eosinophilic pneumonia, the clinical features, patient can have cough, shortness of breath and cough. So there will be shortness of breath, there can be cough. So chronic shortness of breath and cough. And most importantly, on the chest X-ray, you will see bilateral peripheral infiltrates. So chest X-ray shows more of peripheral infiltrates. So here the duration will be 2 or 3 months. So there can be shortness of breath, there can be occasional cough, shortness of breath, occasional cough, and this will not be having hypoxemia, and there will not be that bilateral diffuse pulmonary infiltrates. It will only bilateral peripheral infiltrates. And because it is a chronic disease, by the time patient reaches to you, there will be peripheral eosinophilia. And this is a chronic disease, so more amount of eosinophils will be seen in the bronchoalveolar lavage. So it shows more than 40% of eosinophils. And here also the treatment is steroid. Here also the treatment is steroid. How was a question previously asked in this table? They have mentioned that a 45-year-old male presented to the ICU with features of ARDS, with features suggestive of ARDS. A bronchoscopy was done and his bronchoalveolar lavage was showing 30% of eosinophils. What will be the most appropriate treatment for this patient? What will be the most appropriate treatment for this patient? What will be the most appropriate treatment for this patient? Now, first of all, tell me, what is the diagnosis in this patient? ARDS like picture, but bronchoalveolar lavage showing plenty of eosinophils. Bronchoalveolar lavage showing plenty of eosinophils. It is suggestive of acute eosinophilic pneumonia. So what is the drug of choice in acute eosinophilic pneumonia? Steroids. What is the drug of choice in acute eosinophilic pneumonia? Steroids. Now let us see some radiological pictures. I will show you 2 X-rays. Tell me which is acute eosinophilic pneumonia and which is chronic eosinophilic pneumonia. So what is this? What do you see in this chest X-ray? You notice bilateral, top to bottom, side to side, diffuse pulmonary infiltrates. So this chest X-ray, it is suggestive of acute eosinophilic pneumonia. This chest X-ray is suggestive of acute eosinophilic pneumonia. Now in the next chest X-ray, if you notice, there are wing-shaped infiltrates more in the periphery of the lung. If you see here, there are infiltrates, wing-shaped infiltrates more in the periphery of the lung. So don't get confused with scapula. It is not scapula because the margins are very, very irregular. So wing-shaped opacities more in the periphery of the lung. So this bilateral peripheral opacities is characterized by presence of a disease called as chronic eosinophilic pneumonia. Now, where else in radiology you see wing-like opacities? I think it must have been done in radiology. So in cardiogenic pulmonary edema, you see central bat wing shaped opacities. So central bat wing shaped opacities. Now in cardiogenic pulmonary edema, it is a central bat wing shaped opacity. Whereas in chronic eosinophilic pneumonia, it is opposite. It is not central. It is peripheral. So that's why this sign in chronic eosinophilic pneumonia is given a special name. So this sign is called as reverse bat wing sign. Reverse bat wing sign. So reverse bat wing sign. So what is the classical bat wing sign? It will be central like this. But here it is opposite. It is reverse. It is peripheral. So it was called as reverse bat wing sign. So in cardiogenic pulmonary edema, this sign is called as reverse bat wing sign. Apart from this, there is another name for this sign. It is also called as photographic negative of pulmonary edema. So what is positive for pulmonary edema? Central wing shaped opacities. But here there are peripheral wing shaped opacities. So that's why it is also called as photographic negative of pulmonary edema. So these are all nothing but fancy names. So the simple name is bilateral peripheral opacities. If you want to present it in a fancy manner, you can either call it as reverse bat wing sign or photographic negative of pulmonary edema. So both are the same. What do they denote? They denote bilateral wing-shaped peripheral opacities. Bilateral wing-shaped peripheral opacities. So in chronic eosinophilic pneumonia, there will be bilateral peripheral wing-shaped opacities. It is also called as reverse bat wing sign. It is also called as reverse bat wing sign. Also called as photographic negative of pulmonary edema. See, positive is central opacities. Negative means opposite. So it is not central, it is peripheral. Photographic negative. Photographic negative. So why peripheral in chronic eosinophilic pneumonia, Mr. Bajaj? This is a disease of unknown etiology. We don't know why it is actually happening. Patient presents to us, we are studying it. So still the pathophysiology and etiology is not known. So when it is known, we will know why exactly it was happening in the periphery. See, if eosinophils they are not less, they are normal. It will take some time to get elevated. It will take some time to get elevated in the blood. But in the lung, it is already high. So disease starts in the lung. Okay. See, Agastya Saxena, acute and chronic, it is very difficult with respect to each and every symptom, acute and chronic changes. So for cough, it is 2 weeks. So for shortness of breath, it can be 1 week to 1 month. The range is different. You cannot have a clear-cut indication this is acute or this is chronic. So Neha Dwivedi, acute eosinophilic pneumonia, the differentiation is this point. I have underlined it. Bronchoalveolar lavage will show eosinophils. In ARDS, it is more of neutrophil mediated damage. Neutrophil mediated damage. Okay. Now coming to aspergillus and lung. How will a fungus called as aspergillus cause various lung diseases? There are actually 3 manifestations. We will go one by one. So first manifestation, whenever somebody inhales aspergillus, there can be an hypersensitivity reaction. So aspergillus inhaled can cause hypersensitivity reaction in few patients. So this can be a simple asthma or a more complex phenomena called as allergic bronchopulmonary aspergillosis, ABPA. So ABPA is nothing but allergic bronchopulmonary aspergillosis, allergic bronchopulmonary aspergillosis. So we know that asthma is generally type 1 hypersensitivity. So asthma is generally characterized by type 1 hypersensitivity. whereas ABPA is combination of type 1, type 3 and type 4 hypersensitivity. Already we have discussed in detail regarding asthma. So now let us see what is this ABPA. So write down ABPA features. So ABPA features. So first important feature is there will be either history of asthma, a predisposing condition, either history of asthma, or recent studies have shown that even patients with cystic fibrosis can develop ABPA. So ABPA will be seen on background of asthma in majority. In minority, it can be seen on background of cystic fibrosis. And within the blood, there will be excess eosinophils. So there is peripheral eosinophilia. Peripheral eosinophilia. And serum IgE levels. Serum IgE levels will be more than 1000 international units. And most importantly, there will be elevated aspergillus specific, elevated aspergillus specific IgG and IgE, elevated aspergillus specific IgG and IgE. And if you do a skin test, so skin test will be positive for a fungus called as Aspergillus fumigatus. Aspergillus fumigatus is the fungus responsible for all these manifestations. And if you take a chest X-ray, one can notice upper zone infiltrates. And in a CT scan, you find classical finding called as proximal, also called as central bronchiectasis. So proximal or central bronchiectasis. So we are discussing the features of allergic bronchopulmonary aspergillosis. Now if you see these features, history of asthma, peripheral eosinophilia, high serum IgE, elevated aspergillus specific IgG and IgE, skin test positivity for Aspergillus fumigatus, all this indicate that there is an hyperimmune response against aspergillus in the patient's body. Asthma history, high eosinophils, high IgE and aspergillus specific IgG and IgE, skin test positivity, all this indicate there is some hyperimmune response against aspergillus in the body. And chest X-ray will show upper zone infiltrates. CT chest will show proximal or central bronchiectasis. So what is meant by this central bronchiectasis? So what is considered as large central airway in your body? It is trachea. So trachea is the large central airway. If bronchiectasis is happening in bronchi nearer to the trachea, it is called as proximal or central bronchiectasis. So if bronchiectasis is happening in the bronchi nearer to the trachea, nearer to the central airway, it is called central or proximal bronchiectasis. Now coming to the treatment part. So what is the drug of choice? What is the drug of choice? So this is an hypersensitivity response. So this is an hypersensitivity response. So for hypersensitivity, generally the drug of choice is steroids. Along with the steroids, you can also add an antifungal called as itraconazole. So this itraconazole is added to decrease frequency of exacerbation. So to decrease frequency of exacerbation. But when they ask you what is the single best drug of choice, so what is the single best drug of choice, always your answer should be steroids. So according to recent guidelines, along with steroids, itraconazole is also added. So itraconazole can decrease the fungal load and it can decrease the frequency of exacerbation. It can decrease the frequency of exacerbation. So drug of choice here is steroid. Drug of choice for ABPA is steroid. Now let us see some cases so that you can understand better. Case 21. So there was a patient with poorly controlled asthma. So his asthma was not controlled. IgE is elevated. And what do you notice here? Now consider in this CT scan, this structure is the trachea. So this structure is the trachea. Now can you see in the lung some dilated airways like this? Can you see in the lung some dilated airways? So this everything is bronchiectasis. So where is this bronchiectasis happening? It is happening in the bronchi very close to the trachea. It is happening in the bronchi very close to the trachea. So this is a central bronchiectasis. So this is how a central bronchiectasis appears. So bronchiectasis happening in bronchi very nearer to the trachea. You can see the image here. This is the trachea. So on the other side of the lung, there is no issue at all. So but here there are abnormal dilated airways. So this abnormal dilated airways, it is bronchiectasis. And it is happening nearer to the trachea, so it is called as central bronchiectasis. Now try to solve this question. If at all they give you, there is a poorly controlled asthma in the question, elevated IgE and presence of central bronchiectasis. So what is the answer? The answer for case number 21 is ABPA. So what we are discussing here is allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. So this is the first manifestation of aspergillus in the lung and a hypersensitivity response. Now let us see the next two manifestation. The second manifestation is whenever patient is immunocompromised. This can happen as an pneumonia. So pneumonia in immunocompromised. Aspergillus fungus can cause a pneumonia in immunocompromised. Pneumonia in immunocompromised. So this pneumonia in immunocompromised is also called as invasive pulmonary aspergillosis. It is also called as invasive pulmonary aspergillosis. Whereas the third manifestation, whenever there is a pre-existing lung cavity, colonization in pre-existing lung cavity. Colonization in pre-existing lung cavity. So this colonization in pre-existing lung cavity, it is called as aspergilloma. It is called as aspergilloma, also called as fungal ball. Also called as fungal ball. Colonization in pre-existing lung cavity, it is called as aspergilloma, also called as fungal ball. Now first let us see what is happening in invasive pulmonary aspergillosis. Invasive pulmonary aspergillosis is characterized by transbronchial angioinvasion. Transbronchial angioinvasion. It means there will be invasion of the bronchus. There will be invasion of the blood vessel. So what will be the clinical features? Because this is a pneumonia, patient can have fever. Because the bronchus is involved, lung is involved, there can be shortness of breath. Because blood vessel is involved, patient can develop hemoptysis. So the presentation, patient can have fever, shortness of breath, hemoptysis. Fever, shortness of breath, hemoptysis. Now for your exam, they will ask you the CT chest findings. So what do you see on the CT chest? Because X-ray is not that sensitive, we generally go for CT chest. So what do you see in CT chest during active phase of the disease? And what do you see in the CT chest during recovery phase of the disease? Active phase and recovery phase. Now consider this is the lung. So how will lung appear on a CT chest? So how will lung appear on a CT chest? It will appear completely black like this. So lung on a CT film will appear completely black like this. So because lung is usually filled with air. Lung is usually filled with air. So in this lung now a fungus is growing. So fungus is made up of solid filaments. So fungus will appear white. So in this lung a fungus was growing. So fungus will appear white. Now this fungus is invading the blood vessel. So around the fungus, because the blood vessels are getting invaded, it will appear white. So just I will write it right again. See the lung. See, lung generally appears black like this. Okay, your lung generally appears on a CT film. So very black like this. Now in this black lung, a fungus was actively growing. So fungus is made up of solid filaments. So anything solid tends to appear white. So a fungus growing will appear white. So around this fungus there will be blood because blood vessel is involved. So blood will also appear white, but when compared to white of fungus, it will appear less white. But compared to white of fungus, it will appear less white. It will appear less white. Now presence of such two densities on a CT film, it is called as CT halo sign. So you can see central portion white because of fungus. Peripheral portion less white. Peripheral portion less white. Why it is less white? Because of blood. So presence of such two densities on a CT film, it is called as CT halo sign. So presence of such two densities is called as CT halo sign. So whenever a patient with this picture reaches to me, I identify it as invasive pulmonary aspergillosis and I will start treatment. So once I am treating the patient, so body's immunity will also recover and it will start clearing the fungus. So during recovery phase, body's immunity starts clearing the fungus. So once body's immunity start clearing the fungus, now what do you notice? So recovery phase, again this is the lung. This is the lung. So there was a fungus actively growing previously. Now once you have started treatment, the fungus is dead and now your body's defense mechanisms are clearing the fungus. So once the fungus is cleared in that area, your lung will reappear. So what does lung contain? Air, and this air can reappear like a half moon shaped structure. So what is this sign called as? Air crescent sign. So this sign is called as air crescent sign. So very important, when they ask you what do you see in active phase, when they ask you what do you see in active phase, your answer should be CT halo sign. So in the recovery phase, all this white fungus is getting cleared. So in that area, lung will reappear. What does lung contain? Air, and this air will reappear like a half moon shaped structure. This is called as air crescent sign. Now if they ask you what is the treatment for invasive pulmonary aspergillosis, you should give an antifungal, and most effective antifungal here is oriconazole. So very important, CT halo sign is suggestive of active phase of invasive pulmonary aspergillosis, whereas air crescent sign is suggestive of recovery phase. Now coming to colonization in pre-existing lung cavity. So for aspergilloma to happen, there should be a pre-existing lung cavity. So consider this is the lung and there is a cavity. How will generally cavity appear when compared to surrounding areas? It will appear very black. So because cavity is an air-filled area. Now in this cavity, a fungus is colonizing. It is colonization, not invasion. So it is coming and settling down. Fungus again will be white. So fungal filaments will be white. So fungus is coming and settling down in the cavity. Now if you notice here also around the fungus there is a half moon shaped structure of air. So this is also called as crescent sign. This is also called as crescent sign. But to avoid confusion with air crescent sign, the name is now changed to monad's sign. So this is also a crescent sign, but to avoid confusion, we call this as monad's sign. So there is a cavity in that a fungus has accumulated. So fungus will appear white. Around that white, air appears like a half moon shaped structure. So this is also a crescent sign, but to avoid confusion, we call it as monad's sign. So lung will not develop. There is no cavity. Ajay Kumar Reddy, in invasive pulmonary aspergillosis, there is no cavity. There is a consolidation. It is healing. Once it heals, you will find lung. So a lung will be there. So monad's sign, it is crescent sign. So crescent sign in aspergilloma, it is called as monad's sign. Okay. Next important sign here is, now this is just colonization, not invasion. So if at all the patient is standing like this, by gravity the fungus will be in this part of the cavity. Now if he lies down to this side, the fungus can reach to this side of the cavity. Now if the patient turns to this side, the fungus can reach to this side of the cavity. Now if you take a X-ray film in each position of the patient, you can see the ball moving its position, it's with patient's decubitus. So if you take a chest X-ray, when the patient is sitting, you find the fungal ball is here. If he is lying to this side, you find fungal ball is here. So this phenomena is called as ball changing its position. Ball changing its position. Ball changing its position with patient decubitus. Ball changing its position with patient decubitus. So these two signs are easily identified on the chest X-ray itself. In aspergilloma, you can see the signs easily on the chest X-ray. Now coming to the treatment. So already this cavity is destroyed lung, and in that a fungus is coming and causing problems. So treatment will be resection of affected part. So treatment will be resection of affected part. So whenever they are asking you about aspergilloma, key concepts that you should know is there will be a pre-existing lung cavity. You have a monad's sign and a ball changing its position with decubitus. A ball changing its position with decubitus. So in recovery phase, you can see in invasive pulmonary aspergillosis, you can see the air crescent. Around that you can see whitish area. Usually in monad sign you should find a cavity. So it is completely different. Completely different. See, lung abscess, you will have a fluid level straight like this. Lung abscess, you will have a fluid level straight like this. Now try to solve these questions. So first case, a patient underwent organ transplant. There was history of fever, shortness of breath. Aspergilloma patient can be asymptomatic. In few, it can also cause hemoptysis. So no role of steroid in aspergilloma. Resection. So it is colonization, you have to remove the cavity. So organ transplant patient, history of fever, shortness or hemoptysis. This was the CT chest. So what is your diagnosis? What do you notice in the CT chest? Yes, what do you notice in the CT chest here? So there is area of white. Around that area of less white. Area of white. Around that area of less white. So this is a CT halo sign. CT halo sign. So what exactly is meant by halo? On a full moon day, halo means the dim light. Halo means the dim light around the bright moon. Halo means a dim light around the bright moon. So this picture actually is romantic. Full moon day, moonlight dinner is romantic. But this picture on a CT scan is very problematic. So CT halo is from this picture. So you have a bright light around that dim light. So it was appearing as same. So it was seen in CT scan. That's why it was called as CT halo sign. So this is suggestive of active invasive pulmonary aspergilloma. Active invasive pulmonary aspergilloma. Active invasive pulmonary aspergilloma. Now I have given treatment. After few days, this was the CT scan. So what do you observe here? This is an air crescent sign. 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 See, organ transplant patient is immunocompromised. See, after organ transplant, to avoid graft rejection reactions, we give lot of immunosuppressive therapy. So because we give lot of immunosuppressive therapy, so this patient will be immunocompromised and easily develop invasive pulmonary aspergillosis, pneumocystis, pneumonia. Okay. So this is air crescent sign and this is recovery phase. So this is recovery phase. Coming to the next case. So this patient is a known case of pulmonary tuberculosis, completed his treatment and for routine checkup a chest x-ray was taken. So routine checkup, a chest x-ray was taken. So whenever I say known case of pulmonary TB, there can be some residual cavities. So if you see in his chest x-ray, for aspergilloma, first identify the cavity. So this is the cavity. This is the cavity. In that cavity, there is a fungus. In that cavity, there is a fungus. Around that, you can see air like a half moon shaped structure. So around that you can see air like a half moon shaped structure. So this is also crescent sign, but the better name is monad's sign. So but the better name is monad's sign. So what is the diagnosis here? It is aspergilloma. Now how to identify it on the CT? See, always to identify aspergilloma, first you should see the cavity. If you are not seeing the cavity, it is not aspergilloma. See here. So this is the cavity. So this is the cavity. In that cavity, there is a fungus. There is a fungus. Around that fungus, you see air. So this phenomena is called as monad's sign. This phenomena is called as monad's sign, also called as fungal ball. So once again, repeat with me. So what is the classical radiological feature in ABPA? In ABPA, central bronchiectasis. See, once again, you should not forget. It is the same fungus causing various manifestations. ABPA, central bronchiectasis. Invasive pulmonary aspergillosis, CT halo sign, air crescent sign. Whereas aspergilloma, we get this monad sign. Aspergilloma, we get this monad sign. Monad sign. Now what is this disease? Patient is exposed to pigeons and later on develops respiratory symptoms. So this classical disease is called as bird fanciers disease or bird fanciers lung. It is a type of hypersensitivity pneumonitis. It is a type of hypersensitivity pneumonitis. Hypersensitivity pneumonitis. So write down next topic, hypersensitivity pneumonitis. So hypersensitivity pneumonitis, it is also called as extrinsic allergic alveolitis. Extrinsic allergic alveolitis. So this disease is characterized by type 3 and type 4 hypersensitivity. Type 3 and type 4 hypersensitivity. So because it is type 3 and type 4 hypersensitivity, it is not type 1. Because there is no type 1 hypersensitivity, serum IgE levels will be normal and there will be no peripheral eosinophilia. So eosinophils will not be elevated in the circulation. So there will be no peripheral eosinophilia. See, whenever I say there is some allergy in your lung. So whenever I say there is allergy in your lung. So extrinsic allergic alveolitis is other name for hypersensitivity pneumonitis. So whenever I say there is some allergy in your lung, what is the first disease that comes into your mind? It is asthma. So where is asthma generally happening? In the bronchi. So it is called as bronchial asthma. So what happens in bronchial asthma? An allergen reaches your bronchus. Your bronchus is not liking that allergen. So it will close, not allowing it further into your lung. Because there is bronchospasm, immediately patient can develop shortness of breath. So immediately patient can develop shortness of breath. And if you put your stet, you can listen wheeze. Because there is bronchospasm, one can listen wheeze. And asthma is type 1 hypersensitivity. So in the blood, eosinophils can be elevated and serum IgE will be elevated. Now this disease called as extrinsic allergic alveolitis, it is also having allergic background. It is also coming from outside, but it is not the bronchus involved, it is alveoli involved. So for the allergen to go to the alveoli, cause some inflammation, it will take some time. So symptoms will not be very immediate, it will happen after 4 to 6 hours. So whenever alveoli are inflamed, during expiration they close. During the next inspiration, they open with a popping sound. So if I put my stet, what is the classical sound that I hear in extrinsic allergic alveolitis? It is not wheezing. It will be fine crepitations. I told you yesterday, whenever there is inflammation in and around alveoli can close completely during expiration. During the next inspiration, they open with a sound called as fine crepitations. And there is no type 1 hypersensitivity here. Here it is only type 3 and type 4 hypersensitivity. So serum IgE will not be elevated, it will be normal and there will be no peripheral eosinophilia. Now whenever I do a biopsy, so in this patient's lung, if at all I do a biopsy, what do I notice? I notice non-caseating granulomas. So non-caseating granulomas plus cellular bronchiolitis. Bronchioles filled with inflammatory cells. Along with that, the interstitium of the lung, interstitial inflammation. So within the biopsy of hypersensitivity pneumonitis, I can notice non-caseating granulomas cellular bronchiolitis, interstitial inflammation. So for your exam, the examples of hypersensitivity pneumonitis is important. So there are few examples of hypersensitivity pneumonitis. So first disease is Farmer's lung. These are all examples of, depending upon the occupation, they were given some special name. So Farmer's lung. It is due to moldy hay. The antigen or organism responsible is Micropolyspora fini. Micropolyspora fini. Next we have bagasosis. Bagasosis. The exposure here is sugarcane dust. Sugarcane dust. Exposure here is sugarcane dust. And the antigen responsible here is Thermoactinomyces cercari. Thermoactinomyces cercari. So important point here is both Micropolyspora fini and Thermoactinomyces cercari belong to the same family. They are brothers. Thermoactinomycetes. So previously there was a confusing question. Thermoactinomycetes can cause Farmer's lung. Is it a true statement or false statement? Thermoactinomycetes can cause Farmer's lung. It is a true statement because Thermoactinomycetes is a broad terminology consisting of both Micropolyspora fini and Thermoactinomyces cercari. So third is malt worker's lung. Malt worker's lung. So here this is due to moldy barley. And the organism is Aspergillus clavatus. Then we have the famous bird fancier's lung. Famous bird fancier's lung. The source is pigeon excreta. And the antigen is protein in that excreta. Avian protein. And recently asked hot tub lung. Source or exposure is contaminated water in hot tubs. Contaminated water in hot tubs. The antigen here is Mycobacterium. Mycobacterium avium. So these were the important examples asked previously in your entrance exam. So Farmer's lung, moldy hay, Micropolyspora fini. Bagasosis, Thermoactinomyces cercari. Malt worker's lung, Aspergillus clavatus. Bird fancier's lung, avian protein. Hot tub lung, Mycobacterium avium. So this Mycobacterium avium is a non-tubercular mycobacteria. Mycobacterium avium is a non-tubercular mycobacteria. Okay. So these are some important examples of hypersensitivity pneumonitis. Now let us see the diagnostic criteria. So write down the diagnostic criteria of hypersensitivity pneumonitis. So most important is exposure to known antigen. So PGNs, very, very dangerous. So most important is history. Exposure to known antigen capable of causing hypersensitivity pneumonitis. And second important thing is your body is not liking that antigen and it is producing antibodies. Serum precipitins means antibody. So presence of serum precipitins against offending antigen. So presence of serum precipitins against offending antigen. Occurrence of symptoms in 4 to 8 hours. Recurrence of symptoms on re-exposure. It means the symptoms occur in 4 to 8 hours. So today the patient is exposed to that stimulus, he is getting symptoms. After 1 week he is exposed to the same stimulus, again he will get the same symptoms. So occurrence of symptoms in 4 to 8 hours after exposure and recurrence of symptoms on re-exposure. Next we have inspiratory crepitations. On auscultation we have inspiratory crepitations, and there can also be weight loss in chronic diseases. So if there is a chronic hypersensitivity pneumonitis, so patient will always be having some respiratory symptoms. Because of that he may not take diet properly, so there can also be weight loss. Now coming to the treatment. So coming to the treatment part, most important is avoidance of antigen. Avoidance of offending antigen. If at all patient is getting symptoms to this, he should avoid that antigen. And second important thing is, this is also an hyperinflammatory response. So he should be given steroids. So diagnostic criteria: exposure to known antigen. So presence of serum precipitins against offending antigen. Occurrence of symptoms in 4 to 8 hours. Recurrence of symptoms on re-exposure. Inspiratory crepitations on auscultation. There can also be weight loss. Whereas treatment, most important is avoidance of that offending antigen. So if at all patient is getting symptom due to that antigen, he should avoid that antigen. And also steroids. So this completes hypersensitivity pneumonitis. So if you don't mind, students, I'm just getting a call from the ICU because one of the patient, I think he's sick. Just give me 5 minutes. I'll just discuss and I'll tell him the condition and tell what to do, and I'll be back. Just 5 minutes, please. Yeah, no. 5 minutes to stop. I got a call from ICU. I'll just speak to them. 5 minutes, just 5 minutes. Hello. Yes, hello students. So this COVID disease is very, very unpredictable. Extremely sorry. So one of my known patient is admitted in the ICU. They had some issues, so they had called me. Okay. So this is regarding hypersensitivity pneumonitis. Now the next disease. In this disease, there is predominant involvement of interstitium, that results in fibrosis later on. So what is this disease called as? Yes, what is this disease called as? So predominant involvement of interstitium, so that later on resulting in fibrosis. What is this? So this is interstitial lung disease, ILD. I call it as interesting lung disease. Let us see what is interesting here. So write down the definition here. So characterized by predominant involvement of interstitium, that progress to fibrosis, which vary in mechanism and magnitude. So what happens in ILD is, this disease predominantly involve the interstitium, but later air spaces are also involved, but it predominantly involves the interstitium, and later there will be lung fibrosis, and this fibrosis will vary in mechanism and magnitude. So this fibrosis will not be same in all diseases. So few diseases may result in mild fibrosis, some may progress to severe fibrosis. Those staying in mild fibrosis will have good prognosis. Those extending into severe fibrosis will have bad prognosis. Now let us see the etiology. So etiology of ILD. So the first group is inhalational ILD. So first group we have inhalational ILDs. So inhalational ILDs, it can be either due to inhalation of organic dust or inorganic dust. So organic dust, because of some organisms present in the dust, we have just discussed. Hypersensitivity pneumonitis. So in hypersensitivity pneumonitis also, they have observed interstitial involvement. Hypersensitivity pneumonitis. Inorganic dust, ILD is seen in silica. Asbestos exposure. Next important thing is drugs and radiation. So radiation can lead to ILD. Drugs such as amiodarone, busulfan, bleomycin, nitrofurantoin. Amiodarone, busulfan, bleomycin, nitrofurantoin. And third important is connective tissue disorders. Connective tissue disorders such as rheumatoid arthritis, SLE. Scleroderma. So these connective tissue disorders, as a part of systemic involvement, can involve the lung and result in ILD. So connective tissue disorders have systemic features. So one such feature in the lung is ILD. Then other systemic disorders such as sarcoidosis, can cause ILD. Inflammatory bowel diseases. Inflammatory bowel diseases. So what are the inflammatory bowel diseases that you know? Crohn's disease, ulcerative colitis. So in Crohn's disease and ulcerative colitis also, as a part of systemic involvement, lung can be involved resulting in ALD. Lung can be involved resulting in ILD. And finally, when you don't know the cause, idiopathic. As of now, idiopathic group is the most common group of ILD. So in majority of ILD, still we don't know what is the exact etiology. Idiopathic is the most common group in majority of the ILD. Still we don't know what is the etiology. Now if they ask you what is the investigation of choice for ILD. So what is the investigation of choice for ILD? So your answer should be HRCT chest. High resolution CT chest. High resolution CT chest. High resolution CT chest. And if they ask you confirmatory test. So confirmatory test. So confirmatory test is a lung biopsy. So confirmatory test is a lung biopsy. Confirmatory test is a lung biopsy. The next important thing is from the recent edition of Harrison. What is the most effective method of diagnosis? So ILD is actually a confusing disease and actually a difficult disease to treat. So for that, most effective method of diagnosis. So this is given in recent edition of Harrison. So your answer should be multidisciplinary discussion. Multidisciplinary discussion among physician, pathologist, radiologist. So this is something we generally don't do because ILD is a confusing disease and very difficult to treat. So before labeling the patient as ILD, so we should sit and discuss. Actually this is the best method. So physician will have the clinical picture, pathologist will have the radiological picture, and pathologist will have the biopsy pattern. Radiologist will tell you the CT picture. So all these three will discuss together. So there will be a panel in most of the hospitals to discuss difficult cases. So that is called as multidisciplinary discussion. Physician will share clinical features, pathologist, biopsy, radiologist, the radiological pattern. Actually, it contains everything. So nowadays panel discussion actually looks like this, but this is not the panel discussion that we are doing here. So we are doing a better panel discussion that is between physician, pathologist and radiologist. So if they ask you what is the investigation of choice? What is the investigation of choice? HRCT chest. What is the confirmatory test? So what is the confirmatory test? It is lung biopsy. Most effective method of diagnosis is panel discussion, not such a panel discussion. This panel discussion contains physician, pathologist, radiologist. Physician, pathologist, radiologist. Now because investigation of choice is HRCT chest, first we will discuss the radiological pattern, then we will go into the pathological pattern. So write down radiological pattern of ILD. Radiological pattern of ILD. So write down radiological pattern of ILD. Radiological pattern of ILD. So write down radiological pattern of ILD. So how will a patient present to me? So when do I suspect it is ILD? So patient presents to me with shortness of breath. There can be dry cough, and on auscultation there will be fine crepes. So this will be the initial presentation of the patient with ILD. So whenever a patient reaches to me with this scenario, initially I go for a chest X-ray. So initially I go for a chest X-ray in majority of lung diseases. And what do I do in a chest X-ray? So when a patient comes with these features, I am suspecting it as ILD. First I will see a chest X-ray. So in the chest X-ray, you can notice bilateral interstitial infiltrates. More than this, it is not visible properly on a chest X-ray. So bilateral interstitial infiltrates. So bilateral interstitial infiltrates. Now for better visualization, we go for investigation of choice next. So in chest X-ray, apart from bilateral interstitial infiltrates, not much is visible. So next investigation that we go is chest X-ray, CT chest. So in CT chest, you can find any one of the following. So if I draw anything like this, this is axial section of lung on a CT film. So this will be axial section of lung on a CT film. So initially there will be only mild haziness. So in early disease, not much density. There will be only mild haziness. So this mild haziness, it is called as ground glass opacity. So this mild haziness, it is called as ground glass opacity, also called as GGO. Later, it can progress to more increase in density. So more increase in density. So this more increase in density, it is called as consolidation. So these are the initial findings. So there can be a ground glass opacity and there can be a consolidation. But how will an ILD later progress? So it will progress into fibrosis. So where does the fibrosis predominantly happen? In the interstitium. Because of interstitial fibrosis, there can be a finding called as traction bronchiectasis. Already in bronchiectasis, I have discussed how traction bronchiectasis is happening. So still, if the disease is not controlled, in advanced ILD, what you can notice? So in advanced ILD, there will be dense fibrosis around the airways, resulting in abnormal rounded areas of air at the periphery of the lung. Because of dense fibrosis around the alveoli, there will be abnormal rounded areas of air around the lung. So this is called as honeycombing. So honeycombing indicates dense fibrosis around alveoli. Honeycombing indicates severe architectural distortion of lung parenchyma. Honeycombing indicates severe architectural distortion of lung parenchyma. Now we have seen important findings called as ground glass opacity, consolidation, traction bronchiectasis, honeycombing. Now a very simple question. Out of all these findings, which is associated with worst prognosis? So which finding in CT is associated with worst prognosis? Your answer should be honeycombing. Why is it so? Honeycombing indicates dense fibrosis around the alveoli, severe architectural distortion. So which might be associated with good prognosis? So ground glass opacities, because there is no much architectural distortion. Now I'll show you some CT scans. So try to differentiate what is ground glass opacity, what is consolidation first. So there are two CT films. Now tell me which is ground glass opacity, which is consolidation. I'll give you this as number 1 and this is number 2. So what do you see in number 1? So this is only mild haziness. So this is only mild haziness. So this is called as ground glass opacity. Now what do you see here? Number 2, this is more increase in density. More increase in density. So this is consolidation. This is consolidation. So once again I'll zoom it so that you can see the differences. So ground glass opacity is only mild haziness when compared to surrounding areas, only slightly white, but more increase in density is seen in consolidation. So ground glass opacity and consolidation. Now coming to the next image. Now what is this? So this is a structure called as honeycomb. So honeycomb is the area where honeybees store their honey. So when this CT is seen, can you notice in this CT some abnormal rounded areas of air looking similar to an honeycomb? Yes. So because these two were looking similar, you can see these structures and these structures are looking similar. So it is called as honeycombing. So honeycombing, honeycombing, honeycombing. Now if you observe, this honeycombing in severe disease is most probably seen, and it was most commonly seen at the periphery of the lung. So what is present at the periphery of the lung? So it is the pleural surface. So this honeycombing was seen to occur more in the periphery of the lung. So this phenomena is called as subpleural involvement. So honeycombing generally will be seen more at the periphery, and this involvement is called as subpleural involvement. See, differentiate between crazy paving and honeycombing. See, honeycombing, these are all blackish areas. Crazy paving or whitish areas. So crazy paving will have same shape, but those areas will be white. These are blackish areas. Blackish areas. So crazy paving will always be white, more of whitish areas, surfactant filled areas. Honeycombing, still there is some air, but alveoli are compressed here. So this is more of blackish areas. So you are telling that you are difficult to differentiate crazy pattern. It means you are finding it difficult to differentiate between black and white. So honeycombing is predominantly here black, whereas there it was white. Okay. So subpleural involvement, subpleural involvement, mostly there will be subpleural involvement, very at the periphery. Now what is the disadvantage of having abnormal area of air, abnormal area of air, abnormal area of air at the periphery? So whenever there is an abnormal area of air, it can rupture easily because the abnormal areas are very nearer to the pleural cavity, so there can be increased chances of pneumothorax. So we have discussed in ILD there is pneumothorax. So it is usually seen in advanced ILD. So in advanced ILD, honeycombing is seen at the periphery of the lung. So these are diseased lungs. So these honeycombing areas can easily rupture, and if they rupture, air escapes into pleural cavity, resulting in pneumothorax. So we have understood what is ground glass opacity. So what is consolidation and what is honeycombing? Honeycombing more in the periphery, it is called subpleural involvement because it is at the more in the periphery, more chances of rupture into pleural cavity, more chances of pneumothorax can happen. Now let us see pathological pattern. Pathological pattern of ILD. Up to now we have discussed radiological pattern, the pathological pattern of ILD. So get ready for a very big list. We have usual interstitial pneumonia. Usual interstitial pneumonia, also called as UIP. Non-specific interstitial pneumonia, NSIP. Acute interstitial pneumonia, AIP. Cryptogenic organizing pneumonia, COP. So these four are very important in clinical practice. So these four are also frequently asked in your exam. So these four are also frequently asked in your exam. So less important, we have respiratory bronchiolitis, ILD, written as RBILD. Then we have lymphocytic interstitial pneumonia, called as LIP. And desquamative interstitial pneumonia, So this is called as DIP. So these are all the pathological patterns of ILD. So for your clinical practice, the first four are important. Usual interstitial pneumonia, UIP, non-specific interstitial pneumonia, NSIP, acute interstitial pneumonia, AIP, cryptogenic organizing pneumonia, COP. So less common we have respiratory bronchiolitis, ILD, written as RBILD, lymphocytic interstitial pneumonia, LIP, desquamative interstitial pneumonia, DIP. Now let us see what are the common forms. So this NSIP is most common ILD pattern, in connective tissue disorders. So in majority of connective tissue disorders, most common ILD pattern is NSIP. Except, there is an exception, except in rheumatoid arthritis, it is UIP pattern. In majority of connective tissue disorders, it is NSIP. But in rheumatoid arthritis, you see usual interstitial pneumonia. Then what is the most common ILD pattern overall? Because it was usually happening, routinely happening, it was called as usual interstitial pneumonia. So UIP is most common pattern. UIP is most common pattern overall. UIP is most common pattern overall. So in UIP there is a subtype. So UIP of unknown etiology. So whenever you are unable to identify the etiology of UIP, there is a special name. So that special name is idiopathic pulmonary fibrosis. So idiopathic pulmonary fibrosis, also written as IPF. In majority of books, UIP and IPF are used as synonyms, but there is a slight difference. UIP and IPF in majority of books, they are used as synonyms. There is a slight difference. So whenever you are unable to find out the etiology, idiopathic UIP is called as idiopathic pulmonary fibrosis, also called as IPF. Most common pattern of ILD in connective tissue disorders is NSIP. One exception is rheumatoid arthritis, where you see usual interstitial pneumonia. So first we will see the important differences between UIP and NSIP. Then we will also discuss acute interstitial pneumonia and cryptogenic organizing pneumonia. So write down the important differences between UIP, IPF on one side, NSIP on other side. So UIP, IPF. So in this table, I am going to discuss the clinical presentation, what can be the biopsy picture, what do you see on the CT chest, and what will be the treatment and prognosis. So very, very important table. UIP, the age of presentation, elderly, 50 to 60 years, males more involved than females. It involves smokers. Patient will have chronic symptoms. So over months to years, patient will have chronic symptoms over months to years. So there can be clubbing. And if I put my stent, there will be fine crepitations on auscultation. Elderly male, smoker, chronic symptoms, clubbing, and fine crepitation can be seen. Fine crepitations can be seen in UIP. Whereas biopsy, so in the biopsy there will be characteristic fibroblastic foci. So fibroblastic foci seen, and the involvement will not be uniform. It will not be same throughout. So it is heterogeneous pattern. Fibroblastic foci seen, and the involvement of this disease will not be uniform throughout, so it is called as an heterogeneous pattern. And in CT chest, the disease will be bilateral, lower zone predominant disease. There will be less GGO, minimal ground glass opacity. But one can notice significant traction bronchiectasis, and honeycombing. So this is the CT chest picture of UIP or IPF. Now coming to NSIP, how is the presentation different? So it happens in middle age. Females are more involved than males. Non-smokers also involved. Patient will have subacute symptoms. So days to weeks. And if you put your stent, there will be fine crepitations. And on the biopsy, you don't find those classical fibroblastic foci. So there will be rare fibroblastic foci. and whatever you see is mostly lymphocytic inflammation. Mostly lymphocytic inflammation. And CT chest, the presentation is bilateral, lower zone predominant. So this is also bilateral lower zone predominant. So here we have more of ground glassing opacity. So we have more of ground glass opacity. And there will be some amount of traction bronchiectasis. Because fibroblastic foci are rare, there will be rare honeycombing. So this is the presentation of UIP, usual interstitial pneumonia, or IPF. And on that side, we have seen NSIP. Now, seeing the biopsy features and seeing the CT chest features, you only tell me out of these two, which has good prognosis, which will have worst prognosis. Out of these two, which is good prognosis, which is worst prognosis. NSIP, it is more of GGO, less of honeycombing. So NSIP will have good prognosis. So this will have good prognosis. And what is the treatment here? When you don't know what to give, what will you give in respiratory medicine? Steroids. So you give steroids. So good prognosis. They have observed this disease was having good prognosis with the steroids. Whereas UIP IPF, there is significant traction bronchiectasis and honeycombing. So there is severe architectural damage to the lung. So these patients generally have poor prognosis. And these patients we give treatment. So initial treatment will be drugs such as pirfenidone, nintedanib. So what is this pirfenidone and nintedanib? These are drugs which will stop further progression of fibrosis. Kindly remember, pirfenidone and nintedanib cannot reverse the fibrosis. These can stop further progressing into fibrosis. Now suppose a patient has come to you with 60% lung involvement. If you give these drugs, the involvement will be stopped to 60%. So it cannot reverse the disease. It can only stop further progression. Because already the lung is damaged and even the treatment is not reversing the disease. If at all they ask you, what is the best ultimate treatment for IPF? So your answer should be a lung transplant. Already this is a severe disease and you are not having sufficient treatment. So if the patient worsens, the best treatment will be lung transplant. So if they ask you, out of UIP and IPF, which has good prognosis, UIP and NSIP, good prognosis is generally NSIP. Poor prognosis is usually UIP. So two drugs important are pirfenidone and nintedanib. And if they ask you what is the best treatment, it is a lung transplant. Now I'll show you some images. By seeing those images, you should only identify which is UIP, which is NSIP. Now what is this condition? Is it UIP or NSIP? So can you notice here honeycombing, abnormal areas, rounded areas of air at the periphery of the lung. So this everything is honeycombing. This is a CT chest with honeycombing predominance. So what is your diagnosis? Is it UIP or NSIP? It is UIP. It is UIP. Honeycombing UIP. Honeycombing UIP. I'll show you next CT scan. So what is the diagnosis of the second CT scan? So what do you see here? Only mild haziness. Only mild haziness. Only mild haziness. So there will be GGOs, ground glass opacity. What is this? This is NSIP. So very, very important in your exam. They will give you clinical scenario, or they will give you radiological picture, or they will give you biopsy picture. You should be able to identify. So honeycombing UIP, GGO, NSIP. So very important table. We have understood how to differentiate these two: clinically, pathologically, radiologically, and also based on treatment and prognosis. Coming to the next important ILD, acute interstitial pneumonia. Acute interstitial pneumonia, also called as AIP. Also called as AIP. So AIP is also called as Hammond-Rich syndrome. Hammond-Rich syndrome. Hammond-Rich syndrome. So the presentation. Patient can have acute shortness of breath. Acute shortness of breath. Hypoxemia. Along with that, bilateral diffuse pulmonary infiltrates. So where did we come across such a finding yesterday? Acute shortness of breath, hypoxemia, bilateral diffuse infiltrates, ARDS. So the presentation is similar to ARDS, but we don't know what exactly is causing this disease. So that's why AIP is also called as idiopathic ARDS. So this is such a severe disease where you don't know what exactly is causing this. So that's why it was called as idiopathic ARDS. That's why it was called as idiopathic ARDS. So treatment will be supportive. So you have to mechanically ventilate the patient. You should intubate the patient and you should wait, because you don't know what exactly you are treating. Most probably this patients will have high mortality. So patient presents with ARDS, you have excluded all the causes. You cannot find what happened in this patient, why there was such a presentation. Because for ARDS, yesterday I have discussed, there will be some predisposing cause, either a direct or indirect cause. Here patient will not have any such history, he will land up in respiratory failure. Treatment is supportive and there will be high mortality. Next important is cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia. So this cryptogenic organizing pneumonia is characterized by a triad. So three important features. So patient will have pneumonia-like illness. So he can have pneumonia-like clinical features. And if you take a lung biopsy, one can notice accumulation of granulation tissue, accumulation of granulation tissue in airway. So this accumulated granulation tissue in airway, it is called as Masson bodies. And apart from this, there will be presence of interstitial inflammation. So three important features. Patients will have pneumonia-like illness. And if you do a lung biopsy, you can notice accumulated granulation tissue in the airway. So this granulation tissue is called Masson bodies. And there is interstitial inflammation. And CT chest, one can notice bilateral consolidation. and fortunately these patients respond with steroids. So steroids are helpful in management of cryptogenic organizing pneumonia. Now why this is called as a organizing or cryptogenic organizing pneumonia? So there is granulation tissue getting organized in the airway. Granulation tissue getting organized in the airway. So it is called as organizing pneumonia. So why it is happening, nobody knows. So it was called as cryptogenic. So there is granulation tissue organizing in the lung and we don't know why exactly it is happening. So it is called as cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia. So most of the ILDs are idiopathic forms. So we don't know what exactly is causing them, but whenever they are having a specific presentation, you have to identify it and treat it accordingly. So for your exam, very important is always the differentiating features of usual interstitial pneumonia versus non-specific interstitial pneumonia. So if at all they want to give you a question from ILD, one question from this table is definite. One question from this table is definite. Now smoking and ILDs. So introducing you the world's youngest smoker. He is from Malay, Indonesia. He started to smoke from his second year onwards. So now he is 9-year-old. Fortunately, he has stopped. So smoking and ILDs. So these are the lung diseases or these are the ILDs where smoking is considered as a strong risk factor. So smoking is a strong risk factor for development of these ILDs. So write down the list. Respiratory bronchiolitis associated ILD, desquamative interstitial pneumonia. So once this question was asked, so what are the ILDs where smoking is considered as a strong risk factor? These are the ILDs. Respiratory bronchiolitis associated ILD, desquamative interstitial pneumonia, adult pulmonary Langerhans histiocytosis, acute eosinophilic pneumonia, pulmonary hemorrhage syndromes, idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis. So these are the ILDs where smoking is considered as a very strong risk factor. So these are the ILDs where smoking is considered as a very strong risk factor. So ILDs where smoking is considered as a very strong risk factor. So we have respiratory bronchiolitis ILD, desquamative interstitial pneumonia, adult pulmonary Langerhans histiocytosis, acute eosinophilic pneumonia, pulmonary hemorrhage syndromes, idiopathic pulmonary fibrosis. Now my question is, are there any lung diseases where smoking is considered as protective? So write down ILDs less prevalent in smokers. So ILDs less prevalent in smokers. So can you tell me, are there any direct lung diseases where smoking is considered as protective or where it is not at all happening in smokers? Yes? So there are two important diseases. One is sarcoidosis. Next is hypersensitivity pneumonitis. Hypersensitivity pneumonitis. So many studies have shown that this sarcoidosis and hypersensitivity pneumonitis was not frequently happening in smokers. So they thought that smoking might be a protective factor. but it does not mean that in sarcoidosis and hypersensitivity pneumonitis you should advise patient to smoke. So it was based on an observation. So patients with sarcoidosis and hypersensitivity pneumonitis, this was frequently happening non-smokers. So they thought that smoking might be a protective factor. It does not mean in these patients you should write in treatment start smoking. So most probable reason is already smoker's lung is filled with so many diseases. God must have exempted sarcoidosis and hypersensitivity pneumonitis as a discount to smokers. So here on this side, these are the diseases which are very prevalent in smokers. So these are the diseases, ILDs, very prevalent in smokers. So smoking related ILDs, these are the diseases: respiratory bronchiolitis ILD, desquamative interstitial pneumonia, Langerhans histiocytosis, eosinophilic pneumonia, pulmonary hemorrhage syndromes, idiopathic pulmonary fibrosis. So ILD is less prevalent in smokers. This is the group: sarcoidosis, hypersensitivity pneumonitis. So this question is frequently asked. What are the ILDs less prevalent in smokers? Try to solve this question. There was a 75-year-old male. Everything is important here. Dyspnea for exertion, chronic cough over the past 12 months. So PFT reveals FVC of 72% of predicted. FVC is very less. DLCO is reduced. The chest radiograph shows bilateral patchy infiltrates, mostly at the lung bases. And HRCT is showing reticular opacities, honeycombing in the lung bases. Lung biopsy is showing fibrotic foci surrounded by normal lung parenchyma. What is the most appropriate therapy for this patient? So by history, elderly male, chronic symptoms, restrictive lung disease, honeycombing, fibrotic foci on biopsy. So the diagnosis here is UIP, usual interstitial pneumonia. If you cannot find the etiology, it is called as IPF. So this patient is suffering from UIP, IPF. So in this condition, what is the appropriate therapy? Your answer should be pirfenidone. Case number 24, answer is A. Case number 24, option A, pirfenidone. Now if at all they modify the question like this, what will be the best treatment in this patient ultimately? What will be the best treatment in the patient ultimately? Your answer is lung transplant. Lung transplant. Somebody is asking what is the CT chest find. You can find bilateral consolidations in cryptogenic organizing pneumonia. So if they ask you the best treatment in this patient, ultimate treatment in the patient, your answer should be lung transplant. Lung transplant. Now what is this disease? It is characterized by enlarged lymph nodes, non-caseating granulomas. Always this disease is a confusion. What is this disease? Yes, it is sarcoidosis. Sarcoidosis. So write down sarcoidosis. This is a multi-system disorder. This is a multi-system disorder characterized by non-caseating granulomas. Multi-system disorder characterized by non-caseating granulomas. Coming to the etiology. So these American scientists feel it is an autoimmune disease. Japanese brought a theory regarding propionobacteria. We Indians always confuse this still with tuberculosis. On the whole, what causes sarcoidosis is still not clear. So different countries have different theories. Whenever you cannot convince people, it is better to confuse them. This is the thing happening with sarcoidosis. Each and every country has a different theory. but there is no consolidatory evidence for etiology of sarcoidosis. So many theories, autoimmune theory, propionobacterium theory, tuberculosis theory. So on the whole, the etiology is still unclear. So this is multi-system disorder. If they ask you, what is the most common involvement? So most common involvement will be in the lung. So most common involvement will be pulmonary involvement. And this pulmonary involvement is given by a staging called as Scadding staging. So Scadding has classified sarcoidosis involvement into 4 important stages. So we have stage 1. So in stage 1, there will be bilateral hilar lymph node enlargement. So in stage 1, this will be the pattern. So there will be bilateral hilar lymph node enlargement. In stage 2, there will be bilateral hilar lymph node enlargement. Along with that, few areas of lung infiltrates. So stage 2. So bilateral hilar lymph node enlargement and a few lung infiltrates. So usually it will be focal lung infiltrates, maybe localized to upper shuns. Now stage 3. There will be only lung infiltrates. So now the lung infiltrates may be more diffuse like this throughout the lungs bilaterally. So stage 3, only lung infiltrates. Whereas stage 4, it is the last stage characterized by shrinkage of the lung. So there will be fibrosis. So very, very important. Stage 1, bilateral hilar lymph node enlargement. Stage 2, bilateral hilar lymph node enlargement with lung infiltrates. Stage 3, only lung infiltrates. Stage 4, fibrosis. Because most common is lung involvement in majority. So most commonly these patients will be having respiratory symptoms. So patient can present to me with cough. Patient can present to me with shortness of breath. Because lung is commonly involved, so the presentation in sarcoidosis will be of respiratory symptoms. Cough, shortness of breath. Now next thing they ask you is the multi-system involvement of sarcoidosis is given by few recognizable phenotypes. So write down phenotypes of sarcoidosis. So first important phenotype is lupus perineo. So this is a phenotype involving the skin. So there will be skin involvement. So where all the skin is involved? The skin over bridge of nose and area beneath eyes and cheeks. So there can be some hard nodular area seen in bridge of nose, area beneath eyes and cheeks. Next important phenotype that we have is Lofgren syndrome. So in these patients, there will be combination of erythema nodosum, uveitis, hilar lymph node enlargement, arthritis. So Lofgren syndrome consists of these components: erythema nodosum, uveitis, hilar lymph node enlargement, arthritis. And important feature of this is Lofgren syndrome has good prognosis. So in majority, it will resolve after few months. So Lofgren syndrome, it has good prognosis. And third important is Hereford syndrome. So this is next phenotype, Hereford syndrome. So this Hereford syndrome is also called as uveoparotid fever. Uveoparotid fever. So there will be uveitis, parotid enlargement, parotiditis. Patient will have fever, and most importantly, 7th cranial nerve palsy. So all these are various involvements in sarcoidosis. So sarcoidosis, not just with lung involvement, it can present with skin involvement. It can present with cranial nerve involvement. These are various phenotypes of sarcoidosis. So you should be clearly knowing what is lupus perineo. What are the components of Lofgren syndrome? What are the components of Hereford syndrome? What are the components of Hereford syndrome? So frequently asked question, most common cranial nerve involved in sarcoidosis. What should be your answer? 7th cranial nerve. Most common cranial nerve involved in sarcoidosis, it is 7th cranial nerve. Most common cranial nerve involved in sarcoidosis, it is 7th cranial nerve. It is 7th cranial nerve. So phenotypes of sarcoidosis, all these are direct questions. What you should know, what is lupus perineo, what is meant by Lofgren syndrome, and what is meant by Hereford syndrome. Now, by seeing the clinical features, now you are suspecting this to be sarcoidosis. Now, what are the investigations that are helpful to confirm sarcoidosis? So, write down investigations. So, we will start with basic blood investigation, CBC. So, in CBC, you can notice peripheral lymphopenia. So in CBC, there will be peripheral lymphopenia. So within the circulation, lymphocyte count will be reduced. Lymphocyte count will be reduced. So what is the reason behind this? Whenever there is sarcoidosis happening in your body, it starts in the lungs. So to fight against sarcoidosis, your body uses lymphocytes. So what will your body do when sarcoid disease is starting in the lungs? So it will divert majority of the lymphocyte into the lungs. So where will lymphocytes be less? In the circulation. Where will they be in excess? In the lungs. So peripheral lymphopenia, this is due to sequestration of lymphocytes into lungs. Sequestration of lymphocytes into lungs. Next important thing is, we know in sarcoidosis there is a granuloma. So in sarcoidosis there are granulomas formed, and these granulomas are capable of producing some substances. So these granuloma can produce an enzyme called as ACE. So it can produce angiotensin converting enzyme. So because of that, within the blood, serum ACE levels will be elevated. There will be elevated serum ACE levels. And this granuloma is also capable of increasing the level of 1,2,5-dihydroxy vitamin D. So whenever 1,2,5-dihydroxy vitamin D is increasing, what reabsorption increases? Calcium. So patients with sarcoidosis can present with hypercalcemia. So granuloma has the capability to secrete ACE. So within the blood, ACE levels increases. it has capability to increase 1,2,5 dihydroxy vitamin D, so there will be hypercalcemia. Then CT chest. So CT chest will help me to know the pulmonary and mediastinal lymph node involvement. So I can know by seeing the CT chest, I can see the pulmonary and mediastinal lymph node involvement. So CT chest will help me to recognize the pulmonary and mediastinal lymph node involvement. Now my question is, there is another common disease which has both lung and mediastinal lymph node involvement. So what is that disease? Tuberculosis. Now by seeing the lymph node involvement, of tuberculosis versus sarcoidosis, how to differentiate? So write down. In TB lymph node, there will be a central hypodensity. So central hypodensity is due to necrosis with peripheral rim enhancement. So try to understand this phenomena. In both sarcoidosis and tuberculosis, the lymph nodes can be involved. Now in a CT, how do you differentiate a TB lymph node versus sarcoid lymph node? So in a TB lymph node, what happens is the central portion will be hypodense, less dense, because there is necrosis. The peripheral portion, even though it is normal, because the central portion has become less dense, the peripheral portion will appear slightly more dense. So this phenomena is called as central hypodensity with peripheral rim enhancement. Whereas in sarcoid lymph node, there is no necrosis. So the enlarged lymph node will have single or uniform density. So there will be only a single or uniform density. So this differentiation is very, very important. So in TB lymph node, there will be two densities. What is the reason? Because the central portion, because of necrosis, it will appear less dense. Periphery, even though it is normal, it will appear a bit more dense because of comparison of the densities. So this is called as central hypodensity with peripheral rim enhancement. Sarcoid lymph node, single or uniform density. Next helpful investigation is a bronchoscopy. So within the bronchoscopy, if I collect any fluid, it is called as bronchoalveolar lavage. So if I take a tissue, it is called as bronchoscopic biopsy. So generally the biopsy will show non-caseating granulomas. And within the bronchoalveolar lavage, which cells will be in excess? So there will be sequestration of lymphocytes into the lungs. So bronchoalveolar lavage will show plenty of lymphocytes. And within these lymphocytes, there is a peculiar feature. So when you have examined these lymphocytes, there will be more number of CD4 when compared to CD8. So this was an observational finding. So there will be increased CD4 by CD8 ratio. Increased CD4 by CD8 ratio. In silicosis, there will be eggshell calcification. So there will be calcification. Calcium will be very, very wet. That is eggshell calcification. Okay. So within the bronchoalveolar lavage, there will be excess lymphocytes. So there will be increased lymphocytes. And in that increased lymphocytes, CD4 cells will be more seen. So this is called as increased CD4 by CD8 ratio. Then if they ask you what is the investigation of choice, what is the investigation of choice? So whenever they ask you the investigation of choice for sarcoidosis, so write this statement from Harrison. So in a compatible clinical scenario, in a compatible clinical scenario, in a compatible clinical scenario. So in a compatible clinical scenario, biopsy of involved organ, biopsy of involved organ showing non-caseating granulomas, showing non-caseating granulomas is conclusive of sarcoidosis. Non-caseating granulomas is conclusive of sarcoidosis. So if they ask you what is the investigation of choice, definitely it is biopsy. But what you need to know is there should be a compatible clinical scenario. So you should suspect this patient to have sarcoidosis. So you should have an adequate clinical scenario. And in that adequate clinical scenario, biopsy of involved organ showing non-caseating granulomas is conclusive of sarcoidosis. So compatible clinical scenario means patient should have features of sarcoidosis. He should be having lymph node involvement, he can be having skin involvement, he might be having uveitis. So this is the compatible clinical scenario. You should have combination of any of these symptoms that I have shown you in this first slide. So there is that compatible clinical scenario. Now you have performed a biopsy and that biopsy is showing non-caseating granuloma. Then you can confirm it as sarcoidosis. Then you can confirm it as sarcoidosis. ACE means angiotensin converting enzyme. You must have studied it in renin-angiotensin aldosterone mechanism. So in that this enzyme is important. So granuloma has tendency to produce that ACE. Okay. Now coming to an old investigation after bronchoscopy. So this is a old investigation not done nowadays frequently but can be asked in your exam. Gallium scan. So gallium scan, the importance is there will be increased uptake by gallium. There is increased uptake of gallium by involved organs. So increased uptake of gallium by involved organs in sarcoidosis. So this uptake can happen in two areas, in the face and in the chest. In the face there will be increased uptake by parotid and lacrimal glands. Parotid and lacrimal glands. In the chest, there will be increased uptake by mediastinal lymph nodes. So gallium scan, the concept here is whenever there is sarcoidosis, there will be increased uptake of gallium by involved organs. So in the face, there will be increased uptake by parotid and lacrimal glands. In the chest, increased uptake of gallium by mediastinal lymph nodes. Now because of that, what are the findings that you see? So consider this is the patient's face. There will be increased uptake by lacrimal glands. Increased uptake by parotid glands. Increased uptake by lacrimal glands. Increased uptake by parotid glands. So if you consider this is the nose of the patient, it is looking like face of a panda bear. So it was called as panda sign. Sorry if it is not looking like that. So this phenomena is called as panda sign. Increased uptake of gallium by lacrimal glands, parotid glands. So this is a sign in sarcoidosis called as panda sign. Now coming to increased uptake by mediastinal lymph nodes. Consider this is the bronchus, trachea and bronchus. There is increased uptake by right paratracheal node. and bilateral hilar lymph nodes, right paratracheal and bilateral hilar lymph nodes, bilateral hilar lymph nodes. So if I join this appears like a sign. What is this sign? Yes, this is nothing but a lambda sign. This is nothing but a lambda sign. So in the gallium scan, we have a panda sign and lambda sign. Now coming to the treatment. So whenever you are treating a patient with sarcoidosis, you should see whether the patient is symptomatic or asymptomatic. So asymptomatic patient or symptomatic patient. So if patient is asymptomatic, I can wait and watch. No need to start any treatment, because in sarcoidosis there is a property called as spontaneous resolution. So we don't know why exactly sarcoidosis is happening. In few patients it can resolve by itself spontaneously. Whenever patient is not having any symptom, you can wait and watch for spontaneous resolution. If patient is symptomatic, you should start treatment. So this sarcoidosis is also considered as some abnormal immune response. So whenever there is an abnormal immune response, what is the most important drug you should give? Steroid. So later on, other additional drugs you can also include. So other drugs helpful in sarcoidosis: hydroxychloroquine, the famous HCQ. So then methotrexate. So this is the treatment algorithm. If patient is asymptomatic, I can wait and watch for spontaneous resolution. If patient is symptomatic, sarcoidosis is also some abnormal immune response, I should start steroid. Along with that, later on I can add hydroxychloroquine, methotrexate. So patient is non-symptomatic, why will he come? After age of 50, he has just taken a chest X-ray. Incidentally, there were lymph nodes on chest X-ray. He went for some surgery. He went for some abdominal surgery. Incidentally, there were lymph nodes on chest X-ray. So will nobody take a chest X-ray routinely to evaluate themselves after 40 or 50? Yes. So incidentally diagnosed. See, he went for some other complaint. A routine chest X-ray was taken. So there you found lymph nodes, incidentally diagnosed. Asymptomatic means incidentally diagnosed. Okay. Now this is the classical panda sign. So panda sign, you can see increased uptake by lacrimal and parotid glands. So in the face you see panda sign. So in the chest you see a lambda sign. You see lambda sign. Try to solve this case. A 20-year-old female presents with dry cough dyspnea. Chest X-ray has been performed and demonstrates bilateral hilar lymphadenopathy with bilateral well-defined parenchymal nodules. All will help in evaluation except. So what is the answer here? So first of all, tell me what is the probable diagnosis here. So respiratory symptoms, and you are seeing bilateral hilar lymph node and also some parenchymal infiltrates. So the suspicion is sarcoidosis. All will help in evaluation except. So this is sarcoidosis. Serum ACE levels will help. CT chest will give you idea of lung involvement and also mediastinal lymph node involvement. So gallium scan will also help. So this CD4 by CD8 count is not done in blood. It is done in bronchoalveolar lavage. See, in blood there are very less lymphocytes. If there are very less lymphocytes, there is no point in seeing for CD4 and CD8 count. So CD4 by CD8 ratio is seen in the bronchoalveolar lavage, not in the blood. So answer is option A. So 25. This is a case of sarcoidosis. So if you want to see CD4 by CD8 count, it has to be seen in bronchoalveolar lavage. Answer A. So he is an industrial worker exposed to some particles, later developing some lung disease. What are these lung diseases called as? Occupational lung diseases. Occupational lung diseases. So occupational lung diseases. So write down what is the most common occupational lung disease. Most common occupational lung disease worldwide. Your answer should be silicosis. Most common occupational lung disease. Your answer should be silicosis. Next important point. What is the particle with maximum malignant potential? What is the particle with maximum malignant potential? What is the particle with maximum malignant potential? So particle with maximum malignant potential, the order is asbestos, followed by silica, followed by coal. So actually the malignant potential of coal is not yet exactly known. So we don't know whether coal can cause malignancy or not. So in the question, if they mention most common occupational lung disease, silicosis. Particle with maximum malignant potential, your answer is asbestosis. Particle with maximum malignant potential, it is asbestosis. It is asbestosis or asbestos. Now for your exam, they will ask you the differentiating features of asbestosis, silicosis and coal workers pneumoconiosis. So we'll try to understand this with a table. Asbestosis, silicosis, coal workers pneumoconiosis. So we will see what are the occupations responsible and what are the important features. So occupations and features. Occupations and features of these three diseases. So asbestosis, it is seen in shipbuilders. Occupations responsible, shipbuilders. Construction workers, shipbuilders, construction workers, shipbuilders, construction workers. So break will be given after completion of next topic. It will take another half an hour. Please be patient. So occupation here is shipbuilders, construction workers. So important features. So consider this is the lung. Comfortably sitting on the diaphragm, and let this be the heart shadow. So whenever there is some asbestos exposure, so one can notice calcifications on the diaphragmatic and mediastinal pleura. So these calcifications on the diaphragmatic and mediastinal pleura, they are called as pleural plaques. So these pleural plaques are considered as most specific for asbestos exposure. So they say that pleural plaques are considered as visiting cards of asbestos exposure. So pleural plaques are most specific for asbestos exposure. and after a few months there can be development of fluid within the pleural cavity. So this pleural effusion initially will be benign. No issue in this pleural effusion. So it will be benign. So there will be benign pleural effusion. So if the exposure is continuing, there will be development of lower zone fibrosis. So there will be development of fibrosis, and most importantly it was seen in the lower zone. So there will be lower zone fibrosis, and if still the exposure continues, there will be development of malignancy. There will be development of malignancy. So there will be development of malignancy. So if they ask you what is most specific malignancy associated with asbestos exposure, your answer should be mesothelioma. Mesothelioma. If they ask you what is the most common malignancy, your answer should be lung cancer. So one of the reason is smoking and asbestos. Smoking and asbestos, or synergistic. Smoking and asbestos or synergistic in increasing lung cancer. So these both are double trouble. Smoking and asbestos exposure. If a person who is smoking and he is also exposed to asbestos, the tendency of him to develop lung cancer will be more. So most specific is mesothelioma. Most common is lung cancer, and smoking and asbestos is synergistic in increasing the lung cancer. So these are the important findings. So there can be pleural plaques, benign pleural effusion, lower zone fibrosis, and malignancy, most specific mesothelioma, most common lung cancer. Then coming to silicosis, what are the occupations? So occupations: sandblasting, stone crushers. So where all they get exposed to silica. So important features: consider this is the lung. Initially there will be upper zone individual nodules. So in silicosis, initial finding is upper zone individual nodules. So there can be upper zone nodules. As time progresses, these individual nodules can merge together and form large areas of fibrosis. So merging of nodules into large areas of fibrosis. So this phenomena is called as progressive massive fibrosis. So this is also known as PMF, progressive massive fibrosis. And whenever a patient is exposed to silica, an infection can develop in his lung. So what is that infection that can happen? Chronic silicosis, tuberculosis. So these patients can develop silicotuberculosis, and still the exposure is continuing. So this silica exposure can also result in lung cancer. Silica exposure can also result in lung cancer. But there is a very, very important finding in silicosis. There will be bilateral hilar lymph node enlargement. There will be bilateral hilar lymph node enlargement. And within these lymph nodes, calcification was seen more in the periphery. So calcification was seen more in the periphery. So such calcification was called as eggshell calcification. Peripheral calcification, eggshell calcification. So bilateral hilar lymph node enlargement with eggshell calcification. So these are the features of silicosis. Next we have coal workers pneumoconiosis. So the important occupation is coal miners. Now coming to the features. Initially, the features of coal workers pneumoconiosis and silicosis can be similar. Only difference will be the occupation history. So here also there can be upper zone lesions. So initially individual upper zone lesions. So this individual upper zone lesions, this stage is called as simple coal workers pneumoconiosis. As time progresses, there will be merging of these lesions into large areas of fibrosis. So merging of lesions. So this merging of lesions, it is called as complicated coal workers pneumoconiosis. And this is similar to progressive massive fibrosis. So in some books, because this is also merging into large areas of fibrosis, so complicated coal workers pneumoconiosis is also called as progressive massive fibrosis. So similar findings in both silicosis and coal workers pneumoconiosis. So still the exposure can lead to development of COPD. Lung cancer risk is less. So actually we don't know whether it can cause or not. So there is no lung cancer happening with coal exposure actually. So lung cancer risk still we don't know. So whenever I speak about coal workers pneumoconiosis, I should tell you about a combination called as Kaplan's syndrome. So what is Kaplan's syndrome? So this is combination of rheumatoid arthritis and pneumoconiosis. So combination of rheumatoid arthritis and pneumoconiosis. So what are the particles responsible? It was first identified with coal, but recently silica is causing it more frequently. So what is Kaplan syndrome? It is combination of rheumatoid arthritis with pneumoconiosis. So rheumatoid arthritis and pneumoconiosis. What are the particles responsible? Silica and coal. So whenever they ask you about asbestosis, if you observe here, asbestosis is predominantly lower zone disease. Silicosis is predominantly upper zone disease. Coal workers pneumoconiosis is also upper zone disease. If at all they give you a question, there was a construction worker who is having lower zone fibrosis. What should be your answer? Asbestosis. A stone crusher, upper zone nodules and bilateral hilar lymph node enlargement with eggshell calcification. If they mention such history in the question, silicosis. And if they mention a coal miner is having respiratory discomfort and also joint pains. So respiratory discomfort is equivalent to pneumoconiosis. Joint pains is equivalent to rheumatoid arthritis. So what is this combination called as Kaplan's syndrome? So within this single table, they can ask you multiple questions based on the presentation. So what will be the treatment of all these diseases? See, it is just to support you. So once the disease has happened, you cannot reverse the disease. Support you in the sense, if patient is having some infection, we give antibiotic. If patient is having hypoxemia, we give him oxygen. If possible, we send him for lung transplantation. So more than that, we cannot do anything in occupational lung diseases. Mostly the treatment is supportive. Try to solve this question. A 50-year-old stone mason, okay, smoker currently working in a zoo is referred for chronic dry cough and shortness of breath. So chest X-ray and CT scan are given below. Probable diagnosis. So here occupation history is there, smoking is there. But if you see in this patient, there are upper zone dense nodular lesions. So in the CT scan also you can see upper zone dense nodular lesion. So silica exposure with dense nodular exposure, this is called as progressive massive fibrosis. So this progressive massive fibrosis is a very severe form of fibrosis. All the nodules will merge together, making that area very, very wide. So when you are commenting about progressive massive fibrosis, you should always have a relevant clinical history. So this patient is a stone mason, means there is exposure to silica. So silica exposure with upper zone dense nodular areas. So this phenomena was called as progressive massive fibrosis. Answer here is option D. Now what is this disease? So patient, because of upper airway closure, suddenly wakes up in this sleep. What is this disease? Yes. So this is obstructive sleep apnea, a type of sleep apnea. So write down what is meant by apnea. So apnea means cessation of airflow for at least 10 seconds. Apnea means cessation of airflow for at least 10 seconds. So there is another terminology that you should know, hypapnea. This is not complete stoppage of airflow, more than 30% reduction in airflow, more than 30% reduction in airflow associated with more than 3% fall in SpO2, more than 3% fall in SpO2. Apnea means completely the airflow is stopped. Hypapnea means partial reduction. So about 30% reduction in airflow associated with 3% fall in SpO2. SpO2 means saturation of oxygen, which we measure with a pulse oximeter. Now, if at all these events are regularly happening in sleep, they are called as sleep apnea syndromes. So they are called as sleep apnea syndromes. So based on the presentation, sleep apnea syndromes are classified into two forms. So central sleep apnea, also written as CSA. Obstructive sleep apnea, written as OSA. So we have central sleep apnea and obstructive sleep apnea. Central sleep apnea, obstructive sleep apnea. So let us see what is happening in central sleep apnea. So in central sleep apnea, there is apnea, no respiratory effort. Apnea, no respiratory effort. So we exactly don't know the precise pathophysiology of central sleep apnea. So they thought this was due to some altered ventilatory drive. Altered ventilatory drive. And it was observed in CHF, congestive heart failure, narcotic use. Whereas obstructive sleep apnea, this is the most common form. So central sleep apnea is very rare. Obstructive sleep apnea is most common. So there will be apnea and persisting respiratory effect. Persisting respiratory effect. So why this is happening? This is due to excess upper airway closure during sleep. Excess upper airway closure during sleep. And in majority, this is obesity related. In majority, this is obesity related. First, let us start with central sleep apnea. So let us start with central sleep apnea. So what is happening in central sleep apnea? So whenever I say central, it means problem is in the brain. Problem is in the brain. So your respiratory center is not giving sufficient stimulus to your respiratory muscles. So whenever your respiratory center is not giving sufficient stimulus to your respiratory muscles, your respiratory muscles will not function. So when your respiratory muscles are not functioning, there will be no air entering into the lung. So in central sleep apnea, because the problem is in the brain, so there will be no respiratory effort generated. Because there is no respiratory effort, there will be no airflow. So they don't know the precise pathophysiology. They thought it was due to some altered ventilatory drive. It was observed in congestive heart failure and narcotic use. Now coming to obstructive sleep apnea. So in obstructive sleep apnea, the problem is not in your brain. So the problem is mostly in the upper airway. So there will be excess upper airway closure during sleep. Now suppose somebody tightly holds your neck. So whenever somebody tightly holds your neck, what will happen? So there will be stoppage of airflow. So there is stoppage of airflow, apnea. So whenever there is apnea, in obstructive sleep apnea, there is no problem in your brain. There is no problem in your brain. So whenever there is apnea, how will your brain fight against apnea? By increasing the respiratory effort. So in obstructive sleep apnea, the problem is not in the brain. So there will be apnea and your brain will fight by increasing the respiratory effort. So there is apnea and persisting respiratory effort. See, if you still did not understand, catch hold of neck of a person. So what will he do immediately? He'll start increasing the respiratory effort. Because your brain is functioning well, it senses loss of airflow. So when there is apnea with persisting respiratory effort, it means your brain is intact. So problem is not in your brain, problem is in the upper airway. Most probably it is due to some obstruction. Most probably it is due to obstruction. So this is due to excess airway collapse. So this is in majority obesity related. Now for your exam, most important is obstructive sleep apnea. Obstructive sleep apnea. So write down obstructive sleep apnea. What are the risk factors? So what are the risk factors? So first risk factor is obesity. Second is male gender. Third is craniofacial abnormality. So it's small neck. Craniofacial abnormality, short neck. And acromegaly. Acromegaly. So risk factors, we have obesity, male gender, craniofacial abnormalities and acromegaly. Acromegaly. So just wait, be back. I'll tell you why it is obesity related. Okay, just wait. I'll tell you. So main risk factor is obesity, male gender, craniofacial abnormalities, acromegaly. Now, this will be the clinical scenario of a patient with obstructive sleep apnea. So he will be a middle-aged male, generally having comorbidities, will be obese, and it will be his wife who is forcing to consult me. So why is it so? Because these patients will have most important complaint called as snoring. So snoring is the most common complaint in obstructive sleep apnea. Snoring is most important complaint in obstructive sleep apnea. Now let us see what is the pathophysiology of obstructive sleep apnea and why exactly it is a dangerous disease. In a normal individual, so suppose a normal individual, he is standing like this or is sitting like this, his airway will be completely open like this. So whenever he lies down, by gravity, his airway can slightly close. But this will not have any effect in normal individual. Now whenever this fellow becomes obese, now what is going to happen? Around the neck there will be increased fat deposition. In the neck there will be increased fat deposition. So whenever he lies down, because of that fat, the airway will close further. So whenever it is getting narrowed further, now air has to move with more turbulence and it will produce a sound called as snoring. Now if at all he becomes morbidly obese, more and more fat it is getting deposited in the neck. So whenever he lies down during sleep, suddenly the airway will close. So whenever suddenly the airway closes, there will be apnea. So for example, you are having a deep sleep. If somebody tightly holds your neck, what will you immediately do? You will wake up. So when you wake up, this phenomena is called as arousal. So because of obesity or because of compression of upper airway by fat, there will be apnea. So it will be followed by sudden arousal. So it can happen in non-obese when their neck is short, but most importantly in obese. So during sleep, suddenly the airflow stops, apnea. So just imagine you are having a deep sleep, somebody is tightly holding your neck, what will you do immediately? You will wake up. So whenever you suddenly wake up in sleep in panic, so when somebody is in panic, what are the hormones released in your body? So in panic, you either fight or flight, run away. So what is the hormone released in panic? Catecholamines. So because of arousals, there will be increased catecholamine release. So whenever catecholamines are increasing in the body, see, because of this obesity, there will be frequent arousals during the night. So he will sleep, his airway will close, he will wake up. He will sleep, his airway will close, he will wake up. So with each arousal, the amount of catecholamines in his body will increase. So whenever catecholamines are increasing in the body, what will happen to his blood pressure? It will be uncontrolled. If the patient is not having hypertension, he will develop hypertension. If patient is already having hypertension, it will become uncontrolled hypertension. So whenever catecholamines are increasing, blood pressure is fluctuating, there will be damage to vessels even in the heart. So patient can develop coronary artery disease and it can complicate into myocardial infarction. So because of catecholamine surge, there can be arrhythmias, and arrhythmias can cause sudden cardiac death. And always the blood pressure is fluctuating. at some high blood pressure, vessels in his brain can rupture. So whenever vessels in brain ruptures, what will patient develop? He will develop stroke. So because of excess catecholamines, there can be uncontrolled hypertension. See, Anjali Agarwal, why in male gender, in whom stress response is more predominant male? Who will be more obese male? So craniofacial abnormalities. Your neck is short, so whenever he lies down, airway can close more significantly. In acromegaly, the tongue is very big. The tongue can fall back, resulting in obstructive sleep apnea. Okay. So uncontrolled hypertension. So patient can develop coronary artery disease, myocardial infarction, arrhythmias. It can cause sudden cardiac death. And next important thing, it can result in stroke. So whenever catecholamines are increasing in your body, what will happen to blood sugars? Blood sugars will also increase. So he will have uncontrolled hypertension and also poor glycemic control. Uncontrolled hypertension, poor glycemic control. See, very simple to understand. So whenever there is a patient with hypertension or a patient with coronary artery disease, what is the first thing you advise him? You ask him to stay relaxed. You ask him not to panic, because whenever he panics, the catecholamines will increase in his body, the BP will become uncontrolled, coronary artery disease can precipitate into myocardial infarction, arrhythmia, sudden cardiac death and stroke. So this is the same thing. Each and every time there is apnea, there will be an arousal. When there is a sudden arousal in sleep, he will be in panic. Because of panic, there will be surge of catecholamines in his body. Because of frequent apneas, the amount of oxygen going into his body will reduce. So oxygen going in his body will reduce. So there will be hypoxemia. So hypoxemia in long run will cause pulmonary vasoconstriction. So this pulmonary vasoconstriction will cause pulmonary hypertension and right ventricular dysfunction called as cor pulmonale. Now because of frequent arousals in the night, what will happen? There will be decrease in sleep quality. So he will be not having proper sleep. So he feels to sleep more throughout the day. So there will be excess daytime sleepiness. And because he is always sleepy, so he cannot concentrate on any activity. So there will be altered behavior. He will be depressed regarding his behavior. So there will be depression. And even while driving car, he will fall asleep. And hit somebody, resulting in road accidents. So this is the pathophysiology of obstructive sleep apnea. So this is a very, very important flowchart. So pathophysiology of obstructive sleep apnea. So most important event is apnea. Suddenly when the airflow stops, patient will wake up from sleep in panic. Whenever there is panic, catecholamine surge will happen. So that surge can cause uncontrolled hypertension, uncontrolled diabetes. So that surge can cause heart disease, myocardial infarction, arrhythmia, sudden cardiac death, stroke. Because of continuous apneas, oxygen in the body decreases, hypoxemia, pulmonary vasoconstriction, pulmonary hypertension and cor pulmonale. So excess daytime sleepiness, altered behavior, depressions, road accident, and a lot of psychosocial abnormalities. Yes. So excess daytime sleepiness without OSA. So it means that you are having some behavioral abnormality. So suffering from OSA. Okay. So whenever you sleep, there will be an arousal. Because normally people sleep more during the night. It is more seen during the night. Now, there is a patient with some of these features. And you are suspecting this fellow to have obstructive sleep apnea. How will you investigate further? So write down gold standard investigation. Gold standard investigation or gold standard test for obstructive sleep apnea. So your answer should be polysomnography. Your answer should be polysomnography. So poly means multiple, somno means sleep, graphy means study. I am going to study his sleep with multiple parameters. So what are the parameters in polysomnography? We have EEG, electroencephalography, EOG, electrooculography, EMG, electromyography, ECG, electrocardiography, SpO2, saturation of oxygen measured by a pulse oximeter. So Preeti Yadav, you are asking how poor glycemic control. See, what will increase glucose? Yes, catecholamines have tendency to increase the glucose levels in the body. If you ask how catecholamines increase glucose levels, so that is basic physiology, okay? It can result in glucogenolysis, it can also cause gluconeogenesis. So EEG means electroencephalography, EOG electrooculography, EMG electromyography, ECG cardiography, EEG encephalography, EOG oculography, EMG myography, ECG cardiography, SpO2 saturation of oxygen. Then we have separate sensors for oronasal flow. So there will be a oronasal flow sensor. There will be a sensor to measure thorax and abdominal movements. And there is a specialized device which will measure the intensity of snoring, snore mic. So it measures the intensity of snoring to know whether actually the patient is snoring or his wife is just complaining. Things like that also will happen. And there will be sensors to know body position, limb activity. So sensors to see the activity of the limb and also body position during the sleep. Now you have done a sleep study. So in the morning you will get the sleep study report. By seeing the sleep study report, how will you assess the severity? So assessment of severity of obstructive sleep apnea. So for assessment of severity of obstructive sleep apnea, you are having an index called as apnea-hypapnea index. Apnea-hypapnea index. So this is also written as AHI. So AHI will let me know average number of apneas and hypapneas, average number of apneas and hypapneas per hour. So if at all patient's AHI is less than 5 per hour, it is considered as normal. If patient's AHI is in the range of 5 to 14 per hour, this is considered as mild obstructive sleep apnea. Patient's AHI 15 to 29 per hour. So this is moderate obstructive sleep apnea. AHI more than or equal to 30 per hour. Severe obstructive sleep apnea. So you do a sleep study. In the sleep study report, you will get a parameter called as apnea-hypopnea index. So if it is in the range of 5 to 14 per hour, mild obstructive sleep apnea. So 15 to 29 per hour, moderate obstructive sleep apnea. More than or equal to 30 per hour, severe obstructive sleep apnea. So if it is mild obstructive sleep apnea, most important will be lifestyle modification. So lifestyle modification. So what is this lifestyle modification? Diet restriction, weight reduction, don't smoke, don't drink, sleep well, all this. So lifestyle modification includes weight reduction, diet restriction, do exercise, don't smoke, don't drink, all this. Majority of patients will not follow this. Ultimately, they land into moderate to severe obstructive sleep apnea. Moderate to severe obstructive sleep apnea. So in these patients, medical management of choice. Medical management of choice is CPAP, continuous positive airway pressure. So CPAP, continuous positive airway pressure, continuous positive airway pressure. In few, there is also a surgery performed, uvulopalato-pharyngoplasty. So uvulopalato-pharyngoplasty can decrease the thickness of tissue within the upper airway and can facilitate better airflow. But it is a very, very invasive surgery. So for all practical purposes, medical management of choice is CPAP, continuous positive airway pressure. So how is AHI calculated in the sleep study? So that mission itself will record how many apneas and hypopneas are happening. So there will be specialized sensors. So those sensors will tell you how many apneas and hypopneas are happening. It is an automated mission. It is an automated mission. So snoring can also be physiological. So moderate to severe obstructive sleep apnea, the medical management of choice is continuous positive airway pressure. Continuous positive airway pressure. Now I'll show you some images so that you can understand what is sleep study, how CPAP actually works. So this is a sleep study that I am performing in the hospital. So easiest thing is connecting all these sensors. Difficult thing is asking him to sleep with this. So however, I convince him, counsel him, he is going to sleep throughout the night for 6 to 8 hours. In the morning, I am going to get the sleep study report. So in this sleep study report, there will be apnea-hypopnea index, apnea-hypopnea index. So that will let me know the severity of obstructive sleep apnea. Now, let us see how CPAP works. So this is normal breathing. You can see airway is open, no issue. In obstructive sleep apnea, there is excess closure of upper airway. So there is excess closure of upper airway that is resulting in obstructive sleep apnea. Now what will be the effective treatment here? Effective treatment here is I will connect a mask, and in a mission called as CPAP, I will continuously give positive pressure. So this CPAP will continuously give some positive pressure. Now if at all a balloon is closed like this, what is the best way to open that balloon? By blowing some air. In the same way, whenever your airway, upper airway is closed, if you continuously give positive pressure, your upper airway will remain patent. If upper airway is remaining patent, there is no apnea. If there is no apnea, there will be no arousal. If there is no arousal, all the complication tends to decrease. Patient will have good quality of sleep. So this is how CPAPs work. So CPAPs will force air into the throat to keep it open. Air into the throat to keep it open. Okay. So CPAPs will have air into the throat to keep it open. So whenever I show this image, there will be some brilliant students asking me the same old doubts. Sir, this is during sleep you are keeping a mission. Will patient not have any discomfort? So this is the thing that I explain the patient. When a patient reaches to me with obstructive sleep apnea, I will ask him to choose between two options. So one is discomfort due to CPAP or risk of sudden cardiac death due to obstructive sleep apnea. So what will he choose? He will choose that discomfort. So initially there can be some discomfort as patient's body acclimatizes to mission, and it is recognizing the use of that mission, that apneas are getting improved, sleep quality is getting improved, he will tolerate it eventually and there will be no complaint. So this has to be done throughout the night, daily, and throughout the night. It can be done in home itself. It is a small portable mission. Then for how many days it should be prescribed? So generally, initially I prescribe it for at least 6 months. Again, after 6 months, I am going to repeat the sleep study. If he has followed my advice of lifestyle modification and his AHI has come down, so I will slowly taper the treatment. But in majority of the patients, their AHI will not come down, they would have not reduced their weight. So generally it is a long-term management. So first point, there will be some discomfort, but eventually patient will start tolerating it. And second important thing, this is a long-term management of obstructive sleep apnea. It can be done at their home itself. So prone position may not help that much. For how much time can you put an obese patient in prone? Okay. So CPAP, it costs about 40 to 50,000. So obstruction most commonly happens at the level of soft palate. Most commonly at the level of soft palate. Modafinil, no role in obstructive sleep apnea. So best is medical management. You should give CPAP. So all this modafinil only to increase the activity of the patient, to decrease the drowsiness. So you make him sleep properly in the night. So that will be sufficient. Okay. So we'll take break for 15 minutes and we'll return back. So any contraindication to CPAP? So nothing like that. So CPAP is a type of non-invasive ventilation. CPAP is a type of non-invasive ventilation. So treatment of central sleep apnea, treat the heart failure. You can give NIV here also. So lateral position. So how can a patient for night 8 hours go in a lateral position? It is very difficult. Are you going to tie him during sleep? So sleep is a physiological aspect. He has to sleep comfortably. All you are prone, making him sleep for prone position. Are you going to sit on him and put him on prone throughout the night? It's not possible. Let him sleep on whatever position he wants. Just connect him to a mission. occupational lung disease slide. So patient is not tolerating CPAP, you can go for surgery, and if there is large tongue, also you can go for tongue-based surgery. Craniofacial abnormalities, you can go for surgery. So lean person, his neck might be short. That might be reason for snoring. Okay. So tuberculosis, the topic, generally in the month of October, there will usually be an update. So tuberculosis I am not going to cover today. So the reason is there will be an update very soon. So once the update comes by the October first week, I will give you a recording video, no issue. So tuberculosis will do a recording video. So all the new updates, because if I teach now, again most probably in October the guidelines are going to change. Because of COVID it has been delayed. So already we are having a raw copy, but still it is not into the NTEP. Okay, welcome back. So next topic. So this patient can be a heavy smoker. Ultimately a growth in the lung like this happens. So what is this disease? Yes, smoking and growth in the lung. So this is nothing but lung malignancy, bronchogenic carcinoma. Lung malignancy, bronchogenic carcinoma. So we are going to discuss primary lung malignancies. So primary lung malignancies. So primary lung malignancies can be classified into two forms. We have non-small cell lung cancer, non-small cell lung cancer called as NSCLC, and other is small cell lung cancer. Small cell lung cancer, also called as SCLC. So we can divide it into non-small cell lung cancer and small cell lung cancer. So in non-small cell lung cancer, we have adenocarcinoma. So adenocarcinoma. Next important variant is squamous cell carcinoma. Squamous cell carcinoma. And third is large cell carcinoma. In small cell cancer, we have only one variant, small cell carcinoma or small cell cancer, only one variant. Old name, old cell tumor. So old cell tumor. So this is the brief classification. Out of this, adenocarcinoma is considered as most common type, both in India and also worldwide. So now adenocarcinoma is considered as most common type, So we have broadly classified malignancy into two categories, non-small cell cancer and small cell lung cancer. In non-small cell, we have three variants, adeno, squamous, large. In small cell, we have only one variant, that is small cell carcinoma, also called as old cell tumor. So for your exam, the differentiating features of adenocarcinoma, squamous cell carcinoma and small cell carcinoma are very, very important. So to understand this, we'll make a single table and complete these differences. So very important table. We have adenocarcinoma, squamous cell carcinoma, other is small cell carcinoma. Adenocarcinoma, squamous cell carcinoma, and other is small cell carcinoma, and other is small cell carcinoma. So adenocarcinoma, the important features. This tumor is peripherally located. So it is peripherally located, and this is most common type of lung cancer in females. Non-smokers, and also young males. So if in the question they mention female with lung cancer, non-smoker with lung cancer, young male with lung cancer, your answer should be adenocarcinoma. And this is also most common histology in asbestos related lung cancer. Most common histology in asbestos related lung cancer. So we know that asbestos exposure causes lung cancer. In that, most common histology is adenocarcinoma. So this is the lung cancer that has highest incidence of clubbing. It causes highest incidence of clubbing, and also it can cause most severe form of clubbing. So what is most severe form of clubbing? Anybody? What is most severe form of clubbing? It is hypertrophic. It is called as hypertrophic osteoarthropathy. Hypertrophic osteoarthropathy. And adenocarcinoma is associated with hematological paraneoplastic syndromes. So what is meant by a paraneoplastic syndrome? Tumor cells can produce few substances that will cause various manifestations. So such manifestations caused by tumor cells are called as paraneoplastic syndromes. So adenocarcinoma has highest incidence of paraneoplastic syndrome, hematological paraneoplastic syndrome. So what is that hematological paraneoplastic syndrome? It causes migratory venous thrombophlebitis. Migratory venous thrombophlebitis. So this is also called as Troche syndrome. So this is also called as Troche syndrome. So these are the important features of adenocarcinoma. So it is peripherally located. It is common in females, non-smokers, young males. Most common histology in asbestos related cancer. It has highest incidence of causing clubbing, and it can cause hematological paraneoplastic syndrome, which is nothing but migratory venous thrombophlebitis, also called as Troche syndrome. Now coming to squamous cell carcinoma. So whenever I discuss about squamous cell carcinoma, you should remember 4 C's. So what are these 4 C's? So this tumor is centrally located. This is associated highest with smoking. So associated with cigarette smoking, and it can cause cavity in the lung. It is responsible for cavity formation, and it causes a paraneoplastic syndrome with respect to calcium called as hypercalcemia. So whenever you are dealing with squamous cell carcinoma, remember these 4 C's. Central location, cigarette smoking, cavity formation, and hypercalcemia. So this hypercalcemia will be very severe, and it is considered as a life-threatening metabolic abnormality. So hypercalcemia is a life-threatening metabolic abnormality in squamous cell carcinoma. So what are the important features of severe hypercalcemia? Patient can present with altered sensorium. There can be polyuria. There can be abdominal pain, altered sensorium, polyuria, abdominal pain. All these are manifestations of severe hypercalcemia. So why there is such a severe hypercalcemia? Because there is increased production of parathormone related peptide by tumor cells. So tumor cells can produce parathormone related peptide as a paraneoplastic syndrome. Because of that, there will be severe hypercalcemia. And this severe hypercalcemia is considered as a life-threatening metabolic abnormality in squamous cell carcinoma. So there will be altered sensorium, polyuria, abdominal pain. So why there is altered sensorium? Whenever there is excess calcium in the blood, around your nerves, when there is excess calcium, your nerves cannot fire properly. Because the neurons are not firing properly, there will be decreased conduction of neurons, confusion, altered sensorium. So why there is polyuria in hypercalcemia? So whenever there is excess calcium in your body, it will not allow antidiuretic hormone ADH to function on the kidney. So whenever antidiuretic hormone is not functioning on the kidney, water will not be reabsorbed, it will be lost in the urine. So there will be polyuria. Abdominal pain. Whenever there is hypercalcemia, the same old story. There can be renal stones. There can be biliary stones. All this can result in abdominal pain. So features of life-threatening hypercalcemia: altered sensorium, polyuria, abdominal pain. Now coming to small cell carcinoma. So this is also centrally located. And most importantly, small cell carcinoma has strongest association with smoking. So if they ask you which has strongest association, so both squamous and small have strong association, but strongest is with small cell carcinoma. And next important thing is, this small cell carcinoma is both chemo and radiosensitive. So whenever you find a tumor both chemo and radiosensitive, what do you expect in treatment? You feel it will respond to treatment very well. But what is the issue with small cell carcinoma? If you give treatment, initially it will respond, but there is rapid recurrence and metastasis. So it will respond initially, but later on there will be rapid recurrence and go into metastasis, ultimately leading to poor prognosis. So there is rapid recurrence. And increased chances of metastasis. So because of this, small cell carcinoma is associated with very, very poor prognosis. And next important thing, small cell carcinoma has highest incidence of SVC obstruction. So it can go and invade hematogenous route into the superior vena cava. So increased chances of SVC obstruction. And small cell carcinoma causes many paraneoplastic syndromes. So small cell carcinoma is known for its paraneoplastic syndromes. So what are they? it can cause hyponatremia. So hyponatremia is due to syndrome of inappropriate ADH. It can cause hypokalemia. So why hypokalemia? Because there will be ectopic ACTH production. It can cause hypocalcemia. So why there is hypocalcemia? Because of production of calcitonin by the tumor cells. So tumor cells can produce ADH. So there will be syndrome of inappropriate ADH resulting in hyponatremia. Increased ACTH resulting in hypokalemia. Increased calcitonin resulting in hypocalcemia. Now how to remember this? So if you observe here, there is hyponatremia, hypokalemia, hypocalcemia. So what is meant by hypo? Hypo means less. What is meant by small? Small means also less. So majority of hypos are caused by small cell lung cancer, whereas hypercalcemia is a life-threatening complication of squamous cell lung cancer. Hypercalcemia is a life-threatening complication of squamous cell carcinoma. Along with that, next important paraneoplastic syndrome that must have been discussed in the CNS, it is Lambert-Eaton syndrome. So Lambert-Eaton syndrome, it is a neuromuscular junction disorder. It also happens with small cell carcinoma. So if at all in the question they mention increased clubbing, hypertrophic osteoarthropathy, Troshi syndrome, think about adenocarcinoma. So cavity formation, hypercalcemia, think about squamous cell carcinoma. So both chemo and radiosensitive, poor prognosis, SVC obstruction, all these paraneoplastic syndromes, hyponatremia, hypokalemia, hypocalcemia, Lambert-Eaton syndrome, think about small cell carcinoma. Think about small cell carcinoma. So think about small cell carcinoma. So this is an important table which will solve majority of questions asked on lung cancer histology and differentiating features. So presentation of adenocarcinoma, squamous cell carcinoma and small cell carcinoma. Okay. Next, let us see the clinical features of lung cancer. So why will a patient come to me? So clinical features. So what are the various signs and symptoms? Now consider this is the lung. So this is the lung. And let this be the bronchus. Initially, a small tumor is growing within a bronchus. Within the lung, a small tumor is growing. So whenever a tumor is growing, it can cause irritation to pulmonary mucosa and result in cough. So first important clinical symptom is any growth in the lung can cause irritation to surrounding pulmonary mucosa. So because of that irritation, there will be cough. Now if that tumor infiltrates a blood vessel, so even in the bronchial wall there will be blood vessel. If it invades a blood vessel, so infiltration of vessel. So whenever a blood vessel is infiltrated, now what will patient develop? Hemoptysis. So now what will patient develop? Hemoptysis. Now if at all the tumor grows in size and occludes the bronchus, there will be development of bronchial obstruction and collapse. So tumor growing in size, it can occlude a bronchus. It can cause bronchial obstruction. So bronchial obstruction that results in collapse. So whenever there is collapse, a part of lung is not taking part in oxygenation. So patient will develop shortness of breath. See, if a part of lung is blocked and it is not participating in oxygenation, patient might develop hypoxemia and there will be hyperventilation resulting in shortness of breath. Now this tumor, it may extend onto the pleural surface. So tumor can extend onto the pleural surface. So whenever pleural membrane is involved, there will be pleuritis. So pleural inflammation. So this pleuritis can cause chest pain. And because of involvement of pleura, later fluid can get accumulated. So there will be accumulation of fluid within the pleural cavity. So this manifestation is called as pleural effusion. Pleural effusion. Sometimes the tumor can extend outward onto skin and intercostal nerves. So whenever it is extending onto skin and intercostal nerves, because of involvement of these nerves, patient can have chest pain. Now tumor has caused lot of problem in the lung. Now it is going to the adjacent compartment. So what is the adjacent compartment of the lung? It is the mediastinum. So if at all the pericardium is getting involved. So if at all pericardium is getting involved, there will be pericarditis. There will be pericarditis and pericardial effusion. So once the tumor reaches the mediastinum, it will involve mediastinal structures one by one. So if at all the esophagus is involved, there will be dysphagia. And there is a nerve which turns around like this in this area. So what is the nerve which turns around like this? If at all this nerve is involved. So this is an important nerve in this area. So this is called as recurrent laryngeal nerve. So whenever recurrent laryngeal nerve is involved, what will patient develop? Hoarseness of voice. So patient will develop hoarseness of voice. So there will be change in voice of the patient. So whenever recurrent laryngeal nerve is involved, there will be hoarseness of voice. Sometimes the tumor can involve a big blood vessel in the neck. So what is this big blood vessel in the neck that tumor can involve? It is SVC. So there can be SVC obstruction. So called as superior vena cava obstruction. Superior vena cava obstruction. So what are the findings in superior vena cava obstruction? There will be neck swelling. Along with that, dilated veins over chest wall. So dilated veins over chest wall. Now there is a beautiful structure in the neck, so which contains so many sympathetic nerves. So what is that structure? Stellate ganglion. So whenever stellate ganglion is infiltrated by the tumor, so if at all stellate ganglion is infiltrated by the tumor, so what is this disease called as? Horner's syndrome. Horner's syndrome. So what are the features of Horner's syndrome? So come on, tell me. Horner's syndrome is due to involvement of stellate ganglion. Horner's syndrome is involvement of stellate ganglion. So this stellate ganglion, is it sympathetic ganglion or parasympathetic ganglion? Sympathetic ganglion or parasympathetic ganglion? It is a sympathetic ganglion. It is a sympathetic ganglion. So whenever sympathetic ganglion is involved, what will be the features? There will be anhydrosis, meiosis, classical Horner syndrome features, ptosis, loss of ciliospinal reflex, and also anophthalmos. So the features of Horner syndrome can be remembered with a simple mnemonic called as sample. So it is a sympathetic ganglion, and these are the important manifestations: anhydrosis, meiosis, ptosis, loss of ciliospinal reflex, anophthalmos. Now this tumor has caused a lot of mess not only in the lung but also in the mediastinal compartment. Now it is going for distant metastasis. So distant metastasis. So for distant metastasis, they will ask you what is the most common site and what is the most specific site. So most common site is the brain, whereas most specific site is adrenals. Most specific site is adrenals. So these are the various manifestations that can happen in a patient with lung cancer. So don't think all will happen in a single patient. So these are all the possibilities that can happen. So patient can present to me with cough, hemoptysis, shortness of breath, chest pain, dysphagia, hoarseness of voice, Horner syndrome, superior vena cava obstruction. So any combination of symptoms can happen. Now out of all this clinical manifestation, which is considered as most common? So which is the most common clinical feature in lung carcinoma? So they have found out in majority of the patients cough. So cough is the most common clinical manifestation. So cough is the most common clinical manifestation. Cough is the most common clinical manifestation. Now you have identified a patient with some of these features. How will you evaluate further and confirm it as lung cancer? So write down investigations. So what are all the investigations? So we'll start from basic investigations. So we have to send for cytology. So samples, either sputum or if available pleural fluid. So in cytology we look for presence of any malignant cells. So for cytology we look for presence of any malignant cells. And chest X-ray. In the chest X-ray, depending upon the extent of the disease, initially it can be a single small nodule. So this phenomena is called as solitary pulmonary nodule, or it can extend and result in collapse, or you can identify pleural effusion. Because of spread to the mediastinum, your lymph nodes, you can also see mediastinal lymph node enlargement. So these are various manifestations that a cancer can be showing in chest X-ray. A small nodule, collapse, pleural effusion, mediastinal lymph node enlargement. So next important investigation is CT chest. So CT chest will let me know the precise anatomical location. CT chest will let me know the precise anatomical location. Now, what is the gold standard investigation? What is the gold standard investigation? When tumor is the rumor, cancer is your answer, then tissue becomes the issue. So tissue, so how to get the tissue? By biopsy. So biopsy is the gold standard for any malignancy. So I can do either bronchoscopic biopsy or CT guided biopsy or thoracoscopic biopsy. So I'll tell you why tissue is the issue here. I do any one of this method. I take some tissue, send to my pathologist. My pathologist generally returns it back writing sample insufficient. So that is the thing that irritates me the most. So that's why tissue is the biggest issue. So ultimately, once the pathologist labels it as malignancy, so that is the gold standard for diagnosis. So once you have diagnosed it as malignancy, next important is staging. So for staging, we use a PET scan. So PET scan will help for staging. So PET scan means positron emission tomography. It is a metabolic scan. It is a metabolic scan. So already if the patient is having lung cancer, if you find hypermetabolic areas in the liver, adrenals, bones, what does it mean? Those are all metastatic lesions. So this is the simplified algorithm for investigating a malignancy. So cytology, chest X-ray, CT chest, gold standard is biopsy. For staging, PET scan. For staging, PET scan. Next important thing is treatment. So once you have identified it as malignancy, you have staged it adequately. The next thing that matters is treatment. So for treatment, we have an important algorithm. So for treatment, we have an important algorithm. So first you should know what are you dealing with. Is it non-small cell lung cancer or small cell lung cancer? NSCLC means non-small cell lung cancer, or is it small cell lung cancer? So small cell lung cancer, by the time a patient reaches to me, it will be extensive. So by the time a patient with small cell lung cancer reaches to me, already small cell cancer will spread very rapidly. By the time patient reaches, it will be extensive disease. So whenever there is an extensive tumor, we don't go for surgery, because when the tumor is spread throughout the body, so there is no point going and cutting each and every part of the body. If tumor is localized, you can cut and remove that part. If it is spread to various parts of the body, no point in removing all those. So ultimately nothing will be left in the body. So small cell lung cancer, generally it presents as extensive disease. So we go for chemoradiation. So for chemoradiation. So for chemoradiation, what is the preferred regimen that we give? Cisplatin. So radiation, it will be taken care by that radiation oncologist. So chemotherapy is what we physicians administer. So cisplatin plus etoposide. So non-small cell lung cancer, it can be divided into two forms. So resectable lung cancer unresectable lung cancer. So resectable lung cancer, unresectable lung cancer. So don't worry about the lung tumor staging, because lung tumor staging is a very extensive topic. It will take about 45 minutes to 50 minutes. So that I'll cover in a small video. Now because I cannot incorporate lung staging in regular class, because you need to know the mediastinal lymph node anatomy for that. So was lung staging not done in your surgery? Yes? Was it not done in the surgery, CT surgery? Yes, was it not done in CT surgery? Lung cancer staging. So resectable tumor and unresectable, no. Okay, don't worry. So if time permits, I'll do it separately, because I need 45 minutes at least for lung cancer staging, because it is very extensive, biggest staging. If time doesn't permit, so within 1 or 2 days, I'll just upload a video. So don't worry about lung staging. So now we'll see how lung staging helps in treatmentation. How lung staging helps in treatmentation. No, I'll cover. Don't worry. I'll cover. Don't worry. Okay. So lung staging, we'll do it later. Let this complete now. I'll do it. Don't worry. I'll do it. So resectable tumor, unresectable tumor. So what is meant by resectable tumor? So resectable means the tumor is localized. See, what is the principle of doing a surgery in malignancy? So you have to remove the tumor completely. You have to remove the tumor completely so that it does not spread. So resectable tumor means it is a localized tumor, so you can easily remove it. Unresectable tumor means the tumor might be infiltrating onto the trachea. It might be infiltrating onto the mediastinum. It might be infiltrating onto the diaphragm. So you cannot completely remove the tumor, or else already patient might be having metastasis. So generally resectable tumors come under stage 1 to stage 3A. So stage 1, stage 2 up to stage 3A, it is called resectable tumor. Stage 3B to stage 4, these are unresectable tumors. So as of now, just know localized tumors are stage 1 to stage 3A, whereas extensive tumors are stage 3B to stage 4. Stage 3B to stage 4. Okay. So if it is a resectable tumor, treatment of choice is resect it, surgery. If it is a unresectable tumor, you cannot do surgery. You go for chemo radiation. You do chemo radiation. So how is this chemotherapy done for various histologies? So whenever you are choosing chemotherapy for non-small cell lung cancer, you should know the precise histology. Are you dealing with squamous cell carcinoma? Or you dealing with adenocarcinoma? So in squamous cell carcinoma, what is the preferred chemo regimen? So it is combination of cisplatin plus gemcitabine. Cisplatin plus gemcitabine. If gemcitabine is not available, next preferred is paclitaxel. In adenocarcinoma, we give cisplatin plus pemetrexed. Cisplatin plus pemetrexed. So in few areas, instead of pemetrexed, they also give bevacizumab. So this is the outline of chemotherapy for squamous cell carcinoma, adenocarcinoma, So for adenocarcinoma, there is also a special treatment called as targeted therapy. There is also a special treatment called as targeted therapy. So what is meant by targeted therapy? So for tumor to proliferate, there are some genes called as oncogenes. So tumors generally happen due to overexpression of oncogenes. So this targeted therapy is going to hit those oncogenes and decrease their functioning. So we have two important oncogenes in adenocarcinoma where targeted therapy is helpful. So this targeted therapy is only for adenocarcinoma. It is only for adenocarcinoma available. So we have EGFR antagonist. EGFR antagonist. So EGFR antagonist, what are the drugs? The drugs are erlotinib. Other is zefitinib. Erlotinib, other is zefitinib. So next what we have is ALK antagonist. So these are the drugs which can inhibit the overexpression of tumor oncogenes. So under ALK antagonist we have crizotinib. So for treatment of lung cancer, first you should know whether it is small cell or non-small cell. So this is the simplified algorithm. So if you take in Harrison, it is about 10 pages treatment of lung cancer. It is fully written regarding trials. I have taken all the trials into consideration, and whatever the best treatment that we are giving throughout the country, I have incorporated here. So in majority of oncology centers, this is the algorithm they follow. So if it is extensive, small cell, generally it is extensive, chemoradiation. So what is the preferred chemo regimen? Cisplatin, etoposide. Now non-small cell lung cancer, you divide it into resectable, unresectable. Resectable generally means a localized tumor, you can easily resect it. Unresectable means it is a more diffuse tumor, very difficult to do surgery. So resectable, resect it. Unresectable, go for chemoradiation. And when you are planning for chemoradiation, you should know, are you dealing with squamous cell carcinoma or adenocarcinoma? If it is squamous cell carcinoma, this is the regimen. If it is adeno, this is the regimen. So for adenocarcinoma exclusively, there is targeted therapy. We are targeting oncogenes, EGFR antagonist, and other will be ALK antagonist. So apart from that, there is a recent treatment for lung cancer called as immunotherapy. Immunotherapy for lung cancer. So this is a recent update. So two drugs are very, very important. So we have anti-PD-1 antibodies, immunotherapy in lung cancer, anti-PD-1 antibodies. So PD-1 means programmed cell death. So PD-1 means programmed cell death. So these are some receptors or break proteins. Now what was the reason for introducing immunotherapy in lung cancer? What was the reason for introducing immunotherapy in lung cancer? See, whenever I have started the class, I told you one point. So whenever something wrong is happening in my body's defense mechanism will fight against it. So whenever there is a pathology happening in my body will try to fight against it. Now tumor or malignancy is such an aggressive pathology. Why my body's immune system is not fighting against malignancy? This was the question in scientist mind. Why body's immune system is very quiet, not fighting with malignancy? Because that is also a pathology. Why body is not fighting with malignancy? So for that, what was the answer? So this was the answer. So in my body, there are immune cells called as T cells. So I think most of you know immune cells are called as T cells or T lymphocytes. So T cells. On the surface of T cells, there are some break proteins. So there are some break proteins called as PD1. There are some break proteins called as PD1. So these proteins are called as PD1. See, now what is the function of brake in your car? What is the function of brake in your car? Whenever you step the brake, whenever you activate the brake, what will happen? The function of the car will decrease. Car will stop. In the same way, on the surface of T cells also, there will be proteins called as PD1. If those proteins are activated, or if the brake mechanism will be activated, and that will result in decreased T cell function. So this, on the T cells, there is a brake which will decrease its function. Now whenever a tumor starts in my body, so these tumor cells can bind with these brake proteins and activate the brake mechanism. So tumor cells bind with brake protein. So tumor cells bind with brake protein and activates brake mechanism. So whenever that brake mechanism is activated, there will be decreased T cell function. So this is how tumor cells escapes body's immunity. Very simple. This is how tumor cells escapes body's immunity. So tumor cells bind with T cells, activate the brake mechanism and decrease its function and escapes body's defense mechanism. Now what is the solution? Against this mechanism? So the solution is anti-PD1 antibodies. The solution is, I am drawing in green, it is treatment here, anti-PD1 antibodies. Anti-PD1 antibodies. So what are the anti-PD1 antibodies available? Nivolumab, pembrolizumab. So these anti-PD1 antibodies also bind with brake proteins. And it will break that brake proteins, bind with brake proteins and deactivate the brake mechanism. So whenever brakes are removed from your car, once it starts, can you stop it? No. So that results in increased T cell function. So once the increased T cell function happens, these T cells can cause tumor destruction. So this will cause tumor destruction. Okay. So this is the mechanism. See, these tumor cells escape by activating the brake mechanism. So what is the solution? Drugs called as nivolumab, pembrolizumab also bind with that brake proteins and it deactivates the brake mechanism. So it will not allow the brake to function. So once that brake is not functioning, T cell function increase. Now these T cells start destroying the tumor cells. So this is the new immunotherapy in lung cancer. So the mechanism is, by deactivating the brake mechanism, you will increase the T cell function and result in tumor destruction. So these are the two drugs. One is nivolumab, pembrolizumab. Please remember, this is a potential question. Nivolumab, pembrolizumab. helpful in treatment of lung cancer, and they are anti-PD-1 antibodies. Now let us try some questions. A 47-year-old restaurant owner. So he is 47-year-old, but 50 pack year history. See, pack years means number of cigarette packs he takes. So he might be taking 2 to 3 packets of cigarettes every day. So because of that, more than his age, there is pack year history. He is just like a chain smoker with productive cough and blood-streaked sputum. There is cough and blood-streaked sputum. The physical examination is normal. CBC was normal. Sodium is less. Potassium okay. Chloride okay. Kidney and liver function tests are normal. Chest X-ray and bronchoscopy picture is given. So in bronchoscopy picture, what you can see within the lumen, you can see a tumor. So there is a endobronchial lesion. And bronchoscopic biopsy was positive for tumor cells. Which of the following is most likely lung carcinoma causing this presentation? Now tell me. So a heavy smoker, hyponatremia. Very, very important finding here is hyponatremia. And on the chest X-ray, what do you see? You see a central mass. So this is the mass. So central mass, perihilar density. So small cell carcinoma happens centrally. Great association with smoking, and it is having hyponatremia. So the best answer is small cell carcinoma. Best answer. So why it is not adenocarcinoma? Adenocarcinoma generally peripheral. So adenocarcinoma will not have any hyponatremia. Squamous cell carcinoma is usually causing hypercalcemia, not hyponatremia. So large cell undifferentiated carcinoma is very uncommon, and that will also not cause hyponatremia. So hyponatremia, here positive points are hyponatremia, smoking, central tumor. So all this generally points out towards small cell carcinoma. So you can see the features of small cell carcinoma. There will be hyponatremia. There will be strong association with smoking history, and it is central in location. So what is this image I am showing? This is a bronchoscopic biopsy. I put a forceps and I am taking the tissue from the tumor. So this is how we do bronchoscopic biopsy. Now they have given some pictures like this. This patient was having lung cancer. What are these manifestations and what is this lung cancer? So first manifestation. Yes, first manifestation. So initially the inflammation was here, later here, then here. Now it has migrated to here. So gradually the inflammation is migrating. So what is this? This finding is migratory venous thrombophlebitis. So migratory venous thrombophlebitis. Along with this, what do you see in the next image? There is clubbing. So if they mention migratory venous thrombophlebitis is present, along with it clubbing, patient is having a lung tumor. So in which lung tumor you see this? Adenocarcinoma. Direct question. Just identify the images and correlate with the table that I have given. So Troche syndrome, migratory venous thrombophlebitis, clubbing, it is characteristic of adenocarcinoma. Now this was the manifestation and patient is having lung tumor. What is this lung tumor? What do you see? So can you see on this side, this opening is normal, but here there is ptosis. So ptosis and associated lung cancer. What can be this? This can be Horner's syndrome. On this side, there is Horner's syndrome. So there is Horner's syndrome. So what is this? Identify the lung tumor. Let us understand this. So why will Horner syndrome usually happen? So consider this is the lung. There will be a stellate ganglion here. Stellate ganglion here. Generally, tumors of lung apex easily can involve this. Tumors of lung apex can easily involve the stellate ganglion. So what are tumors of lung apex called as? Tumors of lung apex can involve the stellate ganglion. So tumors of lung apex are called as Pancoast tumors. They are called as Pancoast tumors. And what is the most common histology? So most common histology of Pancoast tumor is squamous cell carcinoma, very closely followed by adenocarcinoma. So most common histology is squamous cell carcinoma followed by adenocarcinoma. So what are all the various manifestations of a Pancoast tumor? So there is a tumor in the lung apex. So it can extend upward and involve the stellate ganglion. So it can cause involvement of stellate ganglion resulting in Horner's syndrome. Horner's syndrome. So from here it can extend outward, involve the chest wall and result in destruction of first two ribs. So it can also result in destruction of first two ribs. So first two ribs. And in some conditions this tumor, so this Pancoast tumor can also involve the cervical nerve roots. So it can involve the cervical nerve roots. It can extend upwards posteriorly and involvement of C8, T1, T2 that results in initially pain and later weakness in ulnar distribution of arm. Ulnar distribution. So very simple to understand. So a Pancoast tumor, so there is a tumor here. So directly it can go upward and involve the stellate ganglion. It can come outward and involve the first two ribs. It can extend posteriorly onto the nerve roots involving C8, T1, T2. So whenever C8, T1, T2 are involved, there will be weakness, pain and weakness along the ulnar distribution. So all these three manifestations are given a single name. So what is that name? These manifestations are called as Pancoast syndrome. Try to understand the difference between Pancoast tumor and syndrome. Pancoast tumor means a tumor is present in the lung apex. All the manifestations caused by Pancoast tumor is called as Pancoast syndrome. So in simple words, Pancoast tumor means presence of a tumor in the lung apex. And what are all the manifestations a Pancoast tumor causes? It is called as Pancoast syndrome. Pancoast syndrome. So Pancoast syndrome consists of the manifestations of a Pancoast tumor. So Horner syndrome, destruction of first two ribs, involvement of C8, T1, T2. Involvement of C8, T1, T2. So now what is the answer here? Identify the lung tumor causing Horner syndrome. Your answer should be a Pancoast tumor. So answer will be generally a Pancoast tumor involves the lung apex and causes Horner syndrome. Now next important question is, generally if you want to visualize any lung pathology radiologically, preferred scanning is a CT scan. So to visualize well a lung pathology on a radiological basis, you need to go for a CT scan. Never ever I have told MRI chest. So nowhere I have written MRI chest. there is one indication for MRI chest. That one indication is Pancoast tumor, because Pancoast tumor is involving the nerve roots. So for excellent visualization of nerve roots, MRI chest is helpful. This was also AIMS 2019 question. So indication of MRI chest. Indication of MRI chest. So MRI chest is helpful in Pancoast tumor to assess the nerve involvement. So normally air in the lung will not give proper signals on MRI. So generally when there is air, we will not prefer MRI because air will not give proper signals. But for assessment of Pancoast tumor, we should go for MRI chest, because MRI chest can involve, because MRI chest will give you clear visualization of the nerve roots. So because of that, MRI chest is helpful in Pancoast tumor to assess nerve involvement. Pancoast tumor to assess nerve involvement. Yes. So adeno is peripheral, then why most common histo is squamous? Om Sharma. See, Om Sharma, just common sense. So a tumor can also extend like this. It can start here and it can extend like this. So no need to be peripheral for that. So even a central tumor can extend upward. So if the tumor is here, this is generally called a central tumor. Now identify this lung tumor. 30th question. So what is there in this patient? Dilated veins over chest wall and neck swelling. So this is an SVC obstruction, superior vena cava obstruction, superior vena cava obstruction. So which lung tumor causes superior vena cava obstruction? The answer is small cell carcinoma. The answer is small cell carcinoma. Small cell carcinoma. Small cell carcinoma. So this is SVC obstruction. SVC obstruction generally caused by small cell carcinoma. So whenever I say acid-base balance or arterial blood gas analysis, this will be expression of many of the students, because majority of this is mathematics. So we all hate mathematics, that's why we have come into MBBS. Now mathematics is back with vengeance in the form of arterial blood gas analysis or ABG. So to complete ABG, I at least need 3 hours. So if you cooperate and if you don't spam, I'll try to complete in 2 hours 45 minutes. I'm just telling you, yes. So before only a disclaimer. So this class will take another 2.5 to 3 hours. Okay. So after that it will be concluded. So tuberculosis, a recent update is pending. So usually in the first week of October we get some updates. So because of this COVID pandemic, there is some postponement. So when the update comes out, I'll just make a complete video, or else in the first week of October I'll give you all the updates. Okay. So don't worry, I'll be taking tuberculosis in detail. So I don't want to do it twice. Now I'll tell you some treatment regimen. First week of October, everything will change. You will read that treatment regimen. Then again, when I put a new thing, you say that, sir, it has changed. What to do now? So just wait for another 15 to 20 days. If at all there is a new update, I will tell you with respect to new update. If there is no new update, whatever is recent, I'll tell you. Okay. All of you take a deep breath. Okay. Let's start ABG. We'll try to make it as simple as possible. So you try to follow the class. I will go as slow as possible. Any doubts, you can ask me at the last. Okay. Even if you don't understand in the beginning, once I teach you the whole topic, you will have a clear view. Or else if you read it once again, you will have a clear view. Just for next 2.5 hours, let us ourselves cooperate with each other. So write down normal values. pH 7.35 to 7.45. So these are the normal values. PaCO2 35 to 40 mmHg. Bicarbonate 22 to 26 milliequivalents. PaO2 70 to 100 mmHg. 70 to 100 mmHg. So these are the normal reference values. So these are a set of values: pH 7.35 to 7.45, PaCO2 35 to 40 mmHg, bicarbonate 22 to 26 milliequivalents, and PaO2 70 to 100 mmHg. So in this present lecture, see, for ABG analysis, these three values are very important: pH, PaCO2 and bicarbonate. So if you keenly observe these three values, majority of ABGs can be solved. So in this present lecture, any pH, so these will be my values. Any pH less than 7.35, it will be termed as acidosis. So kindly keep this in mind. Again, whenever I say acidosis, what is normal pH? Don't ask me. Any pH less than 7.35 is acidosis. pH more than 7.45 will be termed as alkalosis. So simple chemistry, pH is less, acidosis. pH is more, alkalosis. So we will take normal PaCO2 for this lecture as 40. We'll take the upper limit values, bicarbonate as 26. So these are the set of normal values that are to be followed in this present lecture. pH less than 7.35 acidosis, pH more than 7.45 alkalosis. PaCO2 normal we take it as 40, bicarbonate we take it as 26. Now let us see what is the relationship. What is the relationship between pH, PaCO2 and bicarbonate? So this relationship is given by a famous equation called as Henderson-Hasselbalch equation. In mathematics, there is a basic equation called as a plus b whole square is equal to a square plus b square plus 2ab. So this Henderson-Hasselbalch equation is such a basic equation for ABG analysis. So whenever I say an equation, it is a formula. So you follow the formula, you will get the answer. pH is equal to 6.1 plus log of bicarbonate plus log of bicarbonate by PaCO2 into 0.03 by PaCO2 into 0.03. So I am not concerned with all these values. I am only concerned with relationship between pH, bicarbonate and PaCO2. Now, if I write this separately, you will get a basic relation. pH is proportional to bicarbonate. pH is proportional to bicarbonate by PaCO2. So this is the most basic relationship that you should know. Even if you don't have any relationship with anybody as of now, at least you should remember the relationship between pH, bicarbonate by PaCO2. Now, in this basic equation, if at all bicarbonate is increasing, so bicarbonate is increasing, automatically what will happen to pH? pH will increase. Whenever any substance added to your body, if it is increasing the pH, what is that substance considered as in chemistry? If anything is increasing pH, what is that substance considered as? Base. It is considered as base. Now, if at all PaCO2 is increasing, PaCO2 is increasing, automatically what will happen with pH? pH will decrease. So any substance when added to the body, if it is decreasing pH, what is that substance called as? Acid. So according to Henderson-Hasselbalch equation, in my body CO2 behaves like an acid, bicarbonate behaves like a base, bicarbonate behaves like a base. So this is the basic concept that you should know. This is the basic concept that you should know. If at all the pH is predominantly changing to CO2, if the pH is predominantly changing due to CO2, so what is that phenomena called as? It is called as a respiratory process. So if PaCO2 is responsible for pH change, that phenomena is called as respiratory process. If bicarbonate is responsible for pH change, that phenomena is called as metabolic process. That phenomena is called as metabolic process. So in simple words, in your body, acid is CO2, base is bicarbonate. If CO2 is the thing responsible for change in pH, it is called a respiratory process. If bicarbonate is responsible for change in pH, it is called as metabolic process. It is called as metabolic process. Now I'll tell you a simple example. Tell me what is the problem or acid-base disorder. Now I'm sitting in this room and I have suddenly stopped my respiration. Now what will be the acid-base disorder in the body? Yes, I have stopped the respiration. So whenever I stop my respiration, in my body CO2 will increase. So whenever CO2 increases, pH will decrease. So decrease in pH is called as acidosis. This is due to increase in CO2. So it is a respiratory acidosis. Respiratory acidosis. Now another example. Now I am running for 2 kilometers and I have come here and I am hyperventilating like this. Now what is the acid-base disorder? So when somebody hyperventilates, there will be carbon dioxide wash out from the body. So whenever CO2 decreases in the body, so pH and CO2 inverse relation, so pH will increase. So increase in pH, it is called as alkalosis. It is due to CO2. So it is called as respiratory alkalosis. So simple words, if CO2 is increasing in the body, it is respiratory acidosis. If CO2 is decreasing in the body, it is respiratory alkalosis. So that should be clear. CO2 retention, respiratory acidosis. So CO2 retention, it is called as respiratory acidosis. CO2 washout, it is called as respiratory alkalosis. Okay. Now another example. There was a patient with diabetic ketoacidosis. Because of accumulation of keto acids in his body, he developed metabolic acidosis. So whenever there is metabolic acidosis in DKA, what is the classic pattern of breathing in DKA? So what is classic pattern of breathing in DKA? So there will be a Kusumal's breathing, very rapid breathing. So why will a patient with metabolic acidosis have such a rapid breathing? What is the physiological basis behind that? So already in this patient, because of diabetic ketoacidosis, there is metabolic acidosis. So to fight this metabolic acidosis, your lungs is trying to send acid like substance out. So what it is trying to do? It is trying to do CO2 washout, and it is trying to create a respiratory alkalosis. So your body, the phenomena of acid base balance is just like action reaction. Now in this condition that I have explained, so action was metabolic acidosis. Because of some disease, there is metabolic acidosis. How will your body react against it? Your body will try to create respiratory alkalosis, so to maintain the pH. So in simple words, if action is through respiratory phenomena, reaction will be through metabolic phenomena. If action is through metabolic phenomena, reaction will be through respiratory phenomena. If there is acidosis, your body will fight against it by generating alkalosis. If there is alkalosis, your body will fight against it by generating acidosis. Classic example is diabetic ketoacidosis. So in diabetic ketoacidosis, there is metabolic acidosis. So to fight against that metabolic acidosis, what this patient is doing Kusumal's breathing. By doing Kusumal's breathing, he is sending out acid like substance called CO2 out. So for this metabolic acidosis, his body is fighting by generating respiratory alkalosis. So this is some physiological defense mechanism. See, whenever somebody beats you, your pain is a physiological response. So whenever you touch a fire, withdrawal of hand is a physiological response. In the same way, in acid-base balance also, if there is an action, there will be a reaction. So the reaction is nothing but a compensatory process. So in simple acid-base disorders, there will be a primary process. Your body will fight against it by generating a compensatory response. So write down. So whatever I have discussed here is a simple acid-base disorder. Simple acid-base disorder, there will be a primary process. To fight against this, your body will generate adequate compensatory response. This is something routinely happening in all of us. So whenever there is a primary process, your body will fight against it by giving an adequate compensatory response. So first we will discuss how to identify the primary process, then we will calculate compensation. So important primary processes are respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis. So these are the important individual acid-base disorders. In all this, I will discuss how will pH, PaCO2, bicarb will behave. pH, PaCO2, bicarb. So let us start one by one. We'll start with respiratory acidosis. Now to call it as acidosis, what should happen to pH? It's simple chemistry and mathematics. So it is not any advanced science, simple chemistry and mathematics. To call it as acidosis, pH should be decreased. So to call it as a primary respiratory disorder, where the change should primarily happen in CO2. So what should happen to CO2? CO2 will be elevated. So to call it as a respiratory acidosis, the primary change should be in CO2 and CO2 should be elevated. So whenever there is respiratory acidosis, I told you the compensation will be like this. For respiratory, it will be through metabolic. For acidosis, it will be alkalosis. So for respiratory acidosis, the body will fight by generating metabolic alkalosis. So bicarbonate will increase. Now, how will a respiratory alkalosis look like? So to call it as alkalosis, pH should increase. To call it as a primary respiratory disorder, where the change should happen, CO2. So what should happen to CO2 in respiratory alkalosis? It will decrease. So for respiratory alkalosis, the compensation will be metabolic acidosis. So bicarbonate will decrease. Bicarbonate will decrease. Now, coming to metabolic acidosis. To call it as acidosis, pH will decrease. To call it as a primary metabolic disorder, the change should happen in bicarbonate. So what should happen to bicarbonate? Bicarbonate should decrease. So for metabolic acidosis, what is compensation? Respiratory alkalosis. Classical example is diabetic ketoacidosis, Kussmaul's breathing. Now, metabolic alkalosis. To call it as alkalosis, pH should increase. To call it as a primary metabolic disorder, change should primarily happen in bicarbonate. So what should happen to bicarbonate? Bicarbonate will increase. So for metabolic alkalosis, what is compensation? Respiratory acidosis. So this is how simple acid-base disorder. So simple acid-base disorder. Now let us see three important rules of acid-base balance. So three important rules. So first rule, let it be any disorder, acidosis or alkalosis, respiratory or metabolic. Always the primary change, compensation. Primary change and compensation will be moving together. It means if primary change is increase in CO2, okay, if primary change is increase in CO2, how will your body compensate? By increasing bicarbonate. If primary change is increase in CO2, respiratory acidosis, so what will be the compensatory response? Increase in bicarbonate, metabolic alkalosis. In the same way, if primary change is increase in bicarbonate, what is this called as? Metabolic alkalosis. How will your body generate compensatory response? By increasing CO2. So there will be respiratory acidosis. So for acidosis, there will be alkalosis. For alkalosis, there will be acidosis. If primary is through respiratory, compensatory will be through metabolic, and this will be vice versa. This will be vice versa. So write down, in a simple acid-base disorder, in a simple acid-base disorder, ABD, okay, primary change and compensation. So primary change and compensation will move together. Primary change and compensation will move together. Primary change and compensation will move together. So if you observe here, any place, CO2 bicarbonate, CO2 bicarbonate, always primary change and compensation will be moving together. Now, if it is a primary respiratory disorder, change in pH with respect to CO2 and bicarbonate will be in opposite direction. If it is a primary metabolic disorder, change in pH with respect to CO2 and bicarbonate will be in same direction. So write down the rules. I will tell you the logic behind this. So second rule, in primary respiratory disorder, in primary respiratory disorder, change in pH. Change in pH. WRT means with respect to CO2 and bicarbonate will be in opposite direction. Will be in opposite direction. Whereas in primary metabolic disorder, change in pH with respect to CO2 and bicarbonate will be in same direction. Will be in same direction. Now what is the logic behind this? So now we'll start with a primary respiratory disorder. Now to call it as a primary respiratory disorder, so where the change should primarily be? So change should happen primarily in CO2. So to call it as a respiratory disorder, change should primarily happen in CO2. How is pH and CO2 related? How is pH and CO2 related? Inverse relation. It means if CO2 increases, pH will decrease. If CO2 decreases, pH will increase. Because in primary respiratory disorder, pH follows CO2. pH and CO2 are having an inverse relation. So change in pH with respect to parameters will be in opposite direction. Because in primary respiratory disorder, pH will follow CO2 and pH and CO2 has a inverse relation and it has a inverse relation. Now coming to a primary metabolic disorder. In a primary metabolic disorder, pH is dependent on which parameter? Primarily bicarbonate. How is pH and bicarbonate related? They are related directly. So pH is directly proportional to bicarbonate. So if bicarbonate increases, pH increases. If bicarbonate decreases, pH will also decrease. So here the logic is, in a metabolic disorder, pH follows bicarbonate. pH and bicarbonate are directly related. So change in pH with respect to CO2 and bicarbonate will be in same direction. So even if you forget this logic, there is a mnemonic. So this mnemonic is called as ROME, ROME. It means in primary respiratory disorder, the change will be in opposite direction. So in respiratory disorder, the change will be in opposite direction. Whereas in a primary metabolic disorder, the change will be in same direction. So in metabolic, it will be same direction. So this is the famous Rome mnemonic. Same direction, metabolic. Respiratory, opposite. Respiratory, opposite. So now if you do some questions, you can understand this better. Even if you don't know anything about ABG, if you follow this simple steps, 70 to 80% of ABG is done. So they have given you these parameters. So whenever they give you ABG parameters like this, first draw arrow marks. See the trend of pH, CO2, bicarbonate. See, even if you don't know anything, just to follow me, I will help you. Now what is happening to pH? pH is reduced. CO2 increased. Bicarbonate increased. So is there any problem up to this? pH decreased, CO2 increased, bicarbonate increased. Now by seeing the pH, first identify, is it acidosis or alkalosis? It is acidosis. So anywhere decline in pH is acidosis. So this is something very basic. pH if it is less, it should be called as acidosis. pH if it is high, it should be called as alkalosis. So decline in pH, acidosis. Now it is respiratory or metabolic. If you see, change in pH with respect to parameters is in opposite direction. So pH is reduced, but parameters CO2 and bicarbonate are increased. So this is in opposite direction. So what should be the primary? Your answer should be respiratory. So this is respiratory acidosis. Next question. You only solve this and let me know what is the answer. Just to draw arrow marks. pH increased. CO2 decreased. Bicarbonate decreased. Now, increase in pH anywhere should be called as alkalosis. It should be called as alkalosis. Now tell me, what is the primary disorder here? Now if you observe, change in pH with respect to parameters is in opposite direction. So what should be the primary? It should be respiratory. So this is respiratory alkalosis. Next question. So just to draw arrow marks, you'll get the answer. Just to draw arrow marks. pH reduced. CO2 reduced. Bicarbonate reduced. Any decrease in pH anywhere is acidosis. Anywhere is acidosis. Now, is it metabolic or respiratory? Is it metabolic or respiratory? See the direction of change. So pH with respect to parameters, same direction. So what should be the name? Metabolic. So it is metabolic acidosis. Next. What is this? Yes, what is this? Just to draw arrow marks and follow that Rome formula, you'll get the answer. pH increased, CO2 increased, bicarbonate increased. So increased pH anywhere is alkalosis. Increased pH anywhere is alkalosis. Now is it metabolic alkalosis or respiratory alkalosis? Change in pH with respect to parameters, same direction. So what should be the name? Metabolic. Metabolic. So once again, go through those three rules. Let it be any disorder, acidosis or alkalosis, respiratory or metabolic, always primary change, compensation. Primary change and compensation will be moving together. If it is a primary respiratory disorder, change in pH with respect to parameters will be in opposite direction. If it is a primary metabolic disorder, change in pH with respect to parameters will be in same direction. So to understand ABG, these three rules are very important. So if you remember these three rules and if you depict ABG like this, you can easily solve anything. So what was the definition of simple acid-base disorder? There will be a primary process and for that adequate compensatory response. So we have understood how to identify the primary process. Next is how to calculate the compensatory response. How to calculate the compensatory response. So calculation of compensation. So let us start with respiratory disorders. So we have respiratory acidosis. In respiratory acidosis, acute respiratory acidosis, chronic respiratory acidosis. Then respiratory alkalosis, acute respiratory alkalosis, chronic respiratory alkalosis, acute and chronic. Now let us see how to calculate compensation. Now you have identified it as respiratory acidosis. Now you should calculate whether your body is adequately compensating or not. So for acute respiratory acidosis, for every 10 mmHg, for every 10 mmHg increase in CO2, bicarbonate increases by, so this is an acute disorder. Still your kidney is not used to this disorder, so it cannot retain much bicarbonate. It will only retain 1 milli equivalent of bicarbonate. Now in a chronic disorder, for every 10 mmHg increase in CO2, for every 10 mmHg increase in CO2, bicarbonate increases by. Now because it is a chronic disease, now your kidney has understood the disease, so it will start retaining more bicarbonate. So bicarbonate increases by 4 milli equivalents. So now we are discussing how to calculate compensatory response. So in respiratory acidosis, we have divided it into acute and chronic. Now on what basis do you call it as acute or chronic? On the basis of, most importantly, clinical history. Now for example, a patient has ingested a foreign body and he is coming to the emergency department. Now is it acute disorder or chronic disorder? Foreign body ingestion, acute disorder. Now if a patient is having a neuromuscular disorder for which he was suffering from months and years together, so there it will be a chronic disorder. Now how to calculate compensation? Now because of some acute disorder, if CO2 from normal value of 40, it has increased to 60 mmHg. It has increased to 60 mmHg. To call it as a compensatory response, bicarbonate should increase from 26 to how much? So this is an acute disorder. For 10, it will increase by 1. For 20, it will increase by 2. So 26 plus 2, it has to increase to 28 milli equivalents. In the same way, if at all a patient is having a chronic neuromuscular disorder and his CO2 has increased from normal value of 40 to 60, his CO2 has increased from normal value of 40 to 60. So it has increased by 20. To call it as an adequate compensatory response, bicarbonate should increase by how much? See, for 10 it is 4. For 20 it will be 8. So normal value, if you take bicarbonate as 26 plus 8, it has to reach to 34. 26 plus 8, it has to reach to 34. So this is how we should calculate. Now for respiratory alkalosis, the formulas are slightly different. So for every 10 mmHg decrease in CO2, bicarbonate decreases by 2 milli equivalents. So because these were calculated on logarithmic scale, so these values were slightly different. So for our respiratory alkalosis, the values are slightly different. For every 10 mmHg, so these compensation values are real values, these are not imaginary values. For 10 mmHg decline in CO2 in a chronic disorder, bicarbonate decreases by 4 milli equivalents. So bicarbonate decreases by 4 milli equivalents. So in respiratory alkalosis also, in the same way, we can calculate compensation for acute and chronic. So in a question, if you identify respiratory acidosis, depending on the clinical history, you can calculate compensation by any one of the formula. If you identify respiratory alkalosis, depending upon the clinical history, you can calculate compensation with any one of this formula. Now if you do some questions, you can understand this better. There was a patient with chronic neuromuscular disorder. NMD means neuromuscular disorder. pH 7.33. PaCO2 was 60. Bicarbonate was 34. Now they'll ask you, interpret this acid-base disorder. Let us go step by step. Whenever you see any ABG, draw arrow marks. pH is reduced. PaCO2 is increased. Bicarbonate is increased. Bicarbonate is increased. So by seeing the pH, is it acidosis or alkalosis? Acidosis. Acidosis. Now, is it respiratory or metabolic? Yes, is it respiratory or metabolic? It is respiratory. Change in pH with respect to parameters opposite. So the primary should be respiratory. Now, is it acute or chronic? So this is a chronic respiratory acidosis because patient is already having neuromuscular disorder. Now how to calculate compensation here? Now if you observe in this question, CO2 value from normal, so 40 is normal, N means this is normal value. It has increased to 60. It has increased by 20. So to call it as a compensatory response, bicarbonate from normal value of 26 should increase by how much? In chronic disorder, for 10 it is 4. For 20 it will be 8. So it has to increase by 8. It has to reach to 34. So in the question, given bicarbonate and expected bicarbonate are correlating. So the best answer is chronic respiratory acidosis with compensatory metabolic alkalosis. But I am very lazy to write this big name. So to make it easy, what I am going to do? So I am going to write it as chronic. So it is acute or chronic? Chronic disorder. Is this disorder adequately compensated? Yes. Chronic compensated. So when you want to mention, always mention the primary disorder. Chronic compensated respiratory acidosis. So instead of writing this big name, because I am lazy, I want a easy manner. So I have written it as whether acute or chronic, chronic. Is it adequately compensated? Yes or no? Yes. And whenever you want to mention, you should always mention the primary disorder. So this is how you should calculate metabolic compensation after identifying a primary respiratory disorder. Now let us see how to calculate respiratory compensation if you find a metabolic disorder. So write down compensation for metabolic disorders. Compensation for metabolic disorders. So we have metabolic acidosis 1 and metabolic alkalosis. Metabolic alkalosis. Metabolic acidosis, metabolic alkalosis. So for metabolic acidosis, there is a special formula. Expected PaCO2. Expected PaCO2 is equal to 1.5 into bicarbonate plus 8 plus or minus 2. So this formula is the famous Winter's formula. Winter's formula. This formula is the famous Winter's formula. Now let us solve a question so that you can understand this better. Suppose if they mention like this, pH 7.29, PaCO2 22, bicarbonate 10. Now let us identify the primary disorder and calculate compensation. Now pH, draw arrow marks, decreased. So decrease in pH anywhere is acidosis. The change is in same direction. So the name should be metabolic acidosis. So whenever you identify a primary metabolic acidosis, you should calculate respiratory compensation. How to calculate? Expected CO2 is equal to 1.5 into bicarbonate. Substitute this value, 1.5 into 10 plus 8 plus or minus 2. So 15 plus 8 plus or minus 2. So 23 plus or minus 2. So it has to be in the range of 21 to 25 mmHg. So how much is expected CO2? 21 to 25 mmHg. How much is given CO2? 22. It is within the range. So you can call it as metabolic acidosis with compensatory respiratory alkalosis. Metabolic acidosis with compensatory respiratory alkalosis. Now you people should get a valid doubt. Sir, you are telling this is a compensated disorder, adequately compensated disorder, but why pH has not come to normal value? Why pH has not come to normal value? So there lies the concept. See, what you need to understand is these compensatory mechanisms are temporary physiological mechanisms in your body to bring the pH to near normal. It cannot normalize the pH. If you want to normalize the pH, you have to treat the underlying disorder. Now, what is the significance of a compensatory process? So, what will happen if there is no compensatory process? So, if at all an acidosis is happening, a metabolic acidosis is happening. So, if there is no compensatory phenomena, the pH will decrease to a very low value where metabolism of your body will not happen, where your body organs will not function. So, the pH will start decreasing. Now, what will this compensatory response do? This compensatory response will try to pull the pH to near normal. So, it will try to give body some time before you give adequate treatment. So, point to remember here is compensatory mechanisms are not the solution for the acid-base disorders. They are temporary process to bring the pH to near normal so that you will have time to treat. So in DKA, respiratory alkalosis is just a compensatory phenomena so that patient will not die of severe metabolic acidosis. So in DKA, why will patient do that Kussmaul breathing? So that before you treat him, at least pH is coming to near normal or pH is not going into that abnormally dangerous range. So understand the phenomena. Whenever I write compensated, it doesn't mean pH should come back to near normal. It should be normalized. Compensatory phenomena, generally what they do, they try to bring it to near normal and it will give you time so that you find out the adequate treatment. Now metabolic alkalosis, it is a simple formula. Expected PaCO2 is equal to bicarbonate plus 50. Expected PaCO2 is equal to bicarbonate plus 15. Say if at all For everything body was compensating. What is the need of you doing MBBS, I doing post graduation, somebody doing super specialty? Body is compensating for everything happening inside. No need of a doctor. So these compensatory phenomena are temporary mechanisms so that a doctor can go and treat that disease. So you will have some adequate time. So body will provide some adequate time before somebody treats it. So these are the 4 important things that we have learned. So if you find a respiratory acidosis, you should calculate compensation with this formula. If there is a respiratory alkalosis, calculate compensation with this formula. If you find a primary metabolic acidosis, so you find a primary metabolic acidosis, you calculate compensation with this Winter's formula. If you find a primary metabolic alkalosis, compensation should be with this. Now with this background, let us revise whatever we have learned up to now in the form of an algorithm, ABG algorithm. ABG algorithm. So in ABG algorithm, before seeing the ABG analysis, always go through the clinical history. Always go through the clinical history. Because ultimately you are not going to treat that acidosis or alkalosis that you see in the ABG. You are going to treat the condition responsible for acidosis and alkalosis. That you can understand only by seeing the patient. So you are not going to treat the numbers there. You are going to treat the condition in the patient that has caused those abnormal numbers. So clinical history is very, very important. Clinical history is very, very important. Now, after going through relevant clinical history, now go through pH. Go through pH. So by seeing the pH, I think most of you now can identify acidosis. Acidosis. Alkalosis. Acidosis or alkalosis. Now, after identifying whether it is acidosis or alkalosis, next step you should identify primary process. So primary process. So what is the primary process? By seeing the direction of change, if it is in opposite direction, it is a primary respiratory process. If it is in same direction, it is a metabolic process. So by seeing the pH, identify acidosis or alkalosis. By seeing the direction of change, identify whether it is a primary respiratory disorder or primary metabolic disorder. So here respiratory process means it can be either respiratory acidosis or alkalosis, metabolic acidosis or alkalosis. Now after identifying the primary process, next important step is compensation. Compensation. So if it is a primary respiratory disorder, what compensation you should calculate? Metabolic compensation. If it is a primary metabolic disorder, what compensation you should calculate? Respiratory compensation. So we have discussed in detail. If it is a metabolic acidosis, this is the compensation formula. Metabolic alkalosis, don't think much. These are some standard formulas. And if it is respiratory acidosis, depending on history, this formula, respiratory alkalosis, this is the formula. So with the given amount of formulas, you are going to calculate compensation. So once you calculate compensation, you are going to compare the values. So in majority of these scenarios, given value bicarbonate will be correlating with expected bicarbonate. On this side also, given CO2 will be correlating with expected CO2. So whenever given value and expected value are correlating. It means there is adequate compensatory response. So what was the definition of simple acid-base disorder? There is a primary process to that adequate compensatory response. So this can be just written as a simple acid-base disorder. If given and expected are correlating, you can just write it as simple acid-base disorder. Very rarely, you can also get a relationship like this. Given bicarbonate is not correlating with expected bicarbonate. On this side also, given CO2 is not correlating with expected CO2. Given CO2 is not correlating and given bicarbonate is not correlating. So whenever they are correlating, it is adequate compensatory response. When they are not correlating, it is called as inappropriate compensation. Previously, they were using the terms such as partial compensation, decompensation, uncompensated. Now all these terminologies have been removed and put under a single heading called as mixed acid-base disorder. Mixed acid-base disorder. So in simple words, if given and expected values are correlating, it is very simple acid-base disorder. If given and expected is not correlating, it is complex, and that complex phenomena is called as mixed acid-base disorders. Now don't worry about this mixed acid-base disorders. Once we discuss all the individual acid-base disorder, I'll tell you in detail finally. Now after calculation of compensation, next step is calculation of anion gap in blood. Calculation of anion gap in blood. So once you calculate anion gap in blood, if at all there is high anion gap, what you should do? So you should compare change in anion gap. In some books, change in anion gap is also called as delta anion gap, and change in bicarbonate. So change in bicarbonate, in some books it is also written as delta. So delta usually is a mathematical expression of something indicating change. So last step is calculation of anion gap in blood. Calculation of anion gap in blood. If there is high anion gap, so compare change in anion gap and change in bicarbonate. So change in anion gap, it is also called as delta anion gap. Changing bicarbonate, it is also written as delta bicarbonate. So once again, go through the ABG algorithm. Clinical history. By seeing the pH, is it acidosis or alkalosis? By seeing the direction of change, if it is in opposite, respiratory, same direction, metabolic. By given set of formulas, calculate compensation. Given and expected or correlating, simple. Not correlating, mixed. Mixed we'll discuss later. And finally, calculation of anion gap in blood. Now what is this concept of anion gap? So write down concept of anion gap in blood and metabolic acidosis. So in my body, generally there are two compartments. So generally there are two compartments. A positive compartment, positive ions, and next is a negative compartment, negative ions. To maintain electroneutrality, always the total number of positives will try to be equal to total number of negatives. So in my body, the total number of positives will try to be equal to total number of negatives to maintain equilibrium. So in positive compartment, there are few ions that we routinely measure bedside. So what are those we routinely measure bedside? Sodium and potassium. In negative compartment also, there are few ions that we routinely measure bedside. So what are the negative ions that we routinely measure bedside? Chloride, bicarbonate. So in my body, always between measured positives and measured negatives, always between measured positives and measured negatives, there is a significant gap. So this gap is called as anion gap. So anion gap is the difference between measured positives minus measured negatives. Now how to understand this? For example, consider this bottle equivalent to negative compartment. So whatever you see here that you measure routinely is measured part. So this is unmeasured part. So measured part, unmeasured part. Now because of any disease, if unmeasured part is increasing, automatically measured part will decrease. Now because of any disease, if measured part is decreasing, automatically unmeasured part will increase. See, just like in this bottle. So this is measured part. So this will be unmeasured part. So these both will coordinate so that always the total volume of the bottle is maintained. So always the measured and unmeasured parts will adjust so that the total volume of the bottle is maintained. Total volume of the bottle is maintained. So write down. For example, this is the measured part. What you measure routinely bedside. This will be the unmeasured part. So measured part. So this will be the unmeasured part. Okay. So for example, I have given you a partially filled bottle. Now if you see, in the measured positive, there is sodium and potassium. So what is normal value of sodium? Yes, what is normal value of sodium? It is somewhere 135 to 145. So whereas normal value of potassium only 3.5 to 4.5. So when compared to sodium, the value of potassium was very less. So recently they have stopped taking potassium into consideration for anion gap. So because when compared to sodium, the value of potassium is very less. So if they ask you what is new formula for anion gap? Anion gap is calculated as Na plus minus chloride plus bicarbonate. So if you calculate with this formula, normal anion gap will be in the range of 8 to 12 milli equivalents. So it can be written as 10 plus or minus 2 milli equivalents. So for all practical purposes, we take 10 as the reference anion gap. So this is important verb. So normal anion gap is equal to 8 to 12 milli equivalents or 10 plus or minus 2 milli equivalents. So for all practical purposes, if they ask you a single value of anion gap, we take 10 as the value. So according to new formula, we are no longer taking potassium because when compared to sodium, the potassium contribution was very less in the measured part. So if they ask you any question regarding anion gap, this should be the formula that you should use. Now this is something normally happening in all of us. In all of us, there is a difference between measured positives and measured negatives. So this phenomena is called as anion gap. This phenomena is called as anion gap. Now let us see what happens in high anion gap metabolic acidosis. Again, positive compartment, negative compartment, high anion gap metabolic acidosis. So in the positive compartment, we have sodium. In the negative compartment, there is chloride and bicarbonate. Chloride and bicarbonate. And always between these two, there is a gap called as, a significant gap called as anion gap. Anion gap. So this is something happening in all of us. Now, for development of high anion gap metabolic acidosis, what is the initiating event? What is the initiating event? So initiating event is addition of acid to body. Addition of acid to body. So there will be an acid added to the body. So for example, let an acid called HNO3 be added to the body. So how will HNO3 divide? H plus NO3 minus. How will H2SO4 divide? H plus HSO4 minus. How will lactic acid divide? H plus lactate. How will formic acid divide? H plus formate. How will oxalic acid divide? H plus oxalate. So in basic chemistry, let it be any acid, ultimately it will divide into H plus and corresponding acid anion. So this acid also enters into my body and it divides into H plus and corresponding acid anion. H plus corresponding acid anion. H plus corresponding acid anion. So whenever H plus is increasing in my body, whenever H plus is increasing in my body, so what is the most important buffer for H plus in my body? Bicarbonate. So this bicarbonate starts binding with H plus and it will be consumed. So gradually bicarbonate is eaten up by the H plus. So whenever bicarbonate is reduced, what is this phenomena called as metabolic acidosis? So you can see the value of bicarbonate decrease. So if bicarbonate decrease, the sum of chloride and bicarbonate decreases. So what gradually happens to the anion gap? It will increase. And moreover, this acid anion is also negatively charged. It will simultaneously add up into the unmeasured part, keeping the anion gap persistently high. So there is consumption of bicarbonate. So that is responsible for metabolic acidosis. That is responsible for metabolic acidosis. And there is increase in anion gap. So because this metabolic acidosis is associated with increase in anion gap, it is called as high anion gap metabolic acidosis. There are 3 events happening after addition of acid. So kindly listen whatever I am telling you. Once again I will revise, because in metabolic acidosis, high anion gap metabolic acidosis, one question definitely they will ask you. So after addition of acid, 3 events. Consumption of bicarbonate, simultaneous addition of acid anion, that results in persistently high anion gap. So once again repeat with me, consumption of bicarbonate, that results in metabolic acidosis, simultaneous addition of acid anion, both put together will result in persistence of high anion gap. Both put together will result in persistence of high anion gap. Now see this image. So see this image. It is as simple as this. So this is a normal individual. So the difference between this positive and negative is called as anion gap. Now after addition of acid, try to identify these three. So addition of acid will result in consumption of bicarbonate, and addition of acid anions to the unmeasured compartment, and finally increase in anion gap. See this video, you will understand everything. So acid is added, it is divided into H plus and acid anion. Now what is happening? Acid anion is being added to this compartment and bicarbonate is getting consumed. So what has happened to anion gap? It is increased. It is increased. So right, see here once again. See, you will see how anion gap is increasing. So acid anion added, bicarbonate decreasing, increase in anion gap. So once again, three steps: consumption of bicarbonate, addition of acid anion, increase in anion gap. So this is the important video that I have made. So write down mechanism. Rise in anion gap. Rise in anion gap is due to simultaneous decrease in bicarbonate and increase in acid anion. So acid anions are nothing but unmeasured anions because we are not measuring it in the formula. So this is the concept. So rise in anion gap. So why this anion gap has increased? Because bicarbonate is consumed. So because bicarbonate is consumed and acid anions have accumulated. But if you see in ABG, you can only recognize rise in anion gap and fall in bicarbonate. You cannot see this increase in acid anions because they are not measured in the blood. So increase in acid anions. So acid anions are nothing but added to the unmeasured compartment. So they are called as unmeasured anions. So unmeasured anions. So when you look at a patient ABG, you can only recognize that the anion gap has increased and bicarbonate has decreased. So because of this, there is a relation here for every. So again, this is also very, very important relationship. For every 1 milli equivalent increase in anion gap, there will be 1 milli equivalent decrease in bicarbonate. So if it is a pure high anion gap metabolic acidosis, you can identify this relation. So for every 1 milli equivalent increase in anion gap, there will be 1 milli equivalent decrease in bicarbonate. See, anion gap is relevant only in metabolic acidosis. In other disorders, even though you calculate anion gap, it is not that relevant. So for every 1 milli equivalent increase in anion gap, there will be 1 milli equivalent decrease in bicarbonate. See, rise in anion gap is due to simultaneous decrease in bicarbonate and increase in acid anions or unmeasured anions. Because you are not calculating the unmeasured anions in the formula, so for ease we have derived this relation. For every 1 milli equivalent increase in anion gap, there will be 1 milli equivalent decline in bicarbonate. Now the next question is, I have written that high anion gap metabolic acidosis is due to addition of acid. Now, how will an acid be added to the body? How will an acid be added to body? Yes, how will an acid be added to body? There are 4 important phenomena. If the patient has taken some toxins or drugs, ketoacidosis, lactic acidosis or renal failure. So write down, I'll explain in detail causes of high anion gap metabolic acidosis. So it can be divided into 4 groups. So 4 groups: patient consumes some toxins or drugs, or because of ketoacidosis, lactic acidosis, renal failure. Now, why will these cause addition of acid to the body? So, toxins such as methanol poisoning, peraldehyde poisoning, ethylene glycol poisoning, and drugs such as aspirin. Now, what is the logic behind this? You must be knowing any alcohol can get converted into aldehyde and finally gives rise to acid. If somebody takes methanol, it will get converted into formic acid. Ethanol can get converted into acetic acid. Ethylene glycol can get converted into oxalic acid. So here methanol, peraldehyde or ethylene glycol, when added to the body, ultimately in the body acid is formed. Now how is aspirin addition of acid to the body? What is aspirin? Aspirin is nothing but salicylic acid. So we have discussed causes of high anion gap metabolic acidosis, and acid should be added. So methanol will get converted into formic acid. Ethylene glycol is also called as antifreeze. So ethylene glycol will get converted into oxalic acid. Because of this, a patient with ethylene glycol poison will have oxaluria, oxalic acid crystals in the urine. Because in his blood oxalic acid is formed that can be excreted as oxalic acid crystals. Now ketoacidosis, it can be either a part of diabetic ketoacidosis, accumulation of keto acids, starvation ketoacidosis, and third important thing, alcoholic ketoacidosis. Aspirin is nothing but salicylic acid, addition of salicylic acid to the body. So lactic acidosis, lactic acid, so it is also addition of acid. Now why in renal failure there can be high anion gap metabolic acidosis? See, kidney is responsible for excretion of majority of acids in the body. So kidney is not functioning well, all the acids will accumulate in the body. Uric acid can accumulate, lactic acid can accumulate, keto acids can accumulate. So these are the 4 important causes of high anion gap metabolic acidosis. So whenever you find high anion gap metabolic acidosis in a question, you have to rule out whether the patient has taken any toxins or drugs. Is there possibility of ketoacidosis, possibility of lactic acidosis, possibility of renal failure? So in ICU, if you find any patient with high anion gap, first rule out these conditions. Did this fellow take any toxin or he is on any drugs? Is there any possibility of ketoacidosis, possibility of lactic acidosis, possibility of renal failure, See, aldehyde can be converted into acid, so it can be converted into butyric acid. So always remember, high anion gap metabolic acidosis or presence of high anion gap, so in relevant clinical history is always significant. So if you find a patient with renal disease, there is high anion gap, so you should rule out whether that fellow has gone into renal failure. A diabetic patient with some high anion gap. You should see whether this fellow is going into diabetic ketoacidosis. Diabetic ketoacidosis. Now coming to normal anion gap metabolic acidosis. Normal anion gap metabolic acidosis. So again, the same concept. Positive compartment. Aishwarya, how renal failure? Kidney is responsible for excretion of acids from your body. Now kidney is not functioning. Will acids go out from your body, yes or no? They cannot go. So Na plus chloride bicarbonate. So always there will be a gap called as anion gap. Now in normal anion gap metabolic acidosis, the initiating event is there will be loss of bicarbonate. So there will be loss of bicarbonate due to some disease. Because there is bicarbonate loss from the body, there will be metabolic acidosis. So whenever bicarbonate is lost, as a reflex mechanism, your kidney can reabsorb chloride. So there will be chloride reabsorption. Because chloride is coming back, the anion gap can stay normal. See, bicarbonate has been lost, there is metabolic acidosis. Because chloride is coming back, the anion gap will stay normal. Because chloride has come back in excess, in some books this acidosis is also called as hyperchloremic metabolic acidosis. It is also called as hyperchloremic metabolic acidosis. So now try to understand this simple concept. In normal anion gap metabolic acidosis, what will happen is there is loss of bicarbonate. So if at all 5 bicarbonate is lost, 5 chloride are taken. So what will happen to total value of chloride and bicarbonate put together? Total value of chloride and bicarbonate put together, it will be the same. So whatever bicarbonate is lost, in the same quantity your kidney can take chloride. So because this is happening, normal anion gap is maintained. So anion gap is not changing because chloride value has now increased. This is also called as hyperchloremic metabolic acidosis. Now you should get a valid doubt. Even in high anion gap metabolic acidosis, when bicarbonate was being consumed as a buffer, if chloride was being taken back, the anion gap should have remained normal. But what is absent here, present there, adding up and causing high anion gap? Yes, what is absent here, present there, responsible for persistence of high anion gap? It is nothing but acid anion. So you can see this acid anion immediately adds up. Not allowing any chloride reabsorption. But in this condition, there is no acid anion. So it is not due to addition of acid. It is just due to loss of bicarbonate. So as a reflex mechanism, chloride can be reabsorbed. Now how will bicarbonate be lost? So what is the most common disorder where bicarbonate is lost? Diarrhea. So in diarrhea, there is loss of lower GI secretions. Rich in bicarbonate. See, in your lower GIT, the secretions will be rich in bicarbonate. And what is the source of bicarbonate to lower GIT? Pancreas. So pancreas will be giving bicarbonate to your lower GIT. So whenever there is loss of lower GI secretions rich in bicarbonate is lost, these patients will develop metabolic acidosis. The next important, in vomiting. in vomiting. So whenever you vomit, there is loss of upper GI secretions. What does upper GI secretions contain? What does upper GI secretions contain? Acid. So whenever acid is lost from the body will develop metabolic alkalosis. So in vomiting, there is loss of upper GI secretions rich in acid. So that results in metabolic alkalosis. So this is a basic rule. So this will never be overruled. In diarrhea, one should suspect metabolic acidosis. In vomiting, one should suspect metabolic alkalosis. Next concept that they ask you is, what will happen in hyperaldosteronism? What tends to happen in hypoaldosteronism? So hyperaldosteronism and hypoaldosteronism. What happens in hyperaldosteronism and hypoaldosteronism? So where is aldosterone important? It is important in collecting that for sodium and water reabsorption. So for whatever sodium is reabsorbed, there will be loss of K plus and H plus. So to keep it in a simple way, if at all there are 3 sodium reabsorbed, there will be 2 K plus and 1 H plus lost into the urine. So aldosterone will facilitate sodium reabsorption, loss of K plus and H plus. Now if there is hyperaldosteronism, now what is going to happen? So in hyperaldosteronism, due to increased sodium reabsorption. Now sodium will be reabsorbed excess because this enzyme is hitting the collecting duct. It will make it to reabsorb sodium more. So due to increased sodium reabsorption, there will be loss of H plus and K plus from body. There will be loss of H plus and K plus from body. So whenever H plus is lost, this phenomena is called as metabolic alkalosis. And when K plus is decreasing in the body, it is called as hypokalemia. Now what happens in hypoaldosteronism? Now aldosterone is not at all functioning properly. So sodium reabsorption will not happen because sodium is not coming in. From the body, what is not going out? H plus and K plus. In hypoaldosteronism, due to decreased sodium reabsorption, so what is going to happen? H plus and K plus retained in body. H plus and K plus retained in body. So because H plus is staying in the body, it results in metabolic acidosis. K plus has also increased in the body. It causes hyperkalemia. Now what is this concept? So why, if there is loss of H plus, so why loss of H plus is called as metabolic alkalosis? So why retention of H plus is called as metabolic acidosis? So again, this follows the Henderson-Hasselbalch equation. So this follows the Henderson-Hasselbalch equation. So in my body, H plus and bicarbonate will try to stay in equilibrium. And there will be some few free H plus and bicarbonate maintaining the pH. Now, if because of some disease, if H plus is decreasing in my body, See, H plus is decreasing in my body. What will eventually increase? Free bicarbonate. So anywhere increase in bicarbonate according to Henderson-Hasselbalch equation, what is it called as? Metabolic alkalosis. In the same way, if at all H plus is increasing in the body, all the free bicarbonate will come and bind to H plus. So once the free bicarbonate is decreasing, what is this phenomena called as? Metabolic acidosis. It is called as metabolic acidosis. So whenever they mention hyperaldosteronism, so what is the effect of hyperaldosteronism on the ABG? Your answer should be metabolic alkalosis, hypokalemia. What is the effect of hypoaldosteronism on the ABG? Your answer should be metabolic acidosis and hyperkalemia. So these are something basic. So hyperaldosteronism will cause metabolic alkalosis, hypokalemia. Hypoaldosteronism will cause metabolic acidosis, hyperkalemia. Diarrhea, metabolic acidosis. Vomiting, metabolic alkalosis. So these four conditions are frequently asked. They'll give you a clinical scenario: diarrhea, vomiting, hyperaldosteronism. So you should know these concepts. Now let us see what are the causes of, with this basic, what are the causes of normal anion gap metabolic acidosis. What are the causes of normal anion gap metabolic acidosis? So this can be divided into two groups. So we have GIT causes and other is renal causes. So I hope nephrology is done in detail. Renal causes, renal tubular acidosis, all those you know. Yes. So GIT causes. First is diarrhea. Second is enterocutaneous fistula. Third is pancreatic fistula. So fourth is ureterosigmoidostomy. Now let us see what are the reasons. So I think all of you know why in diarrhea there is metabolic acidosis. So loss of bicarbonate, in a reflex fashion chloride is reabsorbed. Now enterocutaneous fistula. Entero means intestine, cutaneous means skin, fistula means open. So in few surgeries they make fistula or opening of intestine to outside. So whenever intestine is connected to the skin, so through that opening bicarbonate rich secretions are lost. Then pancreatic fistula. So pancreas is the source of bicarbonate to your GIT. So if at all there is a fistula from the pancreatic opening outside, through that opening bicarbonate rich secretions from the pancreas are lost. Next is a complex surgery called as ureterosigmoidostomy. So when it is done, so whenever there is a bladder carcinoma, now ureters cannot go into the bladder. So what they are going to do, they will divert the ureters into sigmoid colon. This diversion of ureters into sigmoid colon, it is called as ureterosigmoidostomy. So you can see the example. So this is the sigmoid colon and this is the ureter. So ureters are diverted into sigmoid colon, and normally now urine is coming into the colon. So what does urine contain in excess? Chloride. So whenever excess chloride comes into the intestine, always your intestine likes chloride. So your intestine starts reabsorbing chloride. Your intestine starts reabsorbing chloride. So for whatever chloride is reabsorbed, a negative is taken in, a negative will be thrown out. So bicarbonate will be thrown into the colon and this bicarbonate will be lost in patient's excreta. Bicarbonate will be lost in patient's excreta. So simple logic is whenever ureters are connected to sigmoid colon, lot of urine reaches the sigmoid colon. Urine is rich in chloride. Whenever your intestine sees chloride, it will try to take up chloride. So for whatever chloride is being taken in, a negative is taken in. So your body releases a negative into the intestine. What is that negative intestine? What is the reason? What is the negative coming out? Bicarbonate. So because chloride is taken in, there is maintenance of anion gap. Bicarbonate is going out. There is metabolic acidosis. So bicarbonate is lost, metabolic acidosis. Chloride has gone into the body, the anion gap will stay normal. So this is the mechanism of normal anion gap metabolic acidosis in ureterosigmoidostomy. Now coming to the renal causes. So first is renal tubular acidosis. So renal tubular acidosis, I think this must have been done in your nephrology. So we have, just I'll tell you names, type 1 and type 2 RTA. So these two are associated with metabolic acidosis plus hypokalemia. Next we have type 4 RTA, which is most common. This is associated with metabolic acidosis plus hyperkalemia. Metabolic acidosis with hyperkalemia. Next important cause is drugs. So what are the drugs responsible for metabolic acidosis here? So we have ACE inhibitors. ACE inhibitors, aldosterone antagonist. So somebody has asked me, can you repeat enterocutaneous fistula and pancreatic fistula? So just listen with some common sense. Entero means intestine. Cutaneous means skin, fistula means outside. So from your intestine there is an opening outside. So what will happen? Intestinal contents rich in bicarbonate will be going out. So whenever the bicarbonate rich secretions from the intestine are going out, there will be metabolic acidosis. Pancreatic fistula. Pancreas is the structure giving bicarbonate to your intestines. Now from the pancreas there is an opening outside. So in the pancreatic fistula, from the pancreas all the bicarbonate will be lost. Okay. How? Because bicarbonate is being lost, chloride will be taken up by the kidney. Chloride reabsorption happens. For bicarbonate loss, chloride reabsorption will happen. Okay. So this is the mechanism. So just like in diarrhea, what is happening? Loss of bicarbonate, chloride reabsorption. So these three have similar mechanisms just like diarrhea. So aldosterone antagonist, and third is carbonic anhydrase. Carbonic anhydrase inhibitors. So why will ACE inhibitors and aldosterone antagonists result in metabolic acidosis? So first point. So whenever I give ACE inhibitors, so renin angiotensin aldosterone mechanism, what will happen? the aldosterone will not be produced. So there will be decreased production of aldosterone. So when I give aldosterone antagonist, aldosterone will not function properly. So these two conditions are similar to hypoaldosteronism So when I give ACE inhibitors, aldosterone is not formed in the body. When I give aldosterone antagonist, aldosterone will not work in the body. So these will be similar to hypoaldosteronism. So what is the end result in hypoaldosteronism? It is metabolic acidosis. So there will be metabolic acidosis. Now carbonic anhydrase. So where is this carbonic anhydrase very useful? It is useful in the proximal convoluted tubule for reabsorption of bicarbonate. Now whenever I inhibit the enzyme, there will be decreased reabsorption of bicarbonate. So there will be decreased reabsorption of bicarbonate. So bicarbonate will be lost in urine. Whenever bicarbonate is lost in the urine, patient will develop metabolic acidosis. Normally bicarbonate should be taken in proximal convoluted tubule with help of carbonic anhydrase inhibitor. So there will be decreased reabsorption of bicarbonate from proximal convoluted tubule. So that results in loss of bicarbonate in urine. Because bicarbonate is lost in urine, there will be metabolic acidosis. So these are the important causes: GIT causes, renal causes. So I think renal causes will be well covered in your nephrology. So what is the mechanism of type 1 RTA, type 2 RTA? Spironolactones are nothing but aldosterone antagonists. So when I say a group, don't write all the drug AC inhibitors. What happens in captopril? What happens in enalapril? Okay, not like that. So aldosterone antagonists, AC inhibitors. So renal tubular acidosis, type 1 and type 2 RTA, metabolic acidosis, hypokalemia. Type 4 RTA, metabolic acidosis plus hyperkalemia. So this completes metabolic acidosis. Next concept is metabolic alkalosis. So to understand metabolic alkalosis, you should know what is the concept of initiating event and persisting event. Initiating event and persisting event. So let us try to understand this with a previous AIMS question. So type 2 RTA is not that clinically relevant, very rare. Type 2 RTA, I don't know if it is covered in nephrology. Why are you asking here again? Okay. So let us see this first. A 25-year-old male, history of vomiting, brought to the emergency department. On examination, patient's BP was low, and by the time he reached the emergency department, now there is no vomiting. ABG is showing severe metabolic alkalosis. How to treat metabolic alkalosis here? So this is an important question. Now first of all, tell me, what is the initiating event for metabolic alkalosis here? So there is vomiting. So because of vomiting, the metabolic alkalosis has started in this patient. Because of vomiting, the metabolic alkalosis have started here. So vomiting results in loss of upper GI secretions rich in acid. Now when the patient was brought to the emergency department, now vomiting has completely stopped. There is no active vomiting. But still his ABG is showing severe metabolic alkalosis. Now what is the persisting event that is causing metabolic alkalosis in this patient? So initiating event is vomiting. But by the time he reached the emergency department, his vomiting has stopped. But still he is having severe metabolic alkalosis. So what might be the persisting event? So try to understand here. Whenever a patient vomits, not just acid is lost. Severe vomiting, not just acid is lost, even some fluid is lost from the body. So whenever your body needs to choose between acid base status and fluid status, what will it always prefer? Fluid status. Because without adequate fluid, my organs cannot function properly. So to conserve fluid, what is the system getting activated in your body? Renin, angiotensin, aldosterone system. So what is the function of this system? It will result in sodium and water reabsorption. So for whatever sodium is getting reabsorbed, what will be lost in the urine? K plus and H plus. So if K plus is lost, patient may develop hypokalemia. H plus is also lost. Patient will develop metabolic alkalosis. Now see this peculiar phenomena. Patient started with metabolic alkalosis and his body's defense mechanism is also causing persistence of metabolic alkalosis. So this question is a classical example of extracellular fluid volume contraction. Because of vomiting, there is volume contraction that resulted in hypotension, that resulted in secondary hyperaldosteronism. So because of that secondary hyperaldosteronism, still there is metabolic alkalosis. Now how to treat metabolic alkalosis here? Now what is the reason for persistence of metabolic alkalosis here? Secondary hyperaldosteronism. So what has caused secondary hyperaldosteronism? Hypotension. Now how to effectively treat metabolic alkalosis? So give fluid and improve his BP. So what is the commonly given fluid to improve blood pressure? It is nothing but saline. So if you give saline to this patient, his blood pressure will improve. Once his blood pressure is improving, this renin angiotensin mechanism will be, this secondary hyperaldosterone system will be stopped. So once this secondary hyperaldosteronism decrease, ABG will come back to normal. So this is a classical example. Where you are giving saline to the patient. Because of saline, his metabolic alkalosis is responding. So this phenomena is called as saline responsive metabolic alkalosis. So rule number 1. If there is metabolic alkalosis persisting predominantly due to volume contraction, what you should give in this patient? Volume. What is that? Saline. If you give saline in this patient, he will improve. So the problem here is patient's BP is low. So best way to improve the BP is normal saline. So try to understand here in this given question, the persisting event for metabolic alkalosis, the persisting event is volume contraction, secondary hyperaldosteronism. So if I give volume to the patient, his BP will improve. So this activated renin angiotensin mechanism will come down. So his ABG will come back to normal. Second important thing, now consider another patient. So there is another patient, since his childhood he is having primary hyperaldosteronism. Always his adrenals is producing excess aldosterone. So whenever there is excess production of aldosterone, always there will be increased sodium and water reabsorption. So whenever sodium and water is getting reabsorbed, now what will happen in this patient? His body's volume will increase. So there will be extracellular fluid volume expansion. So this is also aldosterone excess. So there will be metabolic alkalosis. Because always sodium and water was taken inside, this patient will have hypertension. Now this is a case of metabolic alkalosis with hypertension. Now can you give saline in this patient? Yes or no? Can you give saline in this patient? So already there is hypertension. You cannot give saline in this patient. If you give saline in this patient, already fluid load, he will die of cardiac load. So this is also a metabolic alkalosis, but you cannot give saline. So this phenomena is called as saline unresponsive metabolic alkalosis. So rule number two, if there is a metabolic alkalosis with coexisting hypertension, already there is volume excess, no point in giving saline. So here the metabolic alkalosis will not improve with saline. So it is called as saline unresponsive metabolic alkalosis. Why we made such a classification, saline responsive and unresponsive? Because in emergency department, easily to differentiate the cases and whether to treat, whether to give IV saline, yes or no. So write down rule number 1. So before that, mechanisms. So mechanisms. First is extracellular fluid volume contraction, that resulting in hypotension. So whenever there is hypotension, your renin-angiotensin system will become aggressive. So there will be secondary hyperaldosteronism. Second mechanism, because of some primary mineralocorticoid excess. Because of some primary mineralocorticoid excess, there is extracellular fluid volume expansion. Extracellular fluid volume expansion. Along with this, there is hypertension. Now out of these two, which will be saline responsive? First mechanism. So volume contraction, hypotension, secondary hyperaldosteronism. If this mechanism is responsible for metabolic alkalosis, if you give saline, patient will improve. So write down rule number 1. Metabolic alkalosis persisting due to volume contraction. If at all there is a metabolic alkalosis persisting due to volume contraction. So what should be given here? Saline. So this will be saline responsive, because volume contraction itself will cause metabolic alkalosis. So how will volume contraction cause metabolic alkalosis? This is the mechanism. Hypotension, secondary hyperaldosteronism. So what are the examples of these diseases? Vomiting, Ryle's tube aspiration, diuretic use. Now how will these three cause volume contraction? So vomiting, loss of upper GI secretions, so there will be volume loss. Ryle's tube aspiration, where do you put Ryle's tube? You put it into the GIT, upper GIT. When you aspirate, upper GI secretions are gone. So whenever upper GI secretions are lost, so there will be metabolic alkalosis, and also volume contraction. So Ryle's tube aspiration is similar to vomiting. Vomiting, patient does by himself. Ryle's tube aspiration, you are putting a tube and aspirating upper GI secretions. And diuretics, so whenever you give excess diuretics, there will be volume loss. So because diuresis means loss of excess urine. So because of volume contraction, secondary hyperaldosteronism, there will be metabolic alkalosis. Rule number 2. Metabolic alkalosis with coexisting hypertension. So will you give saline, yes or no? Never. Because already patient is having hypertension, there is no point in giving saline. So what are the causes? We have primary hyperaldosteronism. Primary hyperaldosteronism. Cushing's syndrome. Cushing's syndrome. Renin secreting tumor. Renin secreting tumor. So why will these three conditions cause metabolic alkalosis and hypertension? So primary hyperaldosteronism is nothing but primary mineralocorticoid excess. Primary mineralocorticoid excess. Cushing syndrome is nothing but Cushing syndrome. Even though it is glucocorticoid excess, why there is metabolic alkalosis and hypertension? Because glucocorticoids will have some amount of mineralocorticoid activity. So glucocorticoids will have mineralocorticoid activity. Glucocorticoid will have mineralocorticoid activity. Then renin secreting tumor. So whenever renin is secreted in excess, what will ultimately increase in the body? Aldosterone. So whenever aldosterone is increasing, there can be extracellular fluid volume expansion and hypertension. Now coming to third important rule, metabolic alkalosis due to some genetic defects of renal tubules. So genetic defects of renal tubules such as Bartter syndrome, Gitelman syndrome, Liddle syndrome. So these three disorders will also cause metabolic alkalosis and they will be saline unresponsive. Because these are primary genetic defects. Even if you give saline, there will be no change. This is a genetic defect. Even if you give saline, there will be no change. So this is the important classification: saline responsive and saline unresponsive. Apart from this, there is another parameter which differentiates saline responsive and saline unresponsive. It is urinary chloride levels. So urinary chloride levels in saline responsive was found to be less than 20 milliequivalents, whereas in saline unresponsive cases, urinary chloride levels was found to be more than 20 milliequivalents. More than 20 milliequivalents. Now what is the significance of this? Try to think with simple common knowledge. So don't go for complicated mechanisms. Think as a common man now, you will understand this better. Now, whenever there is saline responsive metabolic alkalosis, majority of the patients will be having volume contraction. So whenever your body is not having adequate volume, what will your kidney do? It will try to retain water. So how is water generally retained? Salt and water retention happen. Now tell me, when there is less water in your body, will your kidney try to retain salt or excrete salt? Try to retain salt or excrete salt. So it will try to retain salt. So what does salt contain? Na plus Cl minus. Because chloride is getting reabsorbed in the body. Within the urine, chloride will be less. So urinary chloride in saline responsive cases will be less, because majority of saline responsive cases will be having volume contraction. Whenever there is volume contraction, it is responsibility of the kidneys to retain salt. So kidneys are retaining salt. Salt contains Na plus Cl minus, because chloride is kept in the body. Within the urine, chloride will be less. Now, why in saline unresponsive cases chloride levels in the urine are high? Once again, think as a common man. See, now majority of saline unresponsive cases are having coexisting hypertension. So whenever there is hypertension, whenever there is fluid expansion, is there need to retain salt in the body? Is there need to retain salt in the body? No. So because there is already hypertension, there is no point in retaining salt. So chloride can be lost in the urine. So urinary chloride will be more than 20 milli equivalents. So according to the fluid status, it is divided. If body is having volume contraction, it is responsibility of the kidney to retain salt. So salt will be kept in the body. So urinary chloride will be less. If already body is having fluid overload, no point in retaining salt. So salt can be lost within the chloride, within the urine, chloride will be high. So urinary chloride will be more than 20 milli equivalents. So now respiratory acidosis. So already I have discussed in detail regarding respiratory acidosis. So where did I discuss in detail regarding respiratory acidosis? So respiratory acidosis, hypercapnia, also called as type 2 respiratory failure. So if you want to learn respiratory acidosis, just take and see type 2 respiratory failure. So that is nothing but respiratory acidosis. Then respiratory alkalosis. So write down the important concepts regarding respiratory alkalosis. So chronic respiratory alkalosis is considered as most common acid base abnormality, is considered as most common acid base abnormality in critically ill patient. So why it is considered as most common acid base abnormality in critically ill patient? Once you see the mechanisms, you will know better. So write down the causes of respiratory alkalosis. First group of causes: pain, panic, psychogenic, progesterone. So in pain, people tend to hyperventilate. Panic, there will be some hyperventilation. Especially young females, they will be having psychogenic hyperventilation. And progesterone directly stimulates the respiratory center. So whenever something stimulates the respiratory center, there will be hyperventilation and CO2 washout. Hyperventilation and CO2 washout. And second important thing is sepsis toxins. Toxins released in sepsis and also cirrhosis. So sepsis and cirrhosis. So because of this, so toxins in sepsis and cirrhosis can also stimulate respiration and also stimulate respiration. And third important thing is diseases causing hypoxemia. So hypoxemia. So any disease that causes hypoxemia, it will stimulate respiratory receptors. So whenever respiratory receptors are stimulated, there will be hyperventilation. So when there is hyperventilation, there is CO2 washout. The next important thing, mechanical hyperventilation. So normally you connect to a mechanical ventilator, and if you set normal rate 12 to 15 per minute, there will be no issue. If suppose you set more respiratory rate 16, 17 or 18, when compared to the patient's body, so there will be some hyperventilation. So whenever you connect to a mechanical ventilator, you are going to set some respiratory rate. So if you keep it in physiological value, so 12 to 15, there will be no hyperventilation. So sometimes if you for ventilating fast, few people will set it at 20 per minute. So whenever you increase the respiratory rate in the mechanical ventilator, so there can be some hyperventilation resulting in CO2 washout. Now, why is chronic respiratory alkalosis most common acid-base disorder in critically ill patient? Because critically ill patient might be in pain, he might be in panic, he might be in sepsis, he might be having hypoxemia, he might be connected to a mechanical ventilator. Because all these phenomena frequently happen in critically ill patients, so chronic respiratory alkalosis is considered as most common acid-base abnormality in them. And finally, drugs. So drug called as aspirin. So where did you come across aspirin? So we have come across aspirin in high anion gap metabolic acidosis. So aspirin can directly stimulate the respiratory center. So aspirin has a tendency also to stimulate the respiratory center. So whenever respiratory center is stimulated, there is hyperventilation and respiratory alkalosis. So hyperventilation and respiratory alkalosis. So mechanical hyperventilation means whenever you ventilate with more respiratory rate, whenever you ventilate with more respiratory rate. And there is another entity here in very high doses of aspirin. In very high doses of aspirin, there can be respiratory depression. And this respiratory depression can result in respiratory acidosis. But respiratory acidosis is not common. So if they ask you, aspirin frequently causes what? Frequently causes respiratory alkalosis. So very rarely causes respiratory acidosis. So in very high doses of aspirin, so that toxic doses, it can cause respiratory depression, ultimately leading to respiratory acidosis. These are the important causes of respiratory alkalosis. So now we have discussed metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. So we have completed individual acid-base disorder. So coming to the next important topic, mixed acid-base disorder. So write down mixed acid-base disorder. Clinical history is very, very important. So for mixed acid-base disorder, clinical history is very, very important. Mixed acid-base disorder, clinical history is very, very important. See, aspirin can cause metabolic acidosis. It can cause respiratory alkalosis. In very high doses, it can also cause respiratory acidosis. Now, mixed acid-base disorder, clinical history is very, very important. Let us try to understand with the simple examples. So, just in a simple manner, if you take a primary respiratory acidosis, for example, there was a patient with COPD. His CO2 has increased from normal value of 40 to 60. So to call it as a compensatory phenomena, his bicarbonate should increase by how much? So it is a chronic disorder. CO2 has increased from 40 to 60. So bicarbonate should increase from 26 to 34. So for 10 it is 4, for 20 it will be 8. So 26 plus 8, 34. So this is called adequate compensatory response. Now there is another patient, COPD, and he was also having some vomiting. So there is another patient, COPD, his CO2 has increased from 40 to 60. Now as a compensatory response, bicarbonate should increase to 34. It has to increase to 34. But if it has increased to 38, what does it mean? Body's compensatory response can only bring it to 34. If it has increased beyond that, that means there is some additional disorder resulting in increase in bicarbonate. So this phenomena is called as additional metabolic alkalosis. See whether this fellow has developed some vomiting. Another example, a patient with COPD, his CO2 has increased from 40 to 60. As a compensatory mechanism, bicarbonate should increase up to 34. But now bicarbonate has decreased to 30. See, whenever there is a chronic respiratory acidosis, CO2 should reach to 34. But if it starts decreasing, what does it mean? There is some other disorder trying to decrease bicarbonate. Anything that decreases bicarbonate should be considered as additional metabolic acidosis. See whether this patient has developed some diarrhea. So in simple words, if CO2 increases to this level, bicarbonate should also increase to this level, adequate compensation. If it is increasing beyond that, it means any abnormal increase is additional metabolic alkalosis. So if bicarbonate is decreasing, any abnormal decrease is additional metabolic acidosis, nothing but a mixed acid base disorder. So let us solve this with some clinical examples. So patient with COPD, pH 7.32, CO2 60, bicarbonate 34. So draw arrow marks, pH is reduced, CO2 is increased, bicarbonate is increased. So step by step. So by seeing the pH, can you tell me, is it acidosis or alkalosis? This is acidosis. This is acidosis. Now what is the primary disorder? What is the primary disorder? Change in pH with respect to parameters opposite. So it is a primary respiratory acidosis. Is it acute or chronic? It is chronic because it is COPD, chronic obstructive pulmonary disease. Now we should calculate compensation. Calculate compensation. Now CO2 has increased from 40 to 60. It has increased by 20. So to call it as adequate compensatory response, bicarbonate should increase by how much? 26 plus 8, it should increase to 34. So in the question, how much is given bicarbonate? How much is given bicarbonate? 34. How much is expected bicarbonate? 34. So both are correlating. Given and expected are correlating. So it is respiratory acidosis with compensatory metabolic alkalosis. So it is a simple acid-base disorder. Now there is another patient, COPD and vomiting. These are the ABG parameters. So what do you notice here? pH decreased, CO2 increased, bicarbonate increased. No doubt this is also respiratory acidosis. So whenever CO2 increases to 60, bicarbonate should increase to 34. But here it has increased to 38. So in this question, given bicarbonate is very much more than expected bicarbonate. So given bicarbonate is very much more than expected bicarbonate. So whenever the given bicarbonate is higher than expected, it means there is some other disorder causing addition of bicarbonate. So what is the disorder? This patient is having vomiting. This might be responsible. So this is additional metabolic alkalosis. Patient with COPD and diarrhea. Try to solve this question. pH reduced, CO2 increased, bicarbonate increased. So any decrease in pH anywhere is acidosis, and this is also a respiratory acidosis. Now whenever CO2 increases to 60, as a compensatory phenomena, bicarbonate should increase to 34. but bicarbonate is not 34, it has decreased to 30. So here given bicarbonate is very much less than expected bicarbonate. So when given bicarbonate is less, it means there is some other disorder trying to decrease the bicarbonate. See the history. Is there any disorder that can decrease the bicarbonate? Yes, there is diarrhea. So the answer will be respiratory acidosis with additional metabolic acidosis. Respiratory acidosis with additional metabolic acidosis. So that's why history is very, very important. So this is how we should approach mixed acid base disorder whenever you identify a primary respiratory disorder. Next, mixed acid base disorder with respect to a primary metabolic disorder. Again the same concept. Consider there is a patient with DKA. So there was a patient with diabetic ketoacidosis. So because of accumulation of keto acids, his bicarbonate has decreased from normal value to 10. His bicarbonate has decreased from normal value to 10. As a compensatory phenomena, whenever bicarbonate decreases to 10, CO2 from normal value will come down to 21 to 25 mmHg. How did I calculate this? With help of Winter's formula. So expected CO2 is equal to 1.5 into bicarbonate plus 8 plus or minus 2. So if bicarbonate comes down to 10, CO2 should come down to 21 to 25 mmHg. Now instead of that, if CO2 is 15 mmHg, so body's compensatory response can only bring it down to 21. If it is decreasing beyond that, it means there is some other additional phenomena causing CO2 decline. See whether this patient, because of panic, he is hyperventilating and causing CO2 washout. Another patient with DKA, his bicarbonate has come down to 10. As a compensatory phenomena, what should happen? The CO2 should come down to 21 to 25. But now his CO2 is 30. So whenever bicarbonate comes down to 10, CO2 should come down to 25. But now it has increased to 30. It means there is some other disorder responsible for increasing in CO2. So this is an additional respiratory acidosis. See whether this patient, because of diabetic ketoacidosis, he went into a complication called as diabetic ketoacidotic coma that can result in respiratory depression and respiratory acidosis. So if you do these questions, you will understand this better. Simple lines. So there was a patient with DKA. So these are the parameters. pH reduced, CO2 reduced, bicarbonate reduced. Okay. So no doubt it is metabolic acidosis. So whenever you identify metabolic acidosis, whenever you identify primary metabolic acidosis, you should calculate compensation. So how do you calculate compensation? Expected CO2 is equal to 1.5 into bicarbonate plus 8 plus or minus 2. So 1.5 into 10 plus 8 plus or minus 2. It will be in the range of 21 to 25 mmHg. So given CO2 is 22, expected is correlating. So here given CO2 is correlating with expected CO2. So this is metabolic acidosis with compensatory respiratory alkalosis. Okay. Now next patient with DKA, and he is anxious. So this fellow is very, very anxious. So here pH decreased, CO2 decreased, bicarbonate decreased. So this is also a metabolic acidosis. This is a metabolic acidosis. Okay. Now let us see the compensation. Now whenever bicarbonate decreases to 10. As a compensatory response, CO2 should come down to how much? CO2 should come down to how much? It should come down to 21 to 25 mmHg. But here it has decreased more. So in this question, given CO2 is very much less than expected CO2. So whenever given CO2 is less, it means there is an additional disorder causing CO2 decline. So body's compensatory phenomena can only decrease it to 21. If it is decreased beyond that, there is something additional causing the further decline. So this patient is very, very anxious. So he might be hyperventilating. So this is metabolic acidosis with additional respiratory alkalosis. Another patient, DKA and altered sensorium. So his sensorium is not at all good. pH reduced, CO2 reduced, bicarbonate also reduced. So no doubt it is metabolic acidosis. So whenever in a metabolic acidosis, bicarbonate decreases to 10. As a compensatory mechanism, CO2 should come down to 21 to 25. But here CO2 is gradually increasing. So here given CO2 is more than expected CO2. So whenever given CO2 is higher, it means there is some other disorder trying to increase CO2. Any additional increase in CO2, it is called as additional respiratory acidosis. So what might be the reason for additional respiratory acidosis? And this is very, very important, especially in a patient of DKA. So this patient is with DKA and he is having altered sensorium. It means he is going into a complication called as diabetic ketoacidotic coma. So because of the diabetic ketoacidotic coma, gradually respiratory depression happens and CO2 will be elevated. So whenever you find a patient with such a scenario, because respiratory depression is happening, this patient may need mechanical ventilation. So why there is additional respiratory acidosis here? Because of altered sensorium. So in simple words, if bicarbonate decreases to this level, CO2 should also come to this level. If it decreases beyond that, any additional decrease is called as additional respiratory alkalosis. See whether that fellow is hyperventilating. If CO2, if bicarbonate decreases to this level, CO2 should also come to this level. If it is increasing beyond that, it is additional respiratory acidosis. So see whether this patient is having some respiratory depression. So this is the important concept regarding mixed acid-base disorders. So before we conclude, let us see ABG sampling. So ABG sampling. So which blood is generally used for ABG sampling? Is it arterial blood or venous blood? Generally we go for arterial blood, because in arterial blood only you will get the exact CO2 and oxygen values. And what is the most common artery used? It is radial artery. So most commonly radial artery used. So whenever you are puncturing radial artery, you should make sure your ulnar artery is patent. What is the reason? So if you puncture the radial artery, for some time circulation will not happen here. If your ulnar artery is not patent, these fingers will develop ischemia. These fingers will develop ischemia. So to test the patency of ulnar artery, we do a classical test called as modified Allen's test. So modified Allen's test. So you can do it on yourself. So what I am going to do is, I am going to tightly hold the wrist of the patient and I will close the hand. Now whenever I hold the wrist tightly like this, I am actually blocking both radial and ulnar artery. Now if I open my hand, it will be completely pale because the blood supply is not there. Now what I am going to do, I am going to release the pressure from ulnar artery. On release of pressure from ulnar artery, if my hand turns pink, it means my ulnar artery is patent. If ulnar artery is patent, it means Allen's test is positive. If Allen's test is positive, you can poke the radial artery. Once again, see, I am going to tightly hold my wrist. Okay, close my hand. After some time, when I open this hand will be completely pale. So why it is completely pale? The blood supply is cut off. Now I am going to release the pressure on ulnar artery. So once the pressure from the ulnar artery is released, now if your hand turns pink, it means ulnar artery patent. Ulnar artery patent means Allen's test positive. Allen's test positive means you can poke radial artery. So write down the concept here. On release of pressure from ulnar artery, if hand turns pink, it means ulnar artery patent. Ulnar artery patent. So ulnar artery patent. If ulnar artery is patent, it means Allen's test positive. Allen's test positive means you can poke radial artery. Everything starts with the letter P. On release of pressure from ulnar artery, if hand turns pink, it means ulnar artery patent. Ulnar artery patent means Allen's test positive. Allen's test positive means you can poke radial artery. So if Allen's test is negative, you should go for next hand or you should go for femoral route. Now before taking the blood into this syringe, you should add something into this syringe. What is that? Heparin. Because clotted blood cannot be processed by the ABG machine. So how much heparin is used? 0.1 to 0.2 ml heparin is used. See, now we use only modified Allen's test. So the previous Allen's test is no longer used. No need to know about it. 0.1 to 0.2 ml heparin used for ABG sampling. So this is also one more important concept. 0.1 to 0.2 ml heparin is used for ABG sampling. So ABG sampling, most commonly radial artery is used. We do Allen's test for patency of ulnar artery. If it is positive, we can poke. So 0.1 to 0.2 ml heparin is used for ABG sampling. So just wait for another 5 minutes. I'll give you a complete break tonight. Okay. So this is the modified Allen's test we can do. See here, I release the pressure. When I release the pressure, hand will turn completely pink. Okay. So blood 1 to 2 ml is sufficient. 1 to 2 ml is sufficient. Now before we conclude, let us see some cases so that you can understand ABG better. So follow the algorithm, you'll get the answer. So on a 20-year-old female with chronic hyperventilation with ABG presence. So whenever they give you any ABG, so first is history based approach. So first you should see the clinical scenario and try to find out the diagnosis. Next is ABG wise approach. ABC wise approach, history wise approach, ABC wise approach. So history, this female is anxious and she was having hyperventilation, chronic hyperventilation. So by history, I suspect this patient to have chronic respiratory alkalosis. So this patient might be having chronic respiratory alkalosis. Now ABG wise, you can see pH is increased, CO2 is decreased, bicarbonate is decreased. So step by step, first see the pH, whether it is acidosis or alkalosis. What is the primary process? Change in pH with respect to parameter opposite. So the primary is respiratory. So the answer is respiratory alkalosis. So this is the simplest ABG question that they give you. Now, another question based with complete history. A 60-year-old man with amyotrophic lateral sclerosis. So this is a chronic neuromuscular disorder. He is brought with some symptoms. On history, they have given that he is having headaches, everything. ABG is performed. So they are asking you what is the disorder. Again, history-wise approach. So patient is having a chronic neuromuscular disorder. So there are chances of chronic respiratory acidosis. So chronic respiratory acidosis. Now ABG wise. So if you notice here, I'll write it here, pH 7.34, PaCO2 60, bicarbonate 34. So pH reduced, CO2 increased, bicarbonate increased. So step by step, by seeing the pH, is it acidosis or alkalosis? Acidosis. So what is the primary process? Respiratory or metabolic? Respiratory. Is it acute or chronic? Chronic. After knowing the primary process, what you should do? You should calculate compensation. Now CO2 has increased from 40 to 60. It has increased by 20. So to call it as a compensatory response, bicarbonate should increase by 8. So in the question, expected bicarbonate and given bicarbonate are correlating. So given is 34. Expected is 34. Given and expected are correlating. So chronic respiratory acidosis with compensatory metabolic alkalosis. So in short, I can write it as compensated respiratory acidosis. Compensated respiratory acidosis. So answer is option B. So this was a previous AIMS question. So this is a previous AIMS question. Yes. So what is the answer here? So they're asking you the anion gap. So anion gap is calculated as difference between sodium minus chloride plus bicarbonate. You should use only these parameters. So anion gap. How much is sodium here? 140 minus chloride 112 plus bicarbonate 16. So anion gap 140 minus 128. It is 12. So the answer is 12. So it is normal anion gap. Now last question. 84-year-old female, diarrhea, was found to have a blood pressure of 100/60, heart rate. They have given the electrolytes. They have given ABG parameters. What is the acid-base disorder? So let us see history-wise approach. So by seeing the history, what I can suspect? So patient is having importantly diarrhea. What can diarrhea cause? Normal anion gap metabolic acidosis. Now ABG wise approach. ABG wise. So I'll write the parameters. We will follow the algorithm. You'll get the correct answer. 7.29 PaCO2 24 bicarbonate. So draw arrow marks. pH reduced, CO2 reduced, bicarbonate reduced. First see the pH. After clinical data, first see the pH. So is it acidosis or alkalosis? Acidosis. Then what is the primary? Change in pH with respect to parameter, same. So the name should be metabolic. After identifying the primary process, you should calculate the compensatory response. So if it is metabolic, so you should calculate respiratory compensation. 1.5 into bicarb 10 plus 8 plus or minus 2. It will be in the range of 21 to 25. So here given CO2 is correlating with expected CO2. So metabolic acidosis with compensatory respiratory alkalosis. Then what is the last step? Calculation of anion gap. How much is anion gap? Sodium 137 minus chloride 117 plus bicarbonate 10. So 137 minus 127, it will be 10. So anion gap will be 10. So it is normal anion gap metabolic acidosis with compensatory respiratory alkalosis. I have followed all the steps in algorithm. So it is option C. Non-anion gap means not high anion gap. It means normal anion gap. Non-anion gap means not high anion gap. It means normal anion gap. So all steps have been followed. So I have seen the clinical scenario by seeing the pH, acidosis or alkalosis, direction of change, metabolic and compensatory, and compensatory is there. And next important thing here that I need to know is it is normal anion gap metabolic acidosis. So by this we could conclude respiratory medicine and ABG. So as I promised you, when I get the new update of tuberculosis, I will be doing a complete video. And lung cancer staging, because you are telling it is not covered even in surgery, I'll do it as soon as possible. So before I end, this is something I want to tell you, especially to male medicos sitting there. So why is it important to get a postgraduate degree? The reason is MBBS degree will give you pride. MBBS degree will make you feel like Rajinikanth. But it is PG degree only that will get you good bride. So you choose pride and bride, which is better. So this should be the best motivation for all of you. So I think most of us nowadays, especially in our country, only if you get postgraduate degree, they are giving the bride. So if you are lucky, you will also get good brides. So take care everybody. So thank you. It has been a wonderful experience. So any doubts, you can contact me on this email. So this is my YouTube channel and this is my Facebook channel. Okay. So I'll also organize an ABG quiz in the Facebook. Okay. In DAMS Exclusive Club shortly, there are some 10 ABG questions. I am going to organize a Facebook quiz so that all the concepts will be ABG will be revised. Yeah, done. So extremely sorry for the delay because few concepts I had to take time so that you can understand well. So COVID module is completely present in the AIMS capsule. Then in DVT also I am doing COVID for 30 minutes. There will be a rapid revision. And in Facebook you can ask me whatever doubts you need. సో చాలా మంది తెలుగు వాళ్ళు కూడా ఉన్నారు. చాలా సంతోషం. థ్యాంక్ యూ సో మచ్.